So capnograph is nowadays mandatory whenever you are either in OT or in the ICU. It should be, capnography should be there. Should be part of your gadget. All of you. I talked about the cardiopulmonary resuscitation. It is you to see whether your CPR is effective or not. Okay? ECG in ICU, you put the ECG monitoring, and the continuous ECG monitoring is very, very important. So once you do, all AMI have arrhythmias within first 48 hours, up to 1/3 have VT. Sometimes you see your patient is doing well. What happens? You see VT is going on. You see your pulse, what to do, whether to do if the pulse is there, you will do the, and you cannot give suppose the BP is on lower side, you do the cardioversion. So you have to be there. So ECG monitoring, continuous ECG monitoring, even you are doing the procedure or whatever you're doing, you are putting central line, you are putting arterial line, continuous ECG monitoring is mandatory. Technical issues, proper grounding of equipment, insulation of exposed lead connectors and good site preparation. Important thing is that, and electrodes, conducting gel, appropriate signal damping, we'll talk about all these things. Echocardiography, all of you must have seen. Normally we do the TT. TT gives you a lot of information. When TT doesn't give you the adequate information, you go for the T. Because magnification is 3 to 4 times. Okay. TT indications, hemodynamic instability, important one, ventricular failure, hypovolemia. What information your echocardiography he comes and gives you? First thing, he'll tell you, normally they do the eyeballing. Ejection fraction is this. Then it can vary. Person to person it can vary. Then what he will give you? What is the LV diameter? What is the LA, whether it's dilated or not? RA, whether it's dilated? LV is hypertrophied. What is the RV size? Whether the right ventricular failure is there or not? Or the most important one, they will give you about the fluid around in the pericardium. Tamponade. 2 things can immediately kill the patient. Anyone? Pericardial tamponade, tension pneumothorax. Yes or no? Clear? So, complications after cardiothoracic surgery, patient can have infective endocarditis, aortic dissections. This can kill your patient if it is not diagnosed in time. Aortic dissection. Infective endocarditis will give you time. You have to, I'm not going to talk about those things in detail. Then embolus. A small embolus, peripheral embolus is lying in the peripheries, in the lung. Patient have hypoxia, patient can have alkalosis, mild alkalosis, patient can be tachycardic. But if the big embolus is there, patient can be in obstructive shock. That time, if you are in a primary setup, you can lose your patient. Even tertiary setup, whatever you do, shock never comes back. Patient remains in refractory shock. Even you thrombolize the patients, and there are so many things, or catheter-reactive thrombolysis you do, or the embolectomy you do. It all depends on which center you are working. So, TT in ICU we have talked about. T, I told you, high image quality is there, aortic dissection, intracardiac thrombus, assessment of endocarditis, because vegetations we miss on the TT. We are in dilemma what it is. Then we go for the T for better confirmation. I talked inadequately seen by T, TT not giving adequate information, especially intracardiac, left atrial appendages, thrombus is there, prosthetic valves are there. These things you have to do the T. And sometimes T we do when you might have seen patient in neurosurgical patients in the OT also, continuously they put the T and they do the surgery, few surgeries. They think that the thrombus patient can have embolus, other things. So they put the T catheter inside and they monitor the patient. So inadequate image clarity with T, clear, obesity, because once the patient is obese, you put TT, that is not will give you the adequate window. Or the patient is having emphysema, you don't get the adequate window. Those cases, T's give you better value emphysema. Mechanically ventilated patient with high level PEEP, because there could be associated collapse and other things. Then surgical drains, surgical incision, because suppose surgical drains are there, where you will get the window. Those cases, suppose in the subcostal you do, even if the dressing is there, how you will do? In those cases, TE is being preferred. Okay? And acute perioperative, hemodynamic deregiment's are there. These are things you can do. Ventricular functions I have talked about. Then sepsis-related cardiopathy, cause of hemodynamic instability, hypovolemia, cardiogenic or distributic origin. Those cases you do the TE. How much fluid you have to give adequately. What is this? They will tell you IBC. When the patient is spontaneously ventilating, you see the IBC collapsibility index. I'll show you. When the patient is on ventilator, mechanically ventilated, you see the IBC distensibility index. Okay? So these things we do, and how much fluid you have to give. Repeat bedside examination. You have got TTE with you. Anytime you bring your this one TTE machine, echo machine you do. Anyone, if you are trained enough, not trained enough, you learn, you do your, apply your TTE. Okay, how much fluid, suppose you have given 300, 400 fluid, then again check the size of IBC, whether it is collapsing with the inspiration or not. So these things are being done. Right ventricular function, never ever forget about the right ventricular. Normally, we do the echo we only think about the left ventricle. We miss this. So original RB dysfunction had a sensitivity of 77% and especially 94% for diagnosis of acute PE. Normally you have done your PE and the RARB is not dilated. If it is dilated and the patient is hemodynamically unstable on triple vasopressor support, you cannot take the patient to the CT room for getting the PA done. CT PA done. How you will diagnose the patient? If it is acutely dilated, chances there patient can have acute pulmonary embolism. Okay? Accordingly, you think about, you can thrombolize your patient because either this way patient will go, this way. If the patient, there is no contraindication of thrombolysis, thrombolize it. Fine? So, so these things are there. Diagnosis of acute PE, PPV, pulse pressure variation 70%, NPV, other things, we'll talk. RB dysfunction may alter therapy, fluid loading, vasopressor, thrombolytics, and provide information what? So RB dysfunction, top se, I'll show you. So assessment and filling pressures and volume status is very, very important. Dilated IBC, diameter more than 20 mm without a normal SPT decrease in caliber. So what we see, more than 50% collapsing, you give fluid, and normally we take IBC diameter 16 mm. Okay. In mechanically ventilated patient, 20% cutoff value in IBC diameter variation, response to fluid challenge with PPV means positive pressure ventilation of 93% and 92%. So when, that's why we see the IBC distensibility index when the patient is mechanically ventilated. So these things, bedside echography versus PAC in ICU, pulmonary artery catheter insertion. So TE produces a change in therapy in at least 1/3 of ICU patients, independent of the presence. So PAC, pulmonary artery catheter, we don't prefer nowadays. So this was a study done by the Benjamin. He told that TE was performed in 12 plus 7 minutes, and putting pulmonary artery catheter, doing things, it takes time. What is they are telling? More than 30 minutes. Bedside echography has a better safety profile. PAC continuous monitoring technique to assess the response. So it can be the gold standard, but nowadays is almost obsolete. We don't prefer unless the cardiothoracic cardiac anesthetist they put because the ejection fraction is low, or few cases they still the gold standard, but it's getting almost obsolete because of the complications. Esophageal Doppler monitoring, useful for detecting changes that otherwise have gone unnoticed. EDM shows to predict subsequent complications in the critically ill patient. Overcompensated hypovolemia, better than pulmonary artery pressures for indicating changes in preload. So you can do the esophageal Doppler monitoring. What is the preload? The venous return, and that is equivalent to the left end-diastolic volume. Okay, so limitations of EDM, when there is a pathology in urosophagus, coarctation of aorta, you have put the intra-aortic balloon pump for increasing the blood pressure, and the coagulopathy, when the patient can bleed. Suppose the varices are there, patient can bleed. So these are the limitations of esophageal Doppler monitoring. Gastric tonometry, it gives you intramucosal pH and carbon dioxide tensions, attractive options for diagnosing and monitoring of splenic hypoperfusion. So what happens? Prolonged acidosis in gastric mucosa is sensitive but not a specific predictor of outcome. So normally gastric tonometry we don't do, but still their literature is there. CEP all of you do, we have done. So assessment of volume status and preload, but this is not the very good, if the CEP is on lower side, then that is, mostly it will be okay. The results are okay, means patient is dehydrated. But higher side, you have to check the other things. So it is not the gold standard right now. You put the CEP line for giving fluid or other things. If you don't have the, or if the peripheral line, you cannot you cannot put the peripheral line or peak this one, the CEP. See, ECG, this is a P wave, this is R wave, you all know. So this is CEP, this is A, right atrial contraction. Here the tricuspid valve is closing. This is systole from R to T. So right atrium relaxing and filling. Then V, then Y. We all will discuss in your work session. Okay. So potential use of CEP more than 10, but clinical use CEP as guide to diagnosis of therapy has not been demonstrated. So it's almost obsolete now. You put the CEP catheter less than 10, then your cardiac output decrease. It's 2 or 3 means your patient is dehydrated. Again, where is that CEP catheter is lying? That is also very important. So fluid resuscitation, initially target of CEP at least 10, and if the patient is on ventilator, it should be a higher level, at least 4 to 5 U minus. So around 8 when the patient is non-ventilated, or 12 around the patient is mechanically ventilated. PSC catheter, it will give you the value of pulmonary artery pressure, pulmonary capillary wedge pressure, okay, right atrial pressure, pulmonary artery oxygen saturation, and thermodilation technique. So PSC, so this is a pulmonary artery catheter. We have pulmonary artery catheter with us, so we will discuss those things. ESCAPE trial has been done. It is telling about that comparison has been done between PSC versus non-PSC, 433 patients hospitalized with congestive heart failure and the volume overload. In PSC group, the goal was keep the pulmonary capillary wedge pressure 15 and RA pressures around 8. So when we call pulmonary artery hypertension, what is the new definition? Anything above 20. 20. Before it was 25, now it is 20. Okay. So 9 serious adverse events in the PSC group: infection, bleed, catheter knot, ventricular tachycardia, pulmonary infarction. Because of these things, it's almost obsolete now. But still it is gold standard. Okay. This was the ESCAPE trial. For the primary endpoint, there was no difference between intervention and control group. So why to put this in PSC catheter? There is no difference. Then PSC MAN trial was done. PSC versus non-PSC. 1,041 patients admitted to ICU who attending thought needed a PSC. 66% medical, 65% multi-organ dysfunction. Therapy at the discretion of the clinician. So serious complications occurred 10% patient where the PSC pulmonary artery catheter was put. So serious, because of serious complications and other things, again, there was no difference between intervention and control group. Then this one, NIH ARDS NET FACT trial, fluids and catheter treatment trial. It was multicentral trial, and efficacy of PSC guided versus CBC guided management reducing mortality and morbidity in patients with established acute lung injury. Only trial coupling a treatment protocol with use of PSC. So pulmonary artery catheter versus your CBC central venous catheter compared a fluid conservative approach with a fluid liberal strategy with specific hemodynamic goals and treatment studies. Then fluid boluses or diuretics are used to move hemodynamically stable patients toward filling pressures. CEP around 10 to 14. This pulmonary artery occlusion pressure 14 to 18. And conservative group, when the excessive fluid was used, this is your target 14 to 18. This is less than 8. And CEP when the was less than 4. So PSC guided therapy did not improve survival organ perfusion. Means you are putting your pulmonary artery catheter, it is not going to make the patient survive, or the organ functions are not better, associated with more complications than CBC guided. You remember this? Complications are there when you are putting the pulmonary artery catheter. So use of conservative fluid management strategy in patients with ALI, PSC should not be routinely used for the management of acute lung injury. It's clear? All these trials are showing. So limitations of PSC monitoring, cost is costly. This around 8 to 10,000 is coming, PSC catheter. Incorrect measurement of data, you have to do the calibration, damping and zeroing every time you have to do, transient respiratory muscle activity and rely on the digital readout. So failure to weigh sometimes where you have put, so sometimes it can give you the wrong values. Incorrect interpretation of data, and when the valve diseases are there, and improper therapeutic strategies, poor application of data on birth, jealous goals, targets. So this, then your mixed venous oxygen saturation, normally it is between 70 to 75. In case of exercise, anemia, hypoxemia, and decreased cardiac, all decrease. In case of sepsis, it will decrease. Sepsis, hyperdynamic sepsis, hypothermic muscle relaxation increases VO2. SCVO2 normally decrease in case of your sepsis. So these things can be done. Then SbO2 does not reflect adequate tissue oxygenation, and persistently low is associated with tissue ischemia. So basically, in case of SbO2 also, the SbO2 is low. This is basically ScVO2 is central venous oxygen saturation, should be more than 70%. SbO2 should be 65%. Absolute reduction of mortality. Normally, in case of sepsis, what you see, it goes down. Once it starts 40, 45%, then come up. If it is around your 50, 60, more it is on the higher side, the prognosis is better. SbO2 tracks SbO2, except GA, severe head injury, redistribution of blood flow in the shock, microcirculatory shunting, or cell death. The SbO2 you can do. Pulse counter cardiac output monitoring. I have another slide that you can do non-invasive continuous beat-to-beat cardiac, like your flow track. SBB can be used to evaluate volume status. Baseline calibration is required. And important thing is, whenever you're doing, you have to do the calibration every time. Use your vasopressors, or the patient is in arrhythmia. The arrhythmic patient can affect the accuracy. Okay, very, very important. When you are doing your this one cardiac output monitoring, that will give you the false values. Provide an acceptable level of accuracy with a bias of less than 0.5 liter compared to the thermodilation cardiac output measurement. SBP more than 10% useful predictor of fluid responsiveness. More than 12%, if the SBP is there, you have to give fluid. Non-invasive pulse counter analysis, that is not that okay. You can do all these things, but bioimpedance, blood has significantly lower this I'll show you on the slide. Bioreactance also I'll show you. Thoracic electrical once more. To summarize, you have to do the preload. You all know CEP, PAWP, GD, left ventricular endoscopic volume, PPV, SPV, SPC, IBC. You do, then so cardiac output monitoring, you have to monitor your stroke volume, heart rate, blood pressure, preload, then volume responsiveness, SBP. These are the dynamic variables. Then afterload, contractility you have to see, pulmonary edema, extra lung water. So these things you have to do. Non-invasive monitoring, dynamic is your PPV and SBB, hemodynamic responses you check. So accordingly, non-invasive you do. You all know we have discussed your capnography, your cardiac output, SpO2 and IBP, invasive, CEP, PAP, cardiac output. So important thing is that invasive through arterial line, accurate beat to beat. If it is non-invasive, this is not that accurate. Cuff bladder less than 40% of the arm. So smaller cuff, if we put the smaller size cuff, what is BP will be? BP will be so higher side, and the bigger cuff you use lower side. These things you remember. So measurements of preload, static variables are there. These are. Then dynamic we have talked about, collapsibility, desensibility, stroke volume variation, pulse pressure variation. So dynamic, when the patient is ventilated, these things. So methods of measuring cardiac output, invasive is this is gold standard, pulmonary artery catheter, non-invasive TE, TT, bioimpedance, bioreactance, pulse counter analysis, then CO2 rebreathing. Take home message, effective hemodynamic monitoring requires a tailored approach, considering the patient's specific needs, the clinical scenario, and the available resources. You have to continuously reassessment and integration of monitoring data. And thank you. So another slides, 4, 5, 10, 15 slides are there. I'll show you. Basically, this I have taken from FCCS, so I cannot. Just I'll finish within 5 to 10 minutes. This is 30-year-old woman, gravida 1, para 0 at the 30-week gestation. Complaints of blurry vision, headache, abdominal pain, nausea and malaise. She has no history of hypertension and her blood pressure elevated. What is this? Yeah, very good. So, and the eclampsia, there will be seizure. Okay, patient's hypertension thus far, then you all do diagnosis. So, hemodynamic monitoring in obstetrics, you do the blood pressure management, you do the pulse oximetry, put the pulse oximeter. This one, pulmonary artery catheter, you could do the CP, put the CP line, intra-arterial pressures, minimally invasive cardiac output monitoring, and fetal heart rate monitoring, because the two lives are involved here. Cuff, we have discussed that too small, BP will be falsely elevated. Cuff is too large, BP will be lower side, falsely low. Pulse oximetry do, this is the principle, arterial oxygen saturation, using pulsatile variation, red and infrared light absorbance. Low amplitude suggests decreased perfusion. High is suggesting variable, if it is variable, intravascular hypovolemia. And at the same time, what the pulse rate is showing through your pulse oximeter and the ECG, both the heart rates should be same. Okay. Pulmonary artery catheter, we have show you cardiac, it will show you cardiac output, systemic vascular resistance, pulmonary vascular resistance, left ventricular stroke walk index, these all things. So what you do intermittently with cold saline injection, continuously with copper, these are the mechanics, basically thermodilution technique. Can be helpful with mixed shock state, pulmonary hypertension, and cardiac output and mixed venous oxygen saturation, direct measurements. All other measurements are calculated. These are the direct measurements. Cardiac output when you are putting the PSC catheter. Again, CEP you are putting, we have discussed right ventricular filling pressure if no tricuspid regurgitation. That's why when the tricuspid regurgitation is there, it can be falsely high CEP. That's why CEP value most helpful when it is low. I told you, means there is a volume depletion, you have to give fluid. Does not reflect pulmonary capillary base pressure or the other left heart dynamics. So, arterial, you can put the, when arterial monitoring you have to, you can put the radial artery catheter or femoral artery catheter, you can put your axillary brachial or dorsalis pedic, more accurate we have talked about. So, this is normal, this is underdamped, underdamped will show you lower, what will show you? Underdamping will show you high systolic pressure, when this is overdamping show you low systolic pressure, will show you in the workstation. So this one you see. Seeing this also you can give fluid. Visible variation in pulse pressure we can see, you give fluid then you will see the changes. So greatest accuracy in mechanically ventilated patient, these are things are there when your patient is on ventilator. And patient doesn't have any arrhythmias. When the arrhythmia is there, so you cannot give fluid and other things, you cannot accurately see how much the patient is fluid responsive. Arrhythmia should not be there. Patient is tachycardic or patient is having atrial fibrillation, requires invasive arterial pressure monitoring. This is what I wanted to show you. Passive leg raise, you all know, can be used in first and second trimester. You cannot do in the third trimester. For that, you have to do the transthoracic echocardiography. We have to, this is flow track. That's why you have put this slide. Non-calibrated, operator independent, index to demographic data, age, sex, specialized transducer can be attached to it. Just only what you need only one arterial catheter. Put and then you see the waves and accordingly you give fluid. The flow track is very, very important and accuracy requires normal artery. Again, there should be no arrhythmias. Pico, stroke volume, these all things you will get, these values. Transpulmonary thermodilution calibration requires central line, one arterial line. Okay? And thermistor tipped arterial catheter placed in femoral, you can put or brachial, you can put the arterial catheter or axillary. Calibration, again most important thing, every time you have to do the calibration hourly during hemodynamically unstable the patient. You cannot leave with it. If the patient is having, your patient is hemodynamically unstable, you have to do the hourly calibration, otherwise 8 hourly. Lead co, you give the lithium indicator dilution calibration you do. Only thing is that when the patient is on AKI, you cannot give lithium. Okay, that is contraindicated. So lithium is contraindicated in the first trimester. Okay. So available, again, this bioreactance I was talking about, non-invasive calculates high blood flow by measuring phase shift or high frequency current applied to thorax with electrical pads, reports values similar to those of the pulmonary artery catheter. That's why I'm talking about this bioreactance. Okay? Cardiac output, what it will give you? Cardiac output, stroke volume, SBR. Normally SBR is decreased in case of sepsis. It will be around 400, 500, something. If you see the hemodynamic monitoring, accordingly you see this your patient in sepsis. has been validated against both pulmonary artery catheter and echocardiography. So bioreactance is very good. Okay. Echocardiography focus we have talked about, volume assessment. These are the static parameters, CEP, left ventricular diastolic pressure or volume, IVC diameter. These are static. Dynamic, your fluid challenge, heart-lung interactions and the passive leg raise like PPV, SBB. These are the dynamic parameters. Okay, LV, DC, left ventricular diastolic volume and left parasternal short axis view. Basically, there are so many views. So this is your LV. Okay, and mid papillary view. This is your IVC. IVC you can see at the two things. Once like this, when the patient it comes out from the right atrium. If you are not getting it there, so then you could put it here. If the ultrasound is there, I can show you. One volunteer there, I can show you. So these things are there. IVC diameter and its collapsibility when the patient is on mechanically ventilated on ventilator. This is IVC distensibility index. Spontaneously ventilated patients, IVC collapsibility index. You see here also we are seeing the IVC. You correlates with CPV. So this is IVC collapsibility index, IVC maximum minus IVC minimum divided by IVC maximum into 100. This is your stroke volume. So important one when the patient is spontaneously ventilated, not on ventilator. The same study, patient is having shortness of breath, epigastric and right upper quadrant tenderness is there. Patient is having pitting edema in the lower limbs. The same patient platelet count goes down. What the diagnosis here? What the patient can have? Anyone? HELP syndrome. Okay. So now what you will do? So these things. So I wanted to show you flow track. I wanted to show you bioreactance and other things. Your IVC collapsibility index, your IVC distensibility index. These are important. What are the dynamic variables? What are the static variables? Fine. Thank you. So next our talk will be taken by Dr. Yudhvir Singh. He is associate professor in AIIMS Delhi. He will be talking about physics. Yudhvir? ये हटा देंगे अपना मेल. हाँ? तुम भेजो क्या हमको? भेज दो हम यहाँ निकाल देते हैं. कब भेजो? अच्छा ठीक है निकाल दे. इनबॉक्स में तो अच्छा ये वाला. कहाँ पे है क्वेश्चन? कहाँ रखे? हम बांट देते हैं. ये लो. ये चाहिए? Excuse me. कोई है क्या?
ठीक है हाँ हाँ हेलो आ रहा हेलो सो ये पॉइंटर है ना सो गुड मॉर्निंग एवरीबॉडी So that's okay. So have you solved the questions? Done? Everybody has done? Okay. So put your name on the question papers so that we can assess. Okay. Put your name on that. So we'll be moving on the topic because you are already running late. So we'll be discussing regarding the physiology of hemodynamics monitoring in the ICU. So lot of things already have been covered and it will be repeated here. So as already discussed by Dr. Simanja, non-invasive hemodynamic monitoring includes these parameters. We are all aware of that. And these all parameters are very important while managing the patient with a critically ill or the patient when go in the shock state. And these become also relevant in the patient if it is if it is located in the remote area, how you will assess the patient. By certain parameters, you can assess the patient in the remote area also, or the rural setting, or the resource limited settings. So these are the say, pulse oximetry. You can use capillary fill time, skin temperature. So these all the parameters can be used in the remote or rural area also. So now coming to these automated BP measurement device, I'm not going to discuss. So now coming to the invasive hemodynamic monitoring. So what we do mostly in invasive hemodynamic monitoring, we use IBP, invasive arterial blood pressure, central venous pressure already, and PAC, pulmonary artery catheter placement. Okay. So invasive blood pressure monitoring, you know, it's regarding the waveforms. So there are the various waveforms that is corresponding the QRS complex of the ECG. So you must be aware of that waveform. Coming to the components of the invasive arterial blood pressure monitoring system, we know we have a placed arterial line. So we use a cannula for that. Arterial catheter is there, or arterial line. You can use a simple cannula also to place that in the patient artery, radial artery, whichever artery you prefer, and according to the situation. This line filled tubings, okay, and thus the set and the pressure bag to give to build a pressure so that the damping doesn't occur. And the pressure transducer devices. So these are the components of the intra-arterial cannula, and coupling system will be there. The coupling system consists of pressure tubing, stopcocks, and a continuous flushing device. Tubing should be short, wide, and non-compliant, stiff to reduce the damping. So you have seen the PMO line. This is a pressure monitoring line. So what is the volume of the pressure monitoring line? So there is a volume. If that, and that is a very stiff, so that it cannot, the pressure should not be transduced to the the atmospheric pressure should not be transduced into that tubing. So that then the only can have a good intra-arterial pressure. So that tubing volume is around 2 ml. Okay, 1.2 ml. If you've seen the PMO line, so its volume is almost only 2 ml. So now coming to the indications for intra-arterial blood pressure monitoring. So when the patient in the shock, or when you require repetitive surgery, long hour surgery, major blood loss is there, major fluid shift is there. So there are numerous indications for the arterial blood pressure monitoring. Okay, and you require frequent sampling also for frequent ABG. So that, and if you are thinking the patient is morbidly obese and you are not able to place the BP cuff, your appropriate BP cuff size is not available. So in that case scenario also you require invasive arterial pressure monitoring. So what are the contraindications? I'm not going to the details. If there is, let's say the local site is infected, you will not going to place. Coagulopathy is there is risk of the coagulopathy, but most of the time the patients which come with the hemorrhagic shock or other disorders, sepsis, if they come in the severe sepsis stage, there may be coagulation disorder will be present in that patient. In spite of that, we also go for a invasive arterial pressure monitoring such patients. So there are, it's not absolute contraindication, it is relative contraindication depending upon your expertise and the setup available. So, and the proximal obstruction, certainly if you're thinking there is thoracic outlet syndrome or coarctation of aorta, so these if you're placing the radial in the radial artery, so it may give different blood pressure readings. So you have to see the patient disease also, you have to evaluate what is the history of the patients and if there is certain symptoms of coarctation of aorta and thoracic outlet syndrome. So coarctation of aorta में क्या मिलेगा? Aorta है ना, इस side में क्या मिलेगा, इस side क्या मिलेगा? BP? This side will be low BP, high BP. So that is the finding. Raynaud syndrome and Burgess disease, these are the disease, the peripheral vascular disease. So there may be the inaberrant reading may be wrong. So sites of arterial cannulation, everybody knows that you can place the arterial line at any place, even you go for the brachial artery, but you must be aware, just say in trauma patient, we are managing in trauma patients, often the patient come in a severe shock and the time of the resuscitation, say cardiac stab aata hai, or something like that. If we are not able to get radial cannulation, then we also go for the brachial cannulation for time buying measures. In the meantime, the patient stabilized, then we shift to the femoral line or the radial line, whatever. So it's like that. You can place it radial, femoral, posterior, tibial, dorsal, lot of. So wherever you are convenient and your expertise are there, you can place it at any time. And if it is gone more distally, so the waveform will be different. Will be coming on that. Okay. So regarding the when you place the RTL line in the emergency situation is a different thing. You may put an RTL line at any place, and you are putting the RTL line radial artery. So what is the test you do for the? You say you are putting the RTL line in a control setting in ICU patient comes. So do you check for the do test? Do Allen test. So what is the then what we are discussing here modified Allen test. So what is Allen test then? So is there a difference between Allen test and modified Allen test? Anybody can tell them. So there is slight difference. The most modified Allen test is that means there is slight difference. In Allen test, you are asked the patient to clench the fist, make it for the time for a time. Okay, ask the patient to and hold it for the hour. So particularly what happens in a normal situation, it is possible. But when the patient is very sick, so he is not able to clench the fist. So ask the patient just only to clench and open it, just do repeatedly 7 or 8 times the movement so that their flow will be established. And then you go for the Allen test. You obliterate the radial artery and the ulnar artery, and you release the radial artery and see the flow. Okay, if there is a delay in the flow for more than 15 seconds, then it can be positive. So then you avoid the cannulation, radial cannulation. So these are the transducer device that transmit the other transducer device which we connect when we introduce a arterial line through the arterial catheter. Then we connect that PMO line, and through the PMO line we connect it to the arterial transducer. In this transducer, the device which the amplitude of the arterial wave. So just a minute. So leveling, then zeroing, then level 0 at the insertion site. So leveling, this is the same. So level 2 अगर level 2 low है काफ़ी नहीं है, अगर level नीचे है, then it will show क्या बताएगा? Level 2 काफ़ी नीचे आपने रख दिया है, it will show क्योंकि नीचे चला गया ना, so it will show the high BP. And level is high, okay, so it will show the low BP. तो inverse होता है, just for remembering. So so the proper level should be very important in the patient who is in the shock. Most of the time we are managing the shocks and sometimes bed is up and sometimes bed off, and then we start the vasopressor. We increase the vasopressor. We forget to maintain the level of the arterial line. This is the same zeroing. Expose the air fluid interface to the atmospheric pressure. So it so that it equilibrate with the atmospheric pressure. Keeping the line patent. So what should we do for keeping the line patent? Either we can क्या कर सकते हैं कि if you are putting in a arterial line transducer आपने connect किया and you connect to the monitor, you just keep on intermittent flushing 1 to 2 ml after half an hour or 1 hour. Just keep the blood. क्या होता है कई बार you connect with the device and then the damp occurs. So damping is damping means over damping भी तो mostly क्या होता है over damp हो जाता है. So क्या then it's become the accurate readings are not accurate. So you have to do intermittent flushing for that. Either you connect with the pressure bag and you maintain a pressure of 300 ml mercury on that. The pressure bag is coming and there also the pressure measurement device is also connected. So you can see the pressure device, or approximately you can correlate with the once you use how much pressure required so that the movement can occur. Okay, so the damping, or you can use heparin also 1 unit per ml to make it patent. The line should be patent. So arterial pressure measurement, the systolic pressure is measured at the systolic pressure can measure at the peak of the waveform, and the pressure reflects the function of, so it mostly reflects the function of the left ventricle. Normal value you are aware of that, lowest point on the waveform. So there is a, so this is a dicritic notch, okay. So lowest point of the the end is, so this is the dicritic notch, and after this represents the क्या कहते हैं diastolic and diastolic pressure. So and this the lowest value will reflects the normal diastolic pressure is 60 to 90 mm, okay. So components of the peripheral wave, arterial waveform, the same will be there. As you go the peripheral, as you will go periphery, so the peak will be more, the systolic peak will be more higher. As you, so when you connect to the aorta is more compliance, okay. So there will be no peaking of the systolic wave. It will be more like a round curve. But as you go distally, it will be more peaked. So we will show the graph. So arterial pressure measurement important. The small notch on the downstream of the waveform is a dicritic notch. It represents the, it's corresponding with the closure of the aortic valve, okay. And this represents the point between the systolic and diastolic phase of the cardiac cycle. So ऐसे जाता है the dicritic notch. So the diastolic phase starts and the lower spaces shows the diastolic pressure, okay. तो ठीक है. Now coming to the pulse pressure variation. So this is the pulse pressure variation. Often we see go through the pulsioximetry. We connect the pulse oximetry, and there is a variation. So how this variation comes? Because of the respiratory phase. So the patient breathe, and there is a pulse variation in the pulse oximetry graph. And this graph variation of maximum and the minimum, it used to take for the plethysmography perfusion index. This is used to calculate for the non-invasive method of hemodynamic monitoring. Okay. So regarding this central versus peripheral waveform, I already told why there is difference. So क्या होता है difference में central versus and peripheral blood pressure. Anacrotic and diacrotic notch disappears. As you go periphery, the waveform becomes narrower, steep, and systolic and pulse pressure increases, and upstroke becomes steeper, and diastolic and mean pressure decreases. Diastolic आपका नीचे because there is no इलास्टेंस जो होता है कम होता है, तो डायस्टोलिक आपको नैरो मिलेगा नीचे. So these are the wave, why the difference? Because of wave propagation, reflection, pulse wave velocity, wave reflection, damping and arterial compliance, central artery are more compliant. That's why they get a broader type of form. And as you go narrower, they become systolic, it becomes less compliant and are more muscular. Okay, so you get a steeper waveform. And as the wave travels to the periphery, the systolic peak is augmented due to the summation of the initial forward moving wave and the reflected wave. This phenomenon is called pressure amplification. So as you go travels periphery, the peak becomes summated. So this is called the pressure amplification. This is asked often in the exam. So this is this is the waveform you see in the aortic root. This is the round form. As you go distally, brachial artery, it is most it is getting peak, systolic peak, radial artery, and the femoral artery like that. And if you go all in the distal artery, like dorsalis pedis, it's like it became getting more peaker, and the diastolic has become wider. So central venous monitoring. So why you require central venous monitoring? For what purpose? For resuscitation. Okay. So as already discussed, so what are the setup required for the for central venous monitoring? You require a CVP line. And what does CVP reflects? It reflects right atrium pressure, okay? Because it is you are putting in the right atrium, just below the superior vena cava junction, below the superior. So clinical significance क्या है? What does it reflects? क्या दिखाएगा? Pressure, right atrium pressure, or moreover, if it is normal physiology, we say there is nothing like that, it will reflect the right ventricular diastolic pressure. Okay, let's say कि tricuspid valve abnormality नहीं है, to consider that everything is normal, so it mostly will reflect the right ventricular diastolic pressure. Abnormality in right arterial pressure are caused by the condition that after venous store blood volume or right ventricle contractility. CVP is measured at the end of when you measure the CVP? At the end of the expiration. Why? क्यों नहीं में inspiration में? Because and क्यों? What happened at the expiration? Expiration क्या होता है? We are getting more positive. So intrathoracic pressure is become more positive. So you are coming equivalent to the atmospheric pressure. So factor affecting say central venous pressure, venous tone versus intravascular volume. Again, if intravascular volume is less, then CVP will be less. Okay. And then if the venous tone is also more, then the CVP will be normal. If venous tone is decreased, like peripheral vasodilation, the CVP may be decreased because venous return is decreased. Okay. And the cardiac function almost depend upon the cardiac function. If there is cardiac abnormality of the cardiac disease there, right atrial dilatation is there, or right ventricular failure is there. So then also the CVP will be affected. Extra cardiac factors में क्या हो सकता है? Tight abdomen. Abdomen, if it is a intra-abdominal pressure is raised, so it will push up the diaphragm, and it will ultimately intrathoracic pressure will increase. If intrathoracic pressure will increase, the CVP will be increased. Oh, so these are the factors: tension pneumothorax and cardiac abdomen. This is the same thing. It increases the intrathoracic pressure, so it will reflect on the venous tone. So अगर intrathoracic pressure बढ़ेगा, तो venous return will decrease also. So it will ultimately affect the central venous pressure. So these are the waveform of the CVP. So here is the arterial contraction. Sorry. So already discussed with the Dr. Simhan. Arterial contraction, then a tricuspid valve, C corresponding to the ear, and downward movement of the right ventricle, the X wave, and the back pressure from the blood during the right atrium, and the tricuspid valve opens in the early ventricular diastole. So this is the contraction of the right ventricle here. QRS complex. So CVP waveform, this same thing. So when to measure the CVP? So these are I have already explained it. You can measure the CVP in both in the mechanical ventilation patient or spontaneous breathing patient. But in both the patient, you have measured the CVP at the end of the expiration. This is the spontaneous breathing patient and the ventilated patients, the waveforms are there. So respiratory effects, pleural and pericardial what is the respective effect of the on the CVP. So pleural and pericardial pressure are almost equal to atmospheric at the end of point of the expansion. So this is true with the both spontaneous and mechanical ventilation. These points in time provides the best estimate for the transmural pressure and the cardiac equilibrium. So it is measured in the end of the expiration. Respiratory influences on a CVP. So these are the waveform. So what are the pros and cons of central venous flow of fluid management? So measures easy to use, okay, very easy to place. Anybody can place it. I think everybody is aware how to place the CVP, and minimal apparatus required and very cheap also. And but it is influenced by the errors in the measurement can be there. High CVP is erroneous, okay, and influence of the mechanical ventilation. So positive is आपने high tidal volume में ventilate करो, high PEEP रखा हुआ है, तो it will show the readings are very erroneous type. So you have to calculate that, you have to manage that. Influence of the raised intra-abdominal pressure, that also will reflect it on the CVP. So these are the concern. CVP for fluid responsiveness will come in the later slide, how much it guides the CVP for a fluid responsiveness or not. On higher, if the CVP is greater than 12 to 15 mm mercury, its responsiveness is not very good predictive. On normal range, 6 to 8 millimeter around, in between the 6 to 12, it is very predictive. But beyond or less than, it is not very good predictor of the fluid responsiveness. The predictive value for fluid responsiveness is lower with the CVP than with the dynamic indices. Safety valve, safety value during a fluid challenge, given CVP value can be used as safety valve. Nothing is there. Now coming to the pulmonary artery catheter, we actually these catheter is not mostly used in these days. Mostly is used in the cardiac ICU and setup or CTVS ICU. Only very limited indications they are also using in a complex cardiac heart disease. Because nowadays non-invasive monitoring are lot of non-invasive monitoring devices has come down, and in minimally invasive devices has come down. So the use of pulmonary artery catheter has been reduced because of its standing complications and expertise to place it also. So this was the device developed by the Swan again, and it is placed in the name of the author. This and diagnosis and monitoring treatment. So information provided is right arterial pressure and pulmonary artery pressure, pulmonary artery wedge or occlusion pressure, cardiac output, mixed venous saturation, or right ventricular ejection fraction. We can also there is a port we can measure that is placed in the right atrium. So we can measure the CVP, and the other port is distal. So that is placed in the pulmonary artery. And if you more place it distally in the pulmonary artery, more distally to measure, it will reflect the pulmonary artery wedge pressure. Okay. So these are the different ports. So these are the proximal injection port. This is for the cold thermodilation fluid, and for the CVP measurement proximal, and this is the distal. So proximal port is 30 centimeter before that. The total length is around 110 centimeter of the pulmonary artery catheter. So proximal, this proximal injection port is there is proximal. So it is 30 centimeter before the distal opening. Okay. So according to the length, it is calculated, and so it is placed in the right atrium, and that is going into the pulmonary artery. Okay. So there is a continuous oximetry cable connector, and there is thermistor connector, and there is thermistor for the thermodilation measurement, through which we give the fluid. Okay. And there is a balloon. So when we place it into distally into the pulmonary artery, then we inflate the balloon around 2 ml. Okay. 1.5 to 2 ml we inflate the balloon when we place it for measurement of the pulmonary wedge pressure. So through this we can continuously monitor the cardiac output and other indices, okay, and the mixed venous saturation. And through this we inject the saline, thermistor connector hai. This is power plug for measuring the heat change measure karta hai, and through this we give the fluid. So we inject the saline, 10 ml saline injected, and through this we are measuring the cardiac output of the brain. So the change in the temperature is measured. The saline is injected in the right atrium. The saline, so cold saline will be injected 10 ml, and this source saline will travel to the cardiac right atrium, right ventricle, and the right ventricle pulmonary artery. So the change in the temperature of the right atrium and the pulmonary artery, this change and the duration of the time will be used to calculate the cardiac output. This is the same way where we have placed. This is the device. This is the pulmonary vein, and this heart is this is a tricuspid valve. This is the right atrium, and for this we going into the pulmonary artery, and then there is pulmonary circulation. Then there is the pulmonary vein. Okay, so we are placing the balloon here for pulmonary artery wedge pressure. This is the same diagram. So balloon. While we place the balloon at the pulmonary artery, pulmonary capillary artery, near where we start the pulmonary vein, this measures the pulmonary capillary wedge pressure of 6 to 12 mm mercury. Then pulmonary artery pressure is 20 to 25 of the systolic hypertension. That is, if it is beyond 20, systolic hypertension. Okay, and then venous Swan-Ganz catheter. Here it is the right atrium pressure, the proximal opening of the port. So indications, a lot of indications are there. Cardiac disease, complex congenital heart disease, mostly they are using. Certain pulmonary disease also used, and there are complex fluid management, shock, acute renal disease. Nowadays it is not mostly used in any of the ICU. Specific surgical conditions, pericardiectomy or CTVS ICU, and there is the right in high risk obstructive patient. This is also not. We are managing with the patient with the mostly the intra-arterial line or the non-invasive cardiac monitoring devices. So distance for the incisional site from right internal jugular vein, Miller suggests that 12 to 13.5 centimeter. Okay, and right ventricle is 30-35 centimeter. If you are putting through the right IJV, okay, so 20-25 centimeter length. Right ventricle 30-35 centimeter. Pulmonary artery 40 to 45 centimeter. If you are going through this, from left internal jugular vein, then additional of 5 to 10 centimeter of length. When you are putting the catheter, so after putting the seat, then we put a pulmonary artery catheter. So that is the length for that. If you are going to femoral vein, 15 centimeter additional. So these are the for the distances from the insertion site while putting the catheter. So these are the same graph, different graph waveforms. When it is placed in the right atrium, it will give the CVP. Right ventricle, this is the same. It will like an intra-arterial line. And pulmonary artery wedge pressure, this will be the and pulmonary artery wedge pressure. So average pressure we know 15 to 12, 0.6, pulmonary artery 15 to 25 and 6 to 12, pulmonary artery occlusion pressure 6 to 12. So thermodilation technique already I have told you how to measure that. And catheter placement, this is the cold line 10 ml we inject. Temperature change and measurement. As the cold bolus travels through the right ventricle into the pulmonary artery, it mixes the blood and causes temporary drop in the blood. So there will be a change in the temperature of the blood in the central right atrium and the pulmonary artery. So calculation done through the thermostat device. So cardiac output calculation in such pulmonary artery catheter is inversely proportional to the area under the thermodilation curve. So the equation incorporates the volume and temperature of the injected. So it is calculated by the modified Stewart-Hamilton formula. Okay, so this is the modified Stewart-Hamilton formula. Okay, and this is the area under curve. So it is calculated by this. We have injected fluid here, and the curve is plotted, and it is calculated. So this is the same thing. So advantage of thermodilation technique: direct and continuous monitoring, accurately, very accurately, very gold standard. Pulmonary artery catheter is gold standard for measuring the cardiac output. Only the issue has been already discussed with the Dr. Simant has already discussed. It's very difficult to put, okay, required expertise, and complications are a lot, okay. So, and while you put what is the advantage? It gives pulmonary artery pressure, central venous pressure. So PAC catheter when you're putting, it gives you pulmonary artery pressure, pulmonary artery capillary wedge pressure, central venous pressure, and mixed venous oxygen saturation. So you are getting 4 or 5 values. So this amount of data you are getting from putting pulmonary artery catheter. Limitations. So if there is right side hearted condition, so it has a limitation. It will the inaccurate measurements will be provided. Timing and technique sensitivity. It very depend upon the technique whether you are able to put in the proper place or not. Fluid overload. While there is a fluid overload, So there may be suboptimal performance, the pulmonary edema. So another pulmonary edema, then it will have a suboptimal performance. So possible complication already know. While we have placed the catheter, there may be catheter displacement. Catheter either move forward or catheter moves forward. There is valvular injuries can be happens, and so lot of complications are there. So that is ventricular irritation occurs when the catheter migrates back into right airway or is looped through the ventricle. Okay. So these are the complications. So now we finished with this topic. Next. बस अब ले लीजिए वो इशू आ रहा है ट्रांसफर वाला इशू आ रहा है इसमें डाल लेते हैं पेन ड्राइव में डाल लेते हैं
Next very important topic I am going to discuss, that is use of vasopressors. When to use, टाइम के पीछे चल रहे हो ना ये क्या हो रहा है पहले ठीक था सब You all know what are the inotropes, what are the vasopressors? What are the inotropes? No. See, there are so many different receptors. One is your vasopressor, one is your inotrope. Something can be both, act like both as a vasopressor, some like inotrope. What basically inotropes, how it works? Increase the contractility, huh? Those are the inotropes. And vasopressors? Huh? Peripheral vasoconstriction like your noradrenaline and other things. But it can have action on both your, they are receptors, they are the drugs, those act on various receptors. Okay? So we will talk about, and normally we do, you all know in the shock state, we have to revive the patient. Norepinephrine, first line drug, you all know, and the SSC guidelines also says. That's why I was asking about dobutamine is first line inotrope. But again, you cannot start dobutamine when your systolic pressure is 70. You cannot start because it causes vasodilatation. Huh? So that's why the systolic pressure should be above, at least above 90. But if you want to increase the contractility of the heart, suppose the LVF is, normally what happens in case of sepsis, sepsis-induced cardiomyopathy, sepsis-induced cardiomyopathy, ejection fraction is gone. And mostly you see when the patient recovers, sepsis recovers, the left ventricular ejection fraction is back. Mostly in case of sepsis, unless until it is combined with some other thing. Fine? Like your stress-induced Takotsubo's cardiopathy, you might have heard the name. Okay? So dobutamine we use, but again when to use, we have to be very, very careful. So vasopressors are the class of drugs with powerful and immediate hemodynamic effects. They increase the MAP, and blood pressure does not always equate to the blood. It is important thing. Suppose a person, elderly person, comes with a blood pressure of 120/80 in the emergency room. Patient can be in shock or cannot be in shock? Who will answer? Huh? Can be in shock. Very good. For that, what you have to ask? Very good. What was his baseline blood pressure? Suppose he is in the home, baseline blood pressure is 150/90. He has come with the 120/80. Then you should be worried. If the patient of 90/60 blood pressure is in the ICU, and still patient is having good urine output, you should not be worried. In the organs are well perfused. Even the patient of 130/80 blood pressure, no urine output, you should be worried, because once the kidney goes into shock, that is the last thing. The dictum is, when the patient is having rising creatinine, that is way to heaven, especially in cases of chronic liver disease. Kabhi dekha hai chronic liver disease patients, if you hemodialyze, chances are there, it will accelerate the death process. Fine? So you have to be very, very careful. When the BP is on lower side, you have to decide what type of shock is there. That Dr. Judhvir will be talking to people. Fine? Vasopressors that are increase the heart rate, chronotropic, that also increase the contractility. That's why I was asking was, most of the drugs, they both have vasopressor and inotropic effect. Peripheral vascular tone depends on, so there are so many receptors. So adrenergic or noradrenergic, two groups. Adrenergic one, mostly you find norepinephrine, phenylephrine, epinephrine, dopamine, dobutamine, and isoproterenol. Angiotensin II and nitric oxide inhibitors. Many drugs I talked to you, they have got both vasopressors and inotropic effects. Inotropes change the force of the heart's contraction. Physiological basis for what digitalis does. Digoxin is, it increases though it is now almost obsolete, because digoxin is very notorious drug. It is supposed to cause all sorts of arrhythmias you can think about. But at the same time, it is still useful. In UK NHS, they use it to increase the contractility of the left ventricle. Fine? And for that again, it causes hypokalemia, so that you have to keep the potassium above. So contraction is characterized by changes in the hemostasis of the microvascular flow, and they alter the metabolic rate through the production of metabolic active molecules. So whenever now the inotropes, alpha-1 adrenergic receptors are located in, you have to see how they act. Mostly they are located in vascular walls and induce significant vasoconstriction, like your norepinephrine. And alpha-1 adrenergic receptors in the heart increases the duration of contraction. So if it is in heart, the action is different without increasing the heart rate, like your dobutamine. Even norepinephrine doesn't increase that much heart rate. Okay? Beta-2 in vessels induce vasodilatation, like your dobutamine. Dopamine receptors are present in your cerebral, coronary, mesenteric, and renal vascular bed, and that causes. So dobutamine nowadays we don't use. Before we used to use because of the renal. Here it is used to renal vascular, isn't it? To increase the, but nowadays it's almost obsolete. So our main weapon is norepinephrine. Dopamine receptors are responsible for norepinephrine release, which causes vasoconstriction. Some of these drugs increase the sensitivity, this is important one, of the myocardial contractile apparatus to calcium, leading to increase in inotropy and vasodilatation. So accordingly, you have to see which receptors it is acting. I have got full list. So vasopressors and inotrope therapy has complex effects. Okay, and emergency providers should consider the physiology and clinical trial data. Vasopressin, its analogs are only second-line vasopressors, and as strong recent evidences, so normally vasopressins, why we avoid? Anybody? We don't use vasopressins because it causes ischemias, MI and other things it can cause. So it can be harmful too. So earlier administration of norepinephrine, it allows achieving the initial mean arterial pressure target faster and reduce the risk of fluid overload. That's why whenever your patient comes, it's nothing like that, 30 ml per kg of body weight in first 3 hours you give. Maximum 500 to 1 liter you give. If the BP map is not coming up, start your low dose vasopressors like your norepinephrine. That is the dictum right now. Nothing like that, you wait for the 3 hours. And if your diastolic pressure is low, what your diagnosis is? Isolated low diastolic is diagnosis of sepsis. Okay? So that in that condition, your diastolic is low, your SVR is low, start your norepinephrine. So vasopressors, we have noradrenaline, adrenaline, dopamine, vasopressin, terlipressin, phenylephrine. That's why don't normally, suppose a patient comes with the GI bleed, with the upper GI bleed, and the urine output is also decreased in cases of chronic liver disease, we prefer terlipressin over noradrenaline. Or don't give 2 agents. Don't give both agents. Only start either norepinephrine or terlipressin. Inotropes, dobutamine, mirinone, levosamendin we don't use that much, enoximone I have never used. Other drugs I have used. Dobutamine, it acts on alpha-1 receptor. It has got good action on beta-1, beta-2, that's why very good. Dopamine, again it acts on most of the receptors. Epinephrine, very, very powerful. Vasoconstrictor effect, alpha-1, beta-1, beta-2. Mirinone, norepinephrine has got again very good alpha-1 like your epinephrine. Phenylephrine is very powerful vasoconstrictor. Okay? Normally phenylephrine you people might be using your, after giving a spinal shock is there low doses, isn't it? But phenylephrine can be used in ICU also, but beware, it is a very powerful vasoconstrictor. Okay? So we have talked about which receptors they are acting. So when to use vasopressors? SSC recommends applying vasopressors within the first hour. Okay? Now, when fluid administration is not sufficient, fine, to achieve the hemodynamic resuscitation goals. It's nothing like that, you give 3 liters, 4 liters fluid. No. 1 liter fluid, not able to meet the map, start your vasopressors. Recently, 34 experts from the European Society of Intensive Care have recommended starting vasopressors early before full completion of fluid resuscitation. Okay? It's nothing like that, like you give for 2-3 hours, then you start with no. Now, early norepinephrine administration could correct hypotension faster, and it decreases the mortality. Once, see what happens. Your other organs will recover, but remember, if kidney goes into shock, then things are irreversible, because at that moment, what you can start? You can start CRT. But I have seen patients, I'm practically talking about, putting the patient on CRT, they recommend BP goes down, patient has cardiac arrest. So things are good as long as, that's why now there are so many invasive procedures have come, everything, but if the urine output is decreased, if the kidney is gone, life mortality is very, very high. Mortality is very, very high, whatever you do. Fine? So that's why try to protect kidney. Okay? That's why you might have seen your nephrologist, nahi, map ko upar rakho, urine aayega. Yes or no? Always keep the map above. In ICU, we have got very good nephrologists from AIMS. They always tell you keep map above. You have to protect your kidney. Fine? So retrospective data showed that not only the degree but also the duration of hypotension in the initial phase of septic shock are determinants of patient's outcome. You might have seen anybody from cardiac anesthesia? Raise your hands. No. So you've seen your patients with borderline kidney function, if they go on pump when we do, when suppose mitral valve replacement and suppose the patient we cannot do beating heart, we put the patient on pump, borderline kidney function, and the patient remains on pump for 6 to 7 hours, datas are there, the patient goes into renal failure, chronic renal kidney disease they have. Either what happens, either CVA or the CKD. So incidences of CKD is high when your borderline kidney function, or even the normal person goes for a longer period of hypotension on pump. That's why they tell if the kidney goes into shock, it's not a good condition. Okay? So early norepinephrine infusion, what it will do? It increases the cardiac output, increases cardiac preload, reduce preload dependency at the early phase of septic shock, and they increase the mean systemic filling pressure, redistributes the abnormally increased unstressed volume to the stress volume through alpha adrenergic mediated reduction of energy. So it acts on alpha 1, important one. So start it early. Any could be used to exert a synergistic effect along with the fluid. Give fluid, start your noradrenaline. Lower dose. Lower dose. Suppose what is the dose of noradrenaline? 0.01 microgram per kg body per minute to up to 3 microgram per kg body weight. Even more you can go. Nowadays, there is no upper limit, literally. Suppose your patient goes around, you have started noradrenaline, if the dose is increasing, it's around 0.4 microgram per kg body weight per minute, then what you should do? You should start your vasopressin, provided there is no contraindication for vasopressin, because vasopressin has got its own adverse effects. I have seen patients, normally whatever data we have, those are made for Western people. They are strong. Our Indian people, they don't tolerate terlipressin doses. You even up to 3 mg, your patient have diarrhea, your patient have bradycardia, your patient can have MI too. I have seen, personally, I have seen so many patients. So beware whenever using such drugs, because drugs can backfire also. They can have adverse effects. Okay? So early administration, what they do of any norepinephrine, it recruits microvessels and it improves microcirculation in cases of severe hypotension. So also increases improved tissue muscle oxygen saturation along with increase in MAP by any from 54 to 77. This is the data by George et al. In patients with septic shock. Early norepinephrine administration could prevent harmful fluid overload. Always remember, when you are giving excess fluid and the patient is going ARDS, that time mortality increases. Wet lung causes increased mortality compared to your dry lung. So judicious administration of fluid is advised. Okay? It is well established that positive fluid balance is independently associated with worse outcome, what I was talking about. Fine? Early norepinephrine administration could improve the patient's outcome. 2 retrospective studies found that the time to initiate norepinephrine was independent factor associated with mortality. Earlier the better. Earlier the better. You can taper off. If you don't start, patient goes into shock, kidney goes into shock, things will be irreversible. A recent RCT, randomized control trial, including 101 patients with septic shock, admitted to the emergency department, and the impact on survival of early NE initiation along with fluid administration. So late NE initiation after the failure of 30 ml, this is almost gone to achieve the MAP target. So what you have to do, early administration of norepinephrine in septic shock patient is with increased survival rate. Is clear? A large variety of vasopressors acting on different vascular receptors are available at the bedside. You might have seen your patient is undergoing dialysis and sometimes the BP goes down. What you do? Prophylactically, you start your norepinephrine infusion. आप अगर fluid दोगे, then again you have to remove the excess volume and patient is already in shock. And then what you do? Prophylactically start your norepinephrine. Once the dialysis stop, you taper your norepinephrine. What normally we do. It's clear? So better to start norepinephrine at the earliest. Don't wait. Sometimes it may backfire, but normally nothing happens. So norepinephrine, alpha 1 beta 1 receptor, it causes increased venous and arterial tone, increased preload, increased contractility. What are the major side effects? Can have cardiac arrhythmias, peripheral ischemias. So you have to remember, epinephrine is worst agent, so should not use if possible. It causes tachycardia, tachyarrhythmias, peripheral ischemia, splenic ischemia, increased myocardial oxygen demand, lactic acidosis happens. So it is though it causes increased contractility, increased preload, but it is very powerful vasoconstrictor. Dopamine, the same thing, contractility, it has increased heart rate, increased venous and arterial tone, and before it was being used because of the increased renal and mesenteric vasodilatation, but now it is out of use because of we have got the better agent, norepinephrine, and it causes tachycardia and tachyarrhythmias. Why to use? Comparatively, we don't have that much arrhythmias in case of norepinephrine. Angiotensin II, it causes an increase venous and arterial tone, increase ACTH, it will retain water, aldosterone, it causes tachycardia, peripheral ischemia, thromboembolic events. We don't use vasopressin, we are using, but again I told you cardiac arrhythmias, peripheral ischemias it can cause. It also causes increased water retention, release of coagulation factor, increased corticotrophic excess insulin secretion. So terlipressin mostly are using, it causes, that's why Indian population doesn't tolerate more than 3 mg of terlipressin. I have never seen a patient of Indian patient tolerating of 6 mg of terlipressin. Okay? So peripheral ischemia, mesenteric ischemia and cardiac arrhythmia it can cause. It can cause both bradyarrhythmia and the tachyarrhythmia. Clear? And celepressin I have not used, but same drug is a big brother of terlipressin, same venous and arterial tone, platelet aggregation, decreased vascular leakage, this can cause. So you have to see where it is acting. This is all, I am not going to detail epinephrine causing this, negative effects in critical patients, beta 2 it causes bronchodilation, and on the negative effect it causes increased bronchoconstrictions. So these things are there and you have to see what is happening. So what are the recommendation? Norepinephrine is the first line drug, that is no doubt a strong recommendation. As a strong alpha adrenergic agonist, norepinephrine increases blood pressure primarily through its vasoconstrictor properties with little effect on heart rate. Vasopressin, second line vasopressor, despite the absence of proven outcome, benefit large randomized trial, but normally even if you don't think that the patient can have peripheral ischemias, we start vasopressin, but always check your limbs, even the terlipressin, check your limb color and other things, it can cause peripheral ischemia. I have seen, even the gangrene it can cause, if you don't keep on giving, it causes bradycardia, it causes bradycardia, it causes MI also, we have seen cases. So, but reversible, if you stop the drug, things are pretty reversible. Okay? So surviving sepsis campaign, a post hoc analysis of vast trial found that vasopressin was more effective in less severe shock, whereas if you add vasopressin to the norepinephrine, it reaches the initial map target faster. That's why I'm telling you, what is the dose of norepinephrine? 0.01 microgram per kg body weight, maximum to 3 microgram per kg body weight per minute. If you reach up to 0.4 microgram per kg body weight per minute, start your vasopressin if you are not able to meet your map of 65. Clear? So SSC had suggested that vasopressin to any dot is a weak recommendation, low quality evidence with intent to rising map or target the any doses. But I think so, if there is no contraindication of vasopressin, start your vasopressin at the earliest, like your norepinephrine. Meta-analysis says that in case of distributive shock, like your sepsis, okay, lower incidence of, again very good thing, vasopressin you are adding, there is a lower incidence of atrial fibrillation if you start your combined with the norepinephrine, or you give norepinephrine, chances there patient can have atrial fibrillation. Because see, patient sepsis with lower BP, lower MAP, treating the atrial fibrillation with drugs is a difficult thing. You have to decide use or not to use. It can be counterproductive too. You can lose your patients also. Fine? So recommendation, epinephrine, another second line vasopressor, but it acts on so many receptors, arrhythmias, other things. It can finish your patients also. If you don't have any other choice, start. So epinephrine to any weak recommendation, low aiming to target MAP. If you don't have any choice, you can start your adrenaline. So inotropes, what? It causes evidence of myocardial dysfunction is suggested by low cardiac output and increased filling pressures are there. Start your inotropes, but provided your systolic pressure is on higher side. Persistent hyperperfusion despite optimal fluid resuscitation and use of vasopressors. So what you can use? Dobutamine, we have talked about. Dobutamine is the first agent. Milrinone recommendation that are chronically beta blocked with chronic heart failure, whose adrenergic receptors I have used few cases, but not very good result. So milrinone role in treatment septic shock optimizes cardiovascular performance in septic shock and mixed shock. Basically, cardiogenic shock also being used without affecting hemodynamic variables. But we are not using very frequently in case of very few cases, rare. So levetiracetam again is not currently used in septic shock, and further investigation has to be done. Exerts beneficial effects in treatment substance-induced myocardial, and but one cases I have probably used, not frequently is getting used, levetiracetam, though it is available. Needed to clarify whether levetiracetam improves the overall outcome. I don't think so. Dobutamine, yes, increases heart rate, increases stroke volume or cardiac output, and at the same time, it decreases your left ventricular filling pressure. If the filling pressure increase, it will decrease it. Modest decrease in BP and SBR. So it decreases SBR because of the vasodilatation, but increases the contractility. Data from the acute decompensated heart failure national registry revealed an increase in mortality due to manifested precipitating myocardial ischemia and tachyarrhythmia. Recommended dose is 2 to 15 microgram per kg per minute and does not require renal adjustment. Dobutamine, be careful when you are using it. So when you are comparing norepinephrine with dopamine, that's why vasopressor response are better. You will get higher MAP. Result is more reliable involvement in hemodynamic parameters, most notably MAP and urine output. When norepinephrine administered compared to dopamine for patients with, that's why use of dopamine in septic shock is almost obsolete now because of increased incidences of arrhythmias. Fine, and it's not that powerful vasoconstrictor. Phenylephrine infusion is comparable to norepinephrine in reversing hemodynamics and metabolic abnormalities of sepsis, with an additional benefit of decrease in heart rate and improvement in stroke volume index. Can be used, phenylephrine. It is being used. When you think that nothing is happening, you can use your phenylephrine infusion also. Okay, thank you. आ जाओ एक चाय मुझे भी पिला दिया ना. ये चाहिए क्या? रुको, ये लो.
Hello. Okay. So coming to the next topic, we will be discussing the central venous and pulmonary artery catheters relevance in current scenario, whether which is important, whether we should continue with the use of CVP or not, what is relevant. So are we using CVP as a monitoring for the fluid guiding therapy, for fluid resuscitation? So nowadays mostly CVP is not used. In our ICU at AIMS, we are not at all connecting CVP. We are not at all using the CVP. Okay, we are not at all using. And pulmonary artery catheter already we have just discussed. We'll just discuss some scientific evidence, what is the evidence. So we are also not using the pulmonary artery catheter in normal ICU, it is only restricted to the CTVS ICU. So what is the evidence? So this was the regarding the syndrome. So there was a study done in critical care medicine 2017, and the study was cardiac filling pressures are not appropriate to predictive hemodynamic response to volume challenge. So in that study, so the study was done, a total of 150 volume challenges given to 96% were reviewed, and this in this CVP guided and the CVP guided fluid therapy was studied here. So in this study demonstrated that cardiac filling pressures are poor predictors of fluid response in a septic vessel. Therefore, their use of target for volume restrictions must be discouraged at least after the early phases of sepsis has included. So in this, a central venous pressure of less than 8 mm mercury and a pulmonary arterial occlusion pressure of less than 12 mm mercury predicted the volume response with a positive predictive value of 47% and 57%. So the PP value was 47% only and 54% in both of the central venous pressure and pulmonary artery catheter. So positive predictive value was only 47% with CVP and 54%. So the evidence suggests that CVP is very poor predictor of fluid responsiveness in septic patients. So now coming to the other study, a meta-analysis was done in 2013 by the Paul A. Merrick. This is a very known author, renowned, and he does study, does the central venous pressure predict fluid responsiveness, and a meta-analysis conducted on the study. And in this study, what was found that area under curve was 0.56 of CVP. So the area under curve only was 0.56. So this was this suggests that that there were no data to support the widespread practice of using central venous pressure to guide fluid therapy. And this study meta-analysis comprises of 23 large studies, and according to this study, Paul Merrick, we come to the evidence that the CVP has very poor predictor because area under curve is very 0.56. Okay, if it is more than 8.8, then it is relevant. 0.75, then it is relevant. So very poor predictor of fluid responsiveness in a patient with a shock. So again, to summarize, okay. So this was the Paul Merrick is a 23 study analyzed 0.56, and this was the Osman et al. Study. So both studies suggest that CVP should not be used to predict the fluid responsiveness in the ICU. So no, we are not. So now current recommendation suggests that CVP should not be used to check the fluid responsiveness or in such patients. So regarding the CVP is a static value. Oh, it may be so what this CVP pressure suggests, it may be preload responsive or may not be preload responsive. So it say that may be preload responsive or not preload responsive. So a survey was conducted in the US, and it was found that 73% of anesthesiologists are using CVP as a guiding of the fluid therapy. It was conducted in around 2010. A survey conducted, 73% were using CVP as a guiding fluid therapy, and 84% was using as a guiding fluid therapy in European countries. This was a survey connected. Still, so, but no, So CVP is a marker of preload. Okay, it suggests there is what is the preload in the right atrial pressure, but it doesn't suggest the marker of preload responsiveness, whether the fluid you are giving, okay, so the patient will be able to take the fluid. Okay. So we suggest that, so now coming to the other reference, the cervical sepsis guideline in 2021, this was again it suggests that the committee comes to the conclusion that we suggest that the dynamic indices over the static variables be used to predict the fluid responsiveness when available. Okay, so this was the surviving sepsis guideline 2021, and another study done by the Maurizio Cecchini, and this was a study published in 2019 Intensive Care Medicine, fluid administration of acute circulatory dysfunction using basic monitoring narrative review, an expert panel recommendation by the European Society of Intensive Care Medicine task force. So this also suggests that they examined the data and the results. They also recommended that dynamic indices should be used, such as pulse, pressure variation, and stroke volume variation. So this should be used over the CVP and other. So now coming to the pulmonary artery catheter, measurements from the pulmonary artery catheters. So these are the all data we'll get from the pulmonary artery catheters. Yes, what happened? कुछ स्लाइड में एरर हो गया, बस कुछ एरर आ गया कुछ एरर आ गया, ठीक है वो कॉपी नहीं हुआ है, नहीं ठीक है, ये रहने देते हैं. So we already I think regarding the pulmonary artery catheter, Dr. Siman Jha has discussed. He had quoted the SCAPE trial and PAN trial. So they all suggest that the risk of infection and complications are more in the pulmonary artery catheter. Okay. So it is also not recommended to use in the general ICU. It is only restricted for the CTVS ICU and that. So and all the studies suggested that moreover the data with non-invasive monitoring is equivalent to the pulmonary artery catheter. Okay. So next topic. कर ले. और क्या बचा?
So I will be talking about CEP waveform analysis and beyond, and arterial waveform analysis. In this talk only, I'm going to talk in detail, so that we should not have to discuss in the word discussion as we are running short of time. Okay? PAC waveforms I am not going to discuss because it's almost obsolete now. What the most common thing we are using, we'll discuss about that. Okay? So all of you must have put the arterial line. Mostly where you put? कौन सा? Radial. Okay. नहीं मिलता है तो then you what you try? Brachial नहीं try करना चाहिए. Femoral करने के लिए डॉर्सलिस पेडिस भी और भी कहीं भी कर सकते हो, whatever you can use if you are not getting. So arterial pulsation result from rhythmic ejection of blood from the left ventricle of the heart during the systole, you all know, and it generates a pressure wave, and it is detectable at various sites such as radial or femoral, wherever you are putting your catheters. it travels much faster than the actual blood which is ejected, pressure waves, and conducted through the aortic valve and vessels along a fluid column, then up a catheter, then another fluid column, heart tubing, and finally into your Wheatstone bridge transducer. So we have got this Wheatstone transducer here. You can see one is your transducer end, one is your patient end. You all know. And normally what we do, one pressure bag is there. The pressure bag, we normally keep it pressure of 300. Fine. And we'll talk about, we'll open this and we'll talk about on the workstation how to put the CEP catheters. Both are things are same. Only thing, when you're putting the arterial catheter, arterial line you're connecting, when you CEP line you're connecting. Is clear? So, what information you derive from the pressure waveform? Heart rate, systolic pressure, diastolic pressure, map. Through that waveform I'll show you. Pulse pressure, and it's very high in AR. AR pressure में क्या होता है? Pulse pressure is very high, aortic regurgitation. Low in cardiac tamponade or cardiogenic shock. Changes in amplitude associated with respiration, pulse pressure variation. We have talked. And waveform, slope of anacrotic limb represents aortic valve and LVOT flow. Left ventricular outflow tract flow. Slurred wave in aortic stenosis. Collapsing wave in aortic stenosis. Rapid systolic decline in left ventricular outflow tract obstruction, Bispherians waves in hypertrophic obstructive cardiopathy, low diacritic notch in poor peripheral. So we'll discuss about all these things. You can see this is your normal arterial pulse waveform. This is anacrotic. This is your systole. This is systolic peak. Then this is your diacritic notch. Then this is your diastole. This is phase diastole, and this is end of diastole. Okay. Rapid increase in pressure to peak. This is peak. Followed by a rapid decline, begins with the opening of the, यहाँ पे क्या होगा, aortic valve and corresponds to the left ventricular ejection. So systolic peak में क्या होगा, it will eject the blood. Okay. Diacritic notch, this one believes widely believed to represent the closure of the aortic valve is closed here. Okay. Diastolic phase, which represents the run of blood into the यहाँ पे into the peripheral vessels. This is diacritic limb. This is diacritic notch. This is anacrotic limb. The waveform can be separated anacrotic upstroke and diacritic is your downstroke limbs. Clear? So I am not going to discuss. Take this workstation. Running short of time. Okay. This is area under curve, diacritic notch. This one anacrotic phase and diacritic this one. So map. This one is mean arterial pressure. Pulse pressure is difference between systolic and diastolic pressure. Peak correlates with the systolic pressure as measured by normal non-invasive cuff. The lowest reading before the next pressure wave is the diastolic pressure, you all know. Mean arterial pressure is calculated from the area under the pressure curve. Okay. Now this is your map. Here the map is higher, here the map is on the lower side. Okay. So what it is showing? Though the identical systolic and diastolic pressures both are same, the area under the curve for one wave of substantially small is into a lower map. So area under the curve is less here. That's why lower map, see height of the both systolic is the same, diastolic almost same, but area under the curve is low here in this one. So map is low, here map is high. Okay. Pulse waveform. This is systolic upstroke, systolic peak pressure. Here aortic valve closes, diacritic notch. This is systolic decline. This is diastolic runoff in diastolic pressure. Is clear? Fine. Systolic this is all written here, and this is in diastolic pressure. Okay. When in diastolic pressure there, your systole starts. Timing of what you do. Normally, what you see, you always time with your ECG. Is clear? Systolic upstroke does not occur immediately following the contraction of the heart. है ना? यहाँ contract systolic phase, it normally does not immediately starts. What they are telling, the arterial pulse wave does not appear on the monitors until a 162. See, immediately is not starting. This is QRS T. Immediately it's not starting. It takes time. Around 160 to 180 milliseconds delay is there always. Hmm? So always delay is there, yes or no? Huh? Systolic up, this one, anacrotic, dicrotic notch. Reasons for the delay are not completely related to the measurement apparatus after the R wave. This one, it was R wave. This is R wave. Huh? Q, R, this is S, this is your T. The depolarization wave has to spread through the left ventricle. Some isovolumetric contraction needs to take place, then the aortic valve has to open. At the dicrotic notch, aortic valve closes. And then the aortic pressure wave needs to travel up the aorta and down the arm at the 6 to 10 milli per second. So they are telling about the why there is a delay. Same thing we have discussed. Upstroke, LV contraction, it influences the arterial systolic pressure, aortic valve flow, and arterial peripheral resistances. Diastolic pressure, the pattern of LV electrical activity. So it is getting influenced by all these things. Systolic peak pressure, maximum pressure in the central arteries generated during the systolic ejection. So it is the maximum pressure, that is systolic peak pressure is there. Here it is building. This is the maximum pressure we are getting here. Systole. Systolic decline pressure comes here. The aortic valve closes. A rapid decline in arterial pressure as the ventricular contraction comes to here. It comes to end. It's coming to end. Dicrotic notch. What is telling? Effect of aortic valve closing. Okay. Now, diastolic runoff is there. Drop in pressure which occurs after the aortic valve has closed. So that is in diastolic pressure. Gold standard for blood pressure is always invasive, intra-arterial blood pressure management, because bit to variation you can calculate. Useful to the close monitoring of the patients whose conditions may change rapidly. Not in when you do the invasive blood pressure monitoring, when the BP is level, coming up and down, or patient is in shock. The waveforms produced may be analyzed, allowing further information about the patient's cardiovascular status to be gained. It may also be useful where NIBP measurement is difficult, because in case of burns, in case of obesity, where the patient is in shock, you cannot measure the BP. You think that what is the BP? Put the arterial line, and at the same time, when the patient is shock, the peripheries are cold, your pulse oximeter can give you a deceptive reading. That time you do the ABG and the PO2 is going to give you. That time you are, oh, my PO2, SPO2 is so low. Don't get frightened. Do the ABG. And for doing the frequent ABG, you need a arterial catheter in situ. Yes or no? More than 3 ABGs is indications for, in a day, indications for putting a arterial line. Clear? So it may be also useful where NIBP measurement is difficult in case of burns, obesity, or the patient is in shock. Reduces the risk of tissue injury and neuropraxis in patients who will require prolonged blood pressure measurement. You might have seen your patients, attendants come, then tell you, my patient limbs are swelling. Ecchymose. In case of CLD patients, you keep on continuous non-invasive blood pressure monitoring, you will find the ecchymosed limbs, because the nurses or the doctors, they forget to give the instructions that the BP has to be taken every half an hour, every 5 to 10 minutes, and the patient is in shock. You do the complete continuous monitoring. That time what will happen? It's getting either thrombosed, sometimes ecchymosed, or there will be limbs will be swollen. In those cases, if you do the invasive arterial monitoring, that is useful. So you won't get the risk of, you don't have the risk of injury, tissue injury. Allow frequent arterial blood sampling, more accurate than NIBP in the extremely hypotensive or the patient is having arrhythmias. Okay? Column of fluid directly connecting the arterial system to a pressure transducer. We will show you. Workstation with CVP and both things we will show them. Pressure waveform of the arterial pulse is transmitted via the column to a pressure transducer, where it is converted into electrical signal, and it is being processed, amplified, and converted. Before doing that, you have to make it that you have to keep it 0. This one. You all can see this one. 0 is being done in this position. 0 karte hai, then you take then the waveform comes. And sometimes there is over damping, under damping. Again you do the zeroing, do the flushing. Things are being done, whether it's arterial or the CEP monitoring. So intra-arterial cannula, arterial system is assessed using a short, narrow, parallel-sided cannula made up of polyurethane and Teflon. You all have seen to reduce the risk of arterial. Before, see, both have, one is your Seldinger technique. Even the radial artery, you put that one guide wire, but it can damage the intima. Yes or no? But direct one you can also do, but you have to be very accurate. Through Seldinger, through using guide wire, it can be easy, but repeated attempts that can damage your patient. The radial artery can go into a spasm. That's why Dr. Yudhir was talking about Allen's test and the modified Allen's test. And don't attempt ulnar. Don't attempt brachial. Radial, femoral, dorsalis pedis, or other things can be tried. If nothing you are getting, can be tried, but be careful. Okay. So risk of arterial thrombus formation directly proportional to the diameter of the cannula. Hence, a small diameter cannula used, not the bigger cannulas. Increased damping in the system. So under damping, I'm going to talk about. So tubing should be extra wide and non-compliant, stiff to reduce the damping. Extra 3-way taps. These should be the quality. Wide and non-stiff. Unnecessary length of tubing should be avoided wherever possible. Tubing should be color-coded or clearly labeled to assist easy recognition and reduce the risk of intra-arterial injection. See, intravenous intra-arterial injection can be catastrophic. You can lose your patient also. 3-way tap is incorporated to allow the system to be zeroed and blood samples to be taken. Yes? We will show you. Here. 3-way trap is there. Pressure transducer is there. This is your patient end. This is your transducer end. And one bag, the pressure should be in the bag around 300. Clear? And so attached to the arterial cannula, this is your patient end. Provides a column of non-compressible bubble-free fluid between the arterial blood and the pressure transducer for hydraulic coupling. Okay. Then this is pressure transducer. Fluid in the tubing is in direct contact with the flexural diaphragm, moves strain gauge in the pressure transducer, converting the pressure waveform into an electrical signal through this one. Okay. So now, cable to you all must have seen. They attach that cassette into that one, that monitor. So pressure transducer relays electrical signal via cable to the microprocessor, where it is filtered, it is amplified, analyzed and displayed. The waveform you will be seeing. So unless until you don't have the idea of a normal waveform, whatever waveform you are getting, you think that's okay. You must be having a clear-cut idea of a normal waveform. So infusion flushing bag, 0.9% saline or hypnotized 0.9% saline is pressurized. I talked about the pressure, 300 mm Hg and attached to the fluid filled tubing via a flush system. Allows a slow infusion of fluid. Dr. Yudhir was showing 2 to 4 ml per hour to maintain the patency of the cannula. Okay. Flush system will also a high pressure flush of fluid through the system in order to check the damping and natural frequency of the system and to keep the tubing clear. What factors can affect? Amount of blood the heart pumps per minute, that is cardiac output, arterial compliance, that is stiffness, how easily the arterial walls can expand and contract, the pressure changes, SVR, the resistance the heart must overcome to circulate blood. This is SVR. Normal value is around 800 to 1200. Fine. SVR goes down in case of sepsis. So this is analysis arterial pressure valve form produced by summation of sine waves. You can see this version. This is dichrotic notch, systolic, this one anacrotic, diastolic notch, this is decline, you can see here. Then the same thing, systolic decline, dichrotic notch and other things. This must be in having your mind, what is the normal one? Then only you can compare. This is compared with pressure in the aortic arch, the more peripherally recorded femoral artery pressure waveform demonstrates the wider pulse pressure 1 and 2. And delayed start to the systolic upstroke, delayed slurred dichrotic. So here what you are seeing here, this is in aortic arch, this is in femoral artery. So what happens? You compare one with your two. So delayed start to the systolic upstroke, third one. So if it is aortic arch, it's getting delayed systolic upstroke and delayed slurred dichrotic notch. See. This is dichrotic notch is delayed and a more prominent diastolic wave. Okay. So where you are putting your catheter that is being compared. One is your aortic arch, one is your femoral artery. So aortic arch, who will put? Surgeon, cardiothoracic surgeon. So impact of pressure wave reflection of arterial pressure waveforms, systole, diastole, normal is this one, and inwardly. Inwardly, you see the normal. This one is arterial waveform. So you have to see the age of the patient also when you are seeing. It will be different from in the young patient and in the elderly. It's different because systolic peak pressure is high here. See, waves increase pulse pressure in case of elderly. For late systolic peak pressure arrow, you can see attenuates the diastolic pressure waves and at times distorts the smooth upstroke and early systolic hum. So this is in case of young. This had been compared with the elderly. Components of IP system. This is arterial line. This is patient end. This is pressure transducer. This is your pressure bag. Around 300 we keep the pressure here. Plain 0.9% saline, pressurized to 300 mmHg and connected to the fluid filled tubing via flush system. Slow infusion 1 to 3 ml per hour. Intermittent flushing you can be done through that one. You pick up this, can you see through this? This one, this one, blue one. Dilute concentration of heparin can be done, but you check your patients, what are the parameters, whether the patient is thrombocytopenic or what are there. This is underdamped because underdamping what it will show? Underdamping, and this is overdamped. So systolic pressures are more, but it is being shown less. Here it is less, being shown high. So underdamping you should prevent, and the overdamping. This is very, very important. We talk. So abnormalities you will find in case of aortic stenosis, pulsus parvus, pulsus delayed upstroke, and in case of pulsus parvus, narrow pulse stroke. Then aortic dysphorean pulse you all have seen. Then wide pulse pressure is known, is found in case of aortic regurgitation. Cardiac tamponade, you all know pulsus paradoxus is the exaggerated decrease in systolic blood pressure. This is quite common. Pulsus alterans, this is common in case of systolic left ventricular failure. So if you see both this one, this is pulmonary artery pressure. This is compared with arterial pressure. And this is ECG. Always it is being compared. You should always, should be always showing your ECG. Then you should compare to the ART. It's getting delayed. You see here, this is your pulmonary artery pressures, and it's getting compared. So what you are seeing here, aortic regurgitation produces a dysphorean pulse like this, okay, and a wide pulse pressure is here. In case of D, what you are finding? This is HOCM, hypertrophic cardiopathy, shows a peculiar spike and dome configuration. This is HOCM. The waveform assumes a more normal for following surgical. When the surgery has been done, it will show like this. In case of HOCM, here this is pulmonary artery pressure, this is ECG, this is arterial pressure waveform. So what is PPV? Pulse pressure variation, PP max minus PP minimum divided by PP plus max plus PP. This is formula, divided 2 into 100. When it is 9 to 13% is normal. So when it's more than 13% is, if it is more than 13% is fluid responsive, this is a gray zone 9 to 13, and if it is less than 9%, it is non-responsive, don't give fluid. In case of systolic, this one, SBV, SB max with the same formula, SB maximum plus SB minimum divided 2. So target should be 10 to 13%, and target SBV should be less than 13%. Okay. So damping we have talked about, reduction of it can be over damping, it can be under damping. So if you encounter more resistance, the waveform becomes dampened or flattened. So over damping we have talked about. This excessive damping is there, required in all systems. So excessive damping, the systolic pressure is so low that we have seen. So factors that will cause the over damping: three-way taps, bubbles and clots are there, vasospasm is there, kinks in the cannular tubing. You will correct all these things, then things will be better. So under damping system will show excessive high systolic pressure, always remember, and under damping excessive high blood pressure and low diastolic blood pressure is a residual signal. So when you are seeing the under damping, the smaller one, So it will show excessive high systolic pressure. Critical damping therefore defined as the minimal amount of damping required to prevent any overshoot. So this is your underdamping. Occurs when the arterial system is highly compliant or where there is a low resistance in the vasculature. Okay, the waveform has high amplitude and may show exaggerated peaks and troughs with pronounced oscillation like this. There is a sharp upstroke followed by oscillation that resembles ringing response similar to a mechanical system that is excited. I'll show the pictures. The damping system, underdamping can lead to false positive for fluid responsiveness. You think that this is, but you have to correct it. When you are seeing things such as waves, first correct it, otherwise you end up giving more fluids. So small fluctuations in volume, which might give overdamping occurs when the pulse pace is high, excessively attenuated, and the waveform flattens out. I can show you. It's not there. See, this is underdamping. This is underdamping. This is your overdamping. So anything that reduces energy in oscillating system will reduce the amplitude of oscillation. Some degree of damping is required in all systems. And factors that will cause overdamping: friction in the fluid pathway, three-way taps, bubbles and clots that we have talked about. So underdamping will show excessively high SBP and low diastolic pressure as in resonance signal. Critical damping we have talked about. So underdamping occurs when the arterial pressure is highly compliant or when there is a low resistance in the vasculature. The waveform has a high amplitude and may show exaggerated peaks and troughs like this one. There is a sharp upstroke followed by oscillation that resembles a ringing response. Underdamped system, what you will do can lead to false positive for fluid response. You are thinking that this is underdamping, then you end up giving more fluids. A small fluctuations in volume, and overdamping when the pulse excessively attenuated like this smaller one, and the waveform flattens out, becomes low amplitude and smooth. So the dichrotic notch may be less visible, like this dichrotic notch where the aortic valve is closed and the steep rise and fall of the pressure are muted. Like this is like a smaller one. The later one I showed you. Overdamping reflects a loss of pressure wave energy due to resistance, high viscosity and stiffening of the arterial walls. What are the causes of underdamping? Young patients, healthy arteries, low SBR or vasodilatation. With low blood viscosity, you will get the underdamping. It can also occur in settings with the arterial catheter is too stiff related to the vessel. This is important one when you are going to get the underdamping. When the sampling tubing is short and compliant. Short compliant, low blood viscosity, young individuals, healthy arteries, you will get the underdamping. Causes of overdamping in the elderly with arterial stiffness, high SBR is there, which occurs with aging. The younger one, you will get the underdamping, you end up giving more fluid. In the overdamping, in the elderly, atherosclerosis, sepsis or hypovolemia, increases CVP, increases SBR. Low stroke volume can also contribute to overdamping by slowing down the transmission of the pressure waves. That's why smaller waves. Overdamped IV system, damping coefficient is more than 1, can lead to false negative of excessive. What you will end up giving less fluid. Changes in pulse pressure might not be accurately reflected and leading to underestimate the need for fluid distribution. What you give up, you give less fluids in case of overdamping. In case of underdamping, you give more fluids. It can also make the intermittent systolic diastolic pressure less reliable as the waveform may be no longer follow the typical sharp systolic rise. So always you must be having idea of normal arterial waveform. Then ECG should be there. With ECG you should compare it. Okay. Critical damping is ideal state in which the arterial waveform is neither too exaggerated nor too flattened. Waveform has a well formed, smooth and clear systolic upstroke with distinct dichrotic notch. Causes of critical damping: normal, healthy and cardiovascular system with appropriate level of compliance is well. In case of overdamping, where you are finding? In case of elderly. In young patients, you are finding the underdamping. In case of overdamping, you end up giving less fluid. In case of underdamping, you end up giving more fluids. These things you should remember. So, in this state, what you do? Changes in pulse pressure variation or stroke volume variation can be used to guide fluid therapy and predict how the. That's why pulse pressure variation always is a dynamic. It's a dynamic one. Pulse pressure variation and SBB both. And the role of damping. Fluid responsiveness refer to change in cardiac output that occurs in response to, if you give fluid, if your cardiac output increases or not, you have to see. And especially in shock or hypovolemia, where appropriate fluid resuscitation can significantly improve your outcomes. So you don't have to sit down, you have to see your waveforms, give fluids, and you always look out for the whether this is over damping or under damping, always. Stroke volumetric, fluctuation in stroke volume over respiratory cycle. Dr. Yudhvir has talked. These parameters depend on degree of damping in the arterial waveform. So PPV, difference systolic pressure during inspiration and expiration. You have seen that, no? During inspiration and expiration, PPV. So under damped system, variation in pulse pressure and stroke volume may be exaggerated. We have seen that one. It was exaggerated in the younger patients, even in the absence of significant fluid responsiveness. Even patient is responding to fluid can be under damped. Small variation could result in large changes in the waveform. A small fluid you give, there is large changes. Misleading clinician thinking the patient is fluid responsive, but actually it will be under damped. So you have to be very careful. You check the waveforms, you check everything before giving fluids. Over damped system, a waveform reduced pulsatility can obscure important change in pulse pressure and stroke volume, leading clinicians to think that patient's true fluid responsiveness. You don't know. You end up giving less fluid. Actually, patient needs more fluid here. In case of elderly, the flat waveforms make it hard to detect subtle hemodynamic changes, causing underestimation of need of fluid. You don't give fluid, you can also lose your patients. Okay. Key clinical considerations: mechanical ventilations and damping. On mechanical ventilation, the positive pressure during inspiration can cause cyclic change in arterial pressure. We have seen that. And damping affects the accuracy of these fluctuations. A well-damped system will allow accurate measurement of pulse pressure and stroke volume. So PPV and SBV, for accurate measurement, you have to actually check whether the patient is under damped or over damped. You have to correct that, helping determine whether the patient will respond to fluid or not. Arterial compliance plays a crucial role in shape of pressure waveform. More the ST for the arteries, in the case of elderly, they exhibit over damping. We have talked about younger patients, they will show the under damping. In patients with poor compliance, leading to impaired detection of fluid responsiveness. In correct catheter placement, what you have to think for, where you have to put the catheter, excessive length of longer tube length should be avoided, and poor quality, so good quality tube should be used. And system should be, ask your technician to calibrate whenever it is possible. Take home message: damping of the arterial pressure waveform significantly influences. Under damping over exaggerates the waveform, leading to potential false positive, while over damping fattens the waveform, leading to false negative. Critical damping represents the ideal scenario for accurate fluid management, whereas a small change in the volume can be reliably detected, aiding in the appropriate adjustment of fluid therapy. You have to know pulse pressure, fluid responsiveness, you have to correct the damping. These are the references. Now coming to the central venous waveform, pressures. You all know, talked about this, Dr. Yudhvir also talked, right atrium of the heart pressure it measures, reflects the preload of the right ventricle. Important indicator, have to know the volume status, cardiac function, and repeatedly it has been told, nowadays we don't put the CP line for checking the monitoring to how much fluid we have to boost. We give. Other indications are there for putting the line, can be put in interjugular, subclavian, femoral, not to be talked, you all know, with a pressure transducer. We will show you how to do it. Waveform, basically it is being discussed, CEP waveform, and it has to be compared with your ECG. This is the main thing. P wave, this is R, then this is your T wave. So basically A, this is basically right atrial contraction. Here C, tricuspid valve is getting closed. This is corresponds with your R. Tricuspid valve is closing. A is your right atrial contraction. Right atrium relaxing and filling after C. This one, X is your right atrium relaxing and filling. Then V is your right atrium is full after getting relaxation. It is that is V wave. And Y is your right atrium emptying. So this you have to A, C, X, V and Y. These things you have to know, and you have to correspond. It should correspond with your ECG. This is your diastolic phase. Y. Then again it will start your A. Okay. So diastolic. This is right atrial contraction. This is your tricuspid closing, your C wave. X wave is your right atrium relaxing and filling. This you have to remember. CEP occurs just before the first heart sound. Lub, dup, dum, da. First heart sound lub. Second heart sound dup, dum, da. Third heart sound and fourth heart sound. Third and fourth heart sound not normal. Okay. though it can occur in younger individuals also, fourth sound. Occur just before the first sound during atrial contraction, represents the increase in pressure with the right atrium contracts to push blood into the right ventricle. So you should know A wave. What is A wave? Reflex atrial contraction we have talked. It can, amplitude can increase in case of tricuspid stenosis, right atrial hypertrophy, and pulmonary. If it is stiff going high, patient can have. Through this also you can recognize whether there is a tricuspid stenosis, whether there is a pulmonary hypertension, whether there is a right atrial hypertrophy. Clear? C wave follows the A wave, usually coincides with the start of the ventricular systole caused by the bulging of tricuspid valve into the right atrium. It goes up during the early phase of right ventricular systole. So C wave. C wave is typically seen as small upward deflection, often more difficult to. It can, where will it increase? In case of tricuspid regurgitation. Prominent C wave you will have. Fine. V wave, this one X, then the V wave occurs just after the C wave. During the later half of the systole, this is systolic, start with the systolic C wave, then end of systole is your V wave, where the ventricle contracts and atrium is filling with blood. Here, right atrium is full, Y, right atrium is empty. Okay? Filling with blood during ventricular systole. Because ventricle contracts, that time your atrium is getting full. The atrium experiences rising pressure as venous returns accumulates. Significance, prominent V wave suggests what will, if the V wave is significant, it could be tricuspid regurgitation, right ventricular failure, increased venous returns. Clear? You all have got significance. A wave, C wave and V wave. Okay? X descent occurs after the A wave, just before the V wave. Okay? This is A wave and just after the C wave. Here see, right atrium relaxing, this is then X wave. Okay? You have to see where it is coming. Before the V wave represents the relaxation of the right atrium during the ventricular systole, and where the atrium is expanding as the blood is being pumped into the ventricle. X descent is indicate atrial relaxation. It typically use a reference for. So you have to know why these waves are the Y descent. We have seen this, where this is Y. This is your Y descent. This one. So what do you mean by Y descent? Basically, significance is there. Rapid or pronounced Y descent can indicate of constrictive pericarditis, right sided heart failure. You have to remember, after the V wave, during early diastole, as the tricuspid valve opens and blood flows to right atrium to the right ventricle. That's why you have to check the normal CEP waveform. Normal CEP is around 2 to 6, but on ventilator, add 5, around 5 to 10, 10 to 12. Normal waveform is characterized with clearly visible A wave, C wave and V wave, and well-defined X and Y descent. You should see all these things. A smooth, non-turbulent pattern with consistent oscillation during the cardiac cycles. Abnormal CEP, elevated CEP. That's why telling you, putting the CEP line and the guiding to fluid, because it can be high, falsely high, the right heart failure, tricuspid regurgitation, right-sided, fluid overload, constrictive pericarditis or pulmonary hypertension. So it's not always reliable. Absence of a wave, if this wave is not there, atrial fibrillation could be there, A wave is not there, then complete AV block or any condition that reduces atrial. A wave is not there, it could be atrial fibrillation. Large A wave, we have talked tricuspid stenosis. Large V wave, it is tricuspid, same thing. So stenosis leading to right atrial hypertrophy, pulmonary hypertension. Large V wave, right ventricular failure. Regurgitation will, patient will go into right heart failure. Increased venous return. Flattened or dampened wave, hypovolemia, sepsis or conditions causing low venous return. But again you have to check other things. So flattened or dampened wave, mostly it is hypovolemia. So volume assessment is very important. Key parameters: high CEP says volume overload, low CEP may indicate high volume. But always high CEP can be false positive also. If the right heart failure, other things are there. You have to, or tricuspid regurgitation is there, pulmonary hypertension is there. Right heart function can be reflected for right heart, particular conditions like heart failure and tricuspid valve disease. Okay? So monitoring CEP waveform can guide fluid therapy, vasopressor use, but not always true. You have to use your echo and other things. You have to see patients clinically also. Don't use CEP monitor for guiding fluid. Thank you. क्या कर रहे हो? देखो हमने वो खत्म कर दिया. हाँ, तुम्हारा कौन सा लेना है? हाँ हाँ, करो करो. ये लो.
लंच कर रहे हैं. So moving on to next topic, we'll be discussing the fluid responsiveness in ICU patient. Okay. So how will we check the fluid responsiveness in ICU patient? So whether the patient you are receiving in the ED or in the ICU, so you are going to, patient has come with the, let's say BP of 90/40, okay, and there is tachycardia 130 heart rate, and respiratory also high, very high. So now you are going to, you are in the ED, you are attending the patient. So what is the first thing what you're doing? BP is low. So what did they suggest? They suggest the patient is in shock, something. So it may be, the patient may be in the shock. So it's not like that ki if the BP is low, the patient may be in the shock. So low BP is not a criteria for say the patient in the shock. Okay. So you have to evaluate the patient. So first time you are seeing the patient in the ED. So you start with the fluid. Okay. You given, let's say you are given the fluid. So how much fluid to give? 30 ml per kg you are giving the fluid, or 1 liter you are given the fluid. Okay. So you are given the fluid, there was a pickup in the BP, but later on the BP falls down. So now the question arises whether you are going to give the fluid further or not. Now you are not aware of the patient, whether the patient has a underlying cardiac disease or any other specific illness is there. So whether you are giving the further fluid, so it depends upon whether the patient is, the patient may be fluid responsive or not fluid responsive. Okay, let's say the patient has come with the MI or heart failure. Okay, there is heart failure, underlying heart disease, and you are giving the fluid and the patient BP doesn't pick up. So you must be aware ki how to check the fluid responsiveness in such patients. So now coming to the slide. So assessment of volume stresses and fluid displacement depend upon the optimum fluid balance. So there may be fluid depletion, maybe a patient may have in hypotension, shock, and the shock leads to organ hypoperfusion, and further it is shock persists for more than hours. It may go into the acute kidney injury. So acute kidney, and for that you give the fluid. Okay. And if you are giving the optimum fluid, the patient will improve. And if there is a inadequate fluid therapy, so it persists and further other complication can occur. Volume overload, if you are giving too much of the fluid, let's say you given 1 liter of the fluid and the ED resident was not aware, and he again will overloaded the fluid. So let's say so you are giving the fluid, okay. Let's say 1 liter you have given, then again you have 1 liter given. So maybe that patient is not able to take the fluid in the body, and there is forward output is not there. So there may be volume overload. So the volume overload is kya hota hai? It will cause impaired oxygenation. Patient may go into the pulmonary edema. Patient may, let's say patient was in failure. So patient may land up into the pulmonary edema. So and hyperperfusion hoga, then organs are congested. Okay, and So these are the complications of maybe inadequate fluid therapy and over-aggressive fluid therapy. So we have to choose a path that we should give the fluid therapy that should be optimum to the patient, and the complications should not be developed either way. So now coming to the this is the Frank-Starling curves. So what this says is that if you are giving the, let's say if there is was a underlying, if there is some, everything is normal, patient was normal, and patient come with a diarrhea or let's say hemorrhagic shock, you have given the fluid. Okay. So initially you are seeing the curve when the patient is a responder. So the Frank-Starling curve, this shows that this is a straight line almost, so linearly. So there it will respond. Okay. Oh, this time it responds finding the hypovolemia, and after it is a certain response occurs, and if you are giving more fluid, it becomes non-responders. So the curves flatten. So if this enters into this area, so no more fluid is required. If it is a normal volume patient, so if you given the fluid, there will be no response to the fluid therapy. And if it is a response to fluid therapy, there will be change in the stroke volume. This is the graph plotted between the stroke volume and the preload to assess the fluid. So if there is a change in the stroke volume, so this suggests that there is a fluid responder. Okay, and what happens is when there is a underlying cardiac disease and there is impaired or left ventricular function, and you are giving the fluid, okay, and in these such patients, the change in the stroke volume is here it is very less. Okay, if it is not in a patient of the non-responder, and further it will say as the graph the Frank-Starling curve goes, and it becomes plateau is achieved early. So the change here is also the delta change in the stroke volume is very less comparative to here. Okay. So in patient with decreased left ventricular function, or if there is impaired cardiac function, in such patient if you are going to give further fluid, so there may be not increase in the stroke volume. So you have to see whether the patient is fluid responsive or not. So that can be managed by stroke volume, SVV, or the pulse stroke volume, and the SVVR, systolic pressure variation, SPV. So these can be measured with these dynamic indices, SPV, SVV. So now coming to the septic, what happens with the septic patients? Septic patients have increased blood retention and in staged volume, lay a lot of fluid extravasate. Fluids are administered in attempt to improve the left ventricular preload. We give a lot of the fluid, and only 50% of the patient receiving fluid bolus has shown the response. In most of the study, we have found that we are giving fluid, lot of patients we are giving fluid. So in about 50% of patients are only fluid responsive. So 50 patients are not fluid responsive. In that you are giving the fluid, it will causing the cardiac load. It is adding to the cardiac load. Fluid therapy does not boost perfusion. Okay, if you are giving more fluid, so it doesn't improve the perfusion. Rather, it will decrease it will affect the patient, and the perfusion will be further decreased or impaired. Impairs lung function, produces edema. So edema will be pulmonary edema. Patient may land up into pulmonary edema. There may be bowel edema also. So it affects overall the body functions. So recent guidelines suggest assessing dynamic indices of the fluid responsiveness. So problems with the fluid responsiveness, those who are fluid responsive also fail to show clinical improvement. The 50% patients are not fluid responsive. So this is because what happens, the right arterial pressure does not linearly increase with the volume. So right arterial pressure reflects the right atrium, but it goes to right ventricle, and it does not correlate with the right ventricular pressure linearly. And also in septic patient, there is increased vascular permeability. So lot of fluid extravases. So these are the reasons. What happens? Right atrium pressure does not correlate linearly with the fluid which we are giving. Then right vascular permeability is more. So lot of extra fluid is extravasated. And third is hemodilution reduces the viscosity, thereby reducing the afterload. And further there is hemodilution, and that reduces the afterload. And also in sepsis, if there is septic patients, there is suppression of the myocardium, and that decreases the cardiac contractility. So all there were these trials were done, process trials, arise trial and promise trial. These large randomized trials were done, and this shows that less fluid administration than early goal-directed therapy resulted in the less mortality. If you are going to give less fluid administration, the outcome is better. So techniques of assessing fluid responsiveness. So there are a lot of technique to assessing the fluid responsiveness. Already we are discussing CVP is also one of the technique. So there are static parameters, static dynamic indices, and real and virtual fluid challenge. Okay. So static parameters, as we will discuss, CVP, pulmonary artery, IVP, IVC and SVV diameter का corrected flow time, right ventricular end diastolic volume, left ventricular end diastolic volume, aortic flow time, SVC and IVC variation. So these are all static parameters we are using. Now we are already coming in the conclusion that CVP and pulmonary artery, these all static parameters are not correlating with the fluid responsiveness. We have just discussed. Now coming to the dynamic indices. So here also this is the chart we already paid. In most of the study of the CVP and pulmonary CVP, the area and ROC curve is 0.5 and 0.6. So the sensitivity very poor. And dynamic indices, the various study has been done during the PPV, SPV and stroke volume variation, and plate variability index and aortic blood flow by the Doppler and the cloak. These all the sensitivity and specificity is very high, and ROC curve shows that the 0.7 to 0.8. So these show that they are better predictor of the fluid responsiveness. Real and virtual challenge such as passive leg raising and rapid fluid challenge 100 to 250 ml. So these are more sensitive than the dynamic indices with ROC of 0.9. So as already discussed static indices, we have already discussed about the CVP and pulmonary artery pressure and static ultrasonographic measurements. So these are all static indices we have already discussed in previous talk. So now coming to the topic, there was also these were also discussed by me, whether it is relevant or not. Does the central venous pressure predict fluid responsiveness? Updated meta-analysis by Paul Emerick. So these CVP doesn't predict the fluid responsiveness. So it is not recommended to use now. Already, and also the surviving sepsis guideline 2021 also doesn't recommend to use CVP as a guiding fluid therapy in patient with the shock. These are the same with flow chart or the Frank Sterling curve. These are already discussed. So these are the classification of dynamic indices. We talked about the systolic pressure variation, then the stroke volume variation, and the pulse pressure variation. So these are the classification how it is classified. Group A, cyclic variation in stroke volume and stroke volume related hemodynamic parameters by mechanical ventilation. So these are the three parameters and the aortic blood flow. In group A, group B, cyclic variation of non-stroke volume related hemodynamic parameters such as IVC indices we are using. These in group B, and group C based on the preload redistribution maneuvers, not on mechanical ventilation patients. So generally passive leg raising test is used in the non-medically ventilated patients. So in the group C, this comes the passive leg raising and Valsalva maneuver and esophageal occlusion test. So now coming to the SVV. So these are already discussed. SVV is a stroke volume maximum and stroke volume minimum by stroke volume mean over the respiratory cycle. So this is the respiratory cycle, one is respiratory phase and the expiratory phase, and then the mean of the we divide it. Normal stroke volume index is stroke volume variation index is 10 to 13%. So greater variability predicts positive response to the volume expansion. If there is more SVV is more than 30%, so it will predict that there is positive response to the volume expansion. And stroke volume variation is theoretically superior to the pulse pressure variation. Okay, and it requires a means to directly or indirectly assess the stroke volume. So these are the devices, PICO, LIDCO, and flow track and pram measures are used to measure the stroke volume variation, stroke volume variations. Pulse, now coming to the pulse pressure variation. Pulse pressure is influenced by the stroke volume, okay, and the arterial complex. So you are measuring the pulse pressure variation in the pulse device, and So it depends upon the stroke volume and the arterial compliance. So as already shown in the previous lectures, according to the pulse pressure variation, PP max minus PP minimum and then PP mean into 100. So these can be measured in the ICU setup, and these reflected in the monitor. Okay, you have to start on the monitor and you need a arterial line for the same, and then you can calibrate the arterial line and you can give the value there. So pulse pressure variation is greater than 13%. So this suggests this is the demarcating values, whether you can distinguish between responders and the non-responder. And if it is greater than 13%, so it has a sensitivity of 94% and a specificity of 96%. So PPB and these all pulse pressure variation is mostly validated in fully sedated patients. You cannot assess in the spontaneous breathing patient. So you need to sedate the patient always. All the three parameters, systolic pressure variation. So these all are used in the dynamic indices should be used with the completely sedated patients in the on complete mechanical ventilation, not on spontaneous pressure support. Likewise, put the patient on the pressure support. So it will not be validated. So these are the pulse pressure variation, how we calculate. And this, now coming to systolic pressure variation. This is systolic pressure variation. This is the same SP max, SP minimum, SP. First index to be recognized to the correlate with the hypovolemia. This was the first index to recognize better correlation with the hypovolemia. Okay, so this is the way we calculate. In mechanically ventilated patient, normal systolic pressure variation is 7 to 10 millimeter of mercury, with delta up being 2 to 4 millimeter mercury and delta down being 5 to 6 millimeter of mercury. So hypovolemia causes dramatic increase in the systolic pressure variation, particularly in a down position. And delta down better indicator of, so this down has a better indicator of the fluid responsiveness or volume responsiveness is patient with volume responsiveness. And delta down reflects the expiratory decrease in the left ventricle volume, and related to expiratory decrease in the right, and stroke volume is related to the expiratory decrease in the right ventricle. So this down up stroke is mostly related to the volume responsiveness in the hypovolemia. These all parameters are reliable in. So what we are discussing, SBB, SPV, okay, and PPV. So these all parameters are unreliable when the patient is spontaneously breathing. Okay, so you need to sedate the patients, and if there is arrhythmias, okay, and poor lung compliance, like in the ARDS also. So for ARDS, you are using a low tidal volume, so it becomes very low tidal volume. So in that it is these tests are not reliable. Poor lung compliance, the smaller tidal volume which he has already mentioned, poor lung compliance, and heart rate, respiratory rate ratio is 3.6. Open chest, if there is a raised intra-abdominal pressure, or the patient has a right heart failure. Now coming to the other index, that is pleth variability index. So pleth variability index measures the perfusion. This is basically a perfusion index. PVI is a measurement derived from the pulse oximetry device that assesses the variability in the perfusion index over the respiratory cycles. So this is measured basically in the, there is variation in the pulse. So according to that pulse-wide blood flow, we calculate the this pleth variability index in the over the respiratory cycle. So it is the ratio of the pulse-wide blood flow to the non-pulsatile blood flow in a peripheral tissue over a complete over a respiratory cycle. So what is the value? How it calculated? Pleth variability index. It is 100 maximum amplitude minimum amplitude, then maximum amplitude plus minimum amplitude average. Mean value is taken. Primarily used as a non-invasive indicator to predict fluid responsiveness in patient, in particular that is same patients. It can be used. Now how much is the indices? Pleth variability index greater than 30% indicative of fluid responsiveness. Lower PVI less than 30% indicates lower variability, suggesting that additional fluid may not be significantly increase the cardiac output. Okay. However, poor agreement between the PVI and PVI. So pulse pressure variation and plate variability index, they are not correlating. Okay. So it cannot be predicted that PPV is greater than 13% and PVI also greater than 30%. So it is poorly correlating. Okay. And so now coming to the respiratory variability of the superior vena cava and inferior vena cava. This is also measured for the dynamic indices. Okay. But these has a better predictor as already shown in the ROC curves around 0.9. Okay. So sensitivity of 90% and specificity of 100%. So value greater than 36% discriminates between responder and non-responder. If it is value is coming greater than 36%, so it suggests that the patient is fluid responsive. And SPC cholesterol index requires esophageal Doppler placement. Sir, you have to use the TT, transesophageal TE for measurement. Now, commonly used is the distensibility index or the collapsibility index in the ICU in a spontaneous patient. So this is the most commonly you are using. You are using in the ICU distensibility index. You measure the patient in the patient come in the ICU and it is intubated. Okay, then you are measuring the distensibility index because we are giving the positive pressure. Since we are giving the positive pressure, so that's why it becomes the distensibility because you are giving the positive pressure to the chest, intrathoracic pressure. Okay, the intrathoracic pressure will become more positive. So IVC diameter is a modern day CVP monitor. Nowadays we are not using at all CVP monitoring. Now mostly in the bedside focus it is used with the CVP monitor. Is the modern day CVP monitoring. You could take a probe, curvilinear probe, you place the IVC and you check the IVC distensibility index. So you check the IVC diameter, whether it is more than 2 centimeter or not.
Basically, distensibility index is more important when the patient is ventilated, on ventilator. Collapsibility index when the patient is spontaneously ventilating. More than 80% is suggestive of fluid responsiveness. So whenever you are in doubt, forget about the CVP, always remember your clinical parameters and your TT. Fine?
So it is either the maximum diameter by the minimum diameter in the ultrasound you can go and see it. So now the AI based ultrasounds are there, they automatically detect the maximum and minimum also diameter. So either you measure the M mode and take the maximum diameter and then minimum diameter and take divided by D minimum diameter and give the distensibility index. It is explained as a percentage and predictive fluid responsiveness. If it is greater than 18%, you suggest that the patient is fluid responsive, you can give the fluid. Okay. And if it is less than 18, then you are not going to give the fluid to the patient. No single cutoff value to discriminate between the fluid responsiveness and non-fluid responsiveness. There is range 12 to 18% somebody is predicting. So there is no single cutoff value. Better detection of fluid responsiveness than the IVCD diameter. Some also using what in the ICU we also measure the simple the IVC diameter. So if the IVC diameter is full, it shows that maybe patient may not, but it is not a better indicator. It is better to calculate the distensibility index. So but it can vary. Inter-observer reliability in any ultrasound measurements, it depends upon your observation and your recording. So it is based on the inter-observer reliability. Okay, how much accurately you are measuring the IVCD diameter. So now coming to the article, value of variation index of inferior vena cava in predicting the fluid responsiveness in patient with circulatory shock receiving mechanical ventilation and meta-analysis. So this was the study to analyze whether IVC can predict the fluid responsiveness or not. So in this study, six meta-analysis, 603 patients were concluded in this review, and the study finds that the overall the area under curve was 0.82. So the finding of the study suggests that the distensibility index moderately predict the fluid responsiveness patient with a circulatory shock which are receiving the mechanical ventilation. Okay, so the area under curve where meta-analysis found that the area under curve was 0.82 with in this study. So it is moderately predicting the fluid responsiveness. So you can use the IVC index. Now coming to the other study, accuracy of ultrasonographic measurements in inferior vena cava to determine the fluid responsiveness. This study was also a systemic review and meta-analysis. So in this study, what we find is that the ultrasound evaluation of the diameter of the IVC and its respective variation does not seem to be reliable method to predict the fluid responsiveness. So that study was suggesting that the area under a curve was 0.8 and moderately suggesting that the IVC can be used to predict the fluid responsiveness of the moderate. In this study, it suggests that it is not very reliable to predict the fluid responsiveness because in this the area sensitivity and specificity were 0.7 only. So there was another meta-analysis by a little long, and this meta-analysis suggested that the respective variation in IVC diameter has limited ability to predict fluid responsiveness, particularly in spontaneously ventilating patients. So, but a negative test cannot be used to rule out the fluid responsiveness. So one study was suggesting that 0.8 was moderately sensitive to predict the fluid responsiveness, but other two meta-analyses suggest negative. When using the here it is written. So now coming to the passive leg raising test, and this was the most sensitive test that you use. Covers a part of unstayed blood volume. What happens in the passive blood raising? You are giving the blood volume that is inside the body and just raising that, and unstayed blood volume to a staged volume. So PLR acts like a reversible and short-lived safe fluid challenge test. Okay. Effects observed over the several cardiac and respiratory cycles, basically done for observed for several cardiac and respiratory cycles when we are performed, remains a good predictor in non-intubated arrhythmia patients, mostly done in the spontaneously breathing patients. SEMI recommend blood from the lower limb and splanchnic circulation. Amount of blood transfer between is around 150 to 70 ml of blood is displaced. Okay, and in this real-time measurement track changes over the 60 to 90 seconds we measure it, and effect reverse completely when the patient is made supine. When you may make the patient supine, so the effect will be reversed immediately. So it is a passive test that we can use to assess the fluid responsiveness in breathing spontaneously patient. So this is the way to do. So this is the way to do the PLR test. So what is the limitation of the PLR? Say effect cannot be assessed by observing the arterial pressure. Okay, PLR induces change in the pulse pressure, less accurate changes in the cardiac output than in stroke volume. Okay, so the changes is reflected in the pulse pressure, not in the cardiac output and stroke volume. Cannot be used where patient immobilization is not possible, allowed, like operating room, head injury, pelvic fracture, and stable spine. So it has a limitation. The patient is injured, head injury and OT operation, so you cannot use. In case of, if there is increased abdominal intra-abdominal pressure, so false negative results can occur. So this is the study by the predicting fluid responsiveness by passive leg raising test. पहले वो करना है क्या? Inauguration खत्म ही है. Just like.
Probably they want to inaugurate, so we will start again from this slide. So whatever will be again discussed.
किशोर कहाँ गया? युद्धवीर कहाँ गया? अरे आओ ना। हाँ बैठो। सर को एक माइक दिया जाए। कहाँ गया ऑडियो विजुअल?
Hello, good afternoon to all of you. This is workshop for hemodynamic monitoring and simulation for different conditions. We are organizing two workshops on the occasion of BAPICON that is been conducted by Darbhanga IAP branch. I would first like to introduce the dignitaries who have come from Delhi and other cities to conduct this workshop. Dr. Simant Kumar Jha is consultant critical care expert from PSRI Delhi. Dr. Rakesh Garg, sir is editor of Indian Journal of Anesthesia and professor in AIMS Delhi. Dr. Kishore Jhunjhunwala is Director Critical Care in Medanta, Patna. Dr. Yudhvir Singh is Associate Professor in AIMS Delhi. They are all very learned persons. And Namita is from AIMS. Smita is from AIMS Delhi. They have taken a lot pain to come here. They eventually reached at around 1 a.m. in the night, and they are here from 9 o'clock. So I will request them to inaugurate this workshop. Sir, please come and light the lamp. Ma'am. हाँ सर माचिस लो. हाँ. And this workshop will be inaugurated by our respected Principal Sir, Dr. K.N. Mishra Sir, and Ma'am, Superintendent Ma'am, Dr. Alka Jha Ma'am. राजेश और संजय असिस्ट करो भाई. जला लेने के बाद फोटो खींच लेना. हाँ ठीक है. हाँ फोटो ये 2 मिनट से 2 मिनट से. लाओ इधर लाओ दो. हाँ प्रिंसिपल. I will request our principal sir, Dr. K.N. Mishra sir, to give a bouquet to all of the trainers from different places, sir. Garg sir. Simant. Kishore. Udvir. पीछे हट जाओ, पीछे हट जाओ, पीछे। स्मिता, हाँ मैडम को लिए दूसरा चीज है। हाँ हाँ हाँ, एक ही लाओ ना, पहले एक लाओ ना, एक लाओ ना। हाँ 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 सर, निकालो साड़ी, निकालो साड़ी निकालो। I will request our superintendent ma'am to give a traditional paintings of sari painting for all of them. तुम निकाल के दो ना, तुम निकाल, रखो ना, ये निकाल के दो ना, ये निकाल के दो ना, ये निकाल के दो ना। Udvir, please. Kishore. Smita. Smita. Sanjay, please come. Painting. And now I will request organizing chairman Dr. Yusi Jha sir to give a Mithila painting to all of them. Siman. Udvir, please. Kishore. Smita. Sanjay. हो गया? अब हम लोग सर्टिफिकेट बाद में देंगे। Thank you, thank you. Now you can proceed to your hall.
कोशिश कर रहे हो सर्टिफिकेट निकालने की और अपने हाथ से आप सर्टिफिकेट सबको दे दो, दे दे। There is lunch break for 30 minutes. You can take lunch. After that, session will continue. Okay?
साले इरिटेट कर देता है, पागल जैसा है सही, दोनों वैसे ही हैं, दोनों ऐसे नहीं है, कार्टून है दोनों।
न्यूज़ वैनिंग में खाली तुम्हारा ही है।
आवाज़ आ रही है? हाँ लगा लिए।
न्यूज़ वैनिंग में और कोई नहीं। हम लोग में गया था कुछ लोग, लेकिन चला गया था ना सब छिटकू छोटा वाला छोटी करते थे हम लोग उड़ना।
हाँ देखिए आपको पेन ड्राइव हो गई है, इसको मिनिमाइज करके इसको एस्केप कर दीजिए, आप देख लीजिए फिर हम स्टार्ट करेंगे। पेन ड्राइव खोलोगे ये सारा नहीं खोली नहीं खोली। हाँ ये वाला ये खत्म। हाँ नहीं है, दिखा तो कर दो अपने हेमोडायनामिक मोमेंट में डाला हुआ है। निकाल दीजिए, हम भी सारा निकाल देते हैं तब तक। फिर हाँ ठीक है ठीक है। दिखा तो दिया कितना बार, बहुत बार दिखा दिया है। start करें. So we are starting. So we are discussing the fluid responsiveness in the ICU patient. So we are discussing regarding the CVP, okay, then PPB, SPB, and SBB. Now we are discussing the passive leg raising test. So there was a study. This is a systemic review and meta-analysis. Okay, regarding the passive leg raising test for checking the predictive fluid responsiveness in the critically ill patient. Okay, so this study is done in the spontaneous patient. This can be done in the spontaneous patient, not on mechanically ventilated patient. SPB, SBB, PPB. These three are done in the mechanically ventilated patient with the requisite of you have a arterial line. You need a arterial line to connect, and these come on the monitor. You have to select the parameters on the monitor, and you connect the arterial line. Then it will be reflected on the monitor, and according to the values you see in the monitor, you will give the fluid to the patient. So these were the predicting fluid responsive by the passive leg raising. So there was a systemic review and meta-analysis. It included a lot of 100,000 patients. So these were the analysis in 1,000 patients. So in this, what we find is that the analysis demonstrates a pooled sensitivity of 86% and a specificity of 92%, and a summary area under the curve ROC is 0.95. So much of sensitivity and specificity and ROC of 0.9. So this suggests that the passive leg raising test, which is done for the predicting fluid responses, is highly sensitive and specific. Okay, so this test specifically suggests that you can use to check the responsiveness, but it should be done in the spontaneously breathing patient only, and the patients which can raise the leg. Okay. So the conclusion was that it is a highly diagnostic performance for check the fluid responsiveness. Now coming to the other test is the mini fluid challenge. Classical fluid challenge, we give 300 to 500 ml of fluid, and it may what happens sometimes happens that you are seeing the patients, you don't want to give that much of fluid, you are thinking that patient may be overloaded, but you want to still go to the fluid challenge test. So you can give 100 ml of fluid administered over 1 minute and effect the changes. So what changes you will see? So you will change the stroke volume changes. So that is measured by the aortic VTI. So it is done in the aortic chamber, and there the VTI is velocity time is checked through the transesophageal TTE probe. Transthoracic, okay, and an increase in the VTI, okay, of 10% predicts the fluid responsiveness. So you can, if there is an increase in the VTI of 10%, so you can check the fluid responsiveness. So this can be done with the ultrasonic USG machine through this. And a small volume unlikely to induce the fluid overload. So the advantage that if you are administering very small volume, and so if you're thinking the patient is already fluid overload and you want to check for the fluid challenge, so these tests can be used. Because okay. In tidal CO2 also there is other thing. There is change in the in tidal CO2 of 3% with the mini fluid challenge. Predicted fluid responsiveness with 33.3 sensitivity and 93.4 of the specificity. And if you can also observe the end tidal CO2 changes with the mini fluid challenge. Okay, but the sensitivity is only 33.3% and 93.4% specificity. Or coming to the end expiratory occlusion test. So these are this is the test done at the end of the expiratory phase. You are patient is intubated and you want to check the patient for this is the other method for fluid challenge test. Okay, and so during mechanical ventilation, each insufflation increases. What happens when you are giving mechanical ventilation? We are giving positive pressure. So you are giving positive pressure, it will increase the intrathoracic pressure. So intrathoracic pressure increases. So what it causes? Intrathoracic pressure बढ़ गया. So what happens? Venous return will decrease. Okay. Ultimately, the physiology is like that. in any patients the physiology. So all the parameters which you are observing, systolic, stroke volume variation, pulse pressure variation, or systolic pressure variation, these all parameters depend upon the intrathoracic pressure. You are giving positive pressure, the intrathoracic pressure will increase, so there will be affected, or it will affect these all parameters, dynamic indices. So interrupting the respiratory cycle at end expiration inhibits the cycling impediment in the respiratory. So what is done in this test, that you are measuring at the end of the expiration. So at the end of expiration it equilibrates with almost around the, so at that time the pressure is more positive, okay, maximum positive. So at that time 15-second end expiratory occlusion test is done to increase the arterial pressure or cardiac output by 5%. So you have to see, you have to occlude the for 15 seconds you have to occlude the end expiratory at the end of the end expiratory, and then you see whether the changes in the cardiac output by 5% or arterial pulse pressure changes. Okay. So you can you see the cardiac output changes by the stroke volume index, okay, or by the echo. So sensitivity of 87% and specificity of 100%. So the area under curve is 0.95. So these two tests are very passive leg resisting test and end expiratory occlusion test. So these are really highly sensitive and specific for fluid response. Hemodynamic effects observed over several cardiac cycles, hence it remains valuable even in cardiac arrhythmia. So all the tests, PPV, SPV and PPV, these tests has a different, give inaccurate values in arrhythmias patient. Okay, there was limitation for that also. So in arrhythmias, if the patient has arrhythmias, it has a limitations in such scenario. But these tests is even valuable in cardiac arrhythmias. Can be used in patient with spontaneous breathing activity. Limitation is a continuous monitoring required to demonstrate effects, because it cannot be done many of the times. You have to occlude at the end of the expiratory phase. So this can be performed continuously. This is just a meta-analysis of reliability of end occlusion test and mini fluid challenge test. So the studies was examining, this meta-analysis was conducted in 21 studies. Okay, the pooled area under ROC curve for end expiratory occlusion test was 0.96, and the pool sensitivity and specificity were 0.86, and pool area under ROC curve was 0.91, and also the specificity under mini fluid challenge was 0.82 and 0.83. So these suggest that it predicts the fluid responsiveness. Now coming to the respiratory systolic variation, this is another test to analyze the variation in systolic blood pressure during the respiratory cycle. It is very minimally invasive. It utilizes the standard arterial lines, arterial waveform. We analyze the arterial waveform. These all are devised in a monitor. You have to only correct the arterial lines, and you have to select these tests if the monitor is enabled of these tests. High variation greater than 12 to 15%. If there is high variation, it suggests that the patient is likely to be fluid responsive. If there is more than 12 to 15% of variation in respiratory systolic variation test, and low variation less than 12%, it is not sensitive of fluid administration. So respiratory cycles, it is observed over the progressive increase in the pressure of 10, 20, 30 centimeter of water. We increase the value compared with the corresponding minimum invasive systolic pressure. We draw a slope between the first and the third cycle of respiratory phase, and these are how we do the test. And the main important is that area under curve is 0.96. So this test is also highly sensitive for fluid challenge. So this is the minimum value of systolic blood pressure, and the maximum and minimum. So these three minimum values are taken. So the change in stroke volume induced by lung recruitment maneuver predict fluid responses in mechanically ventilated patient in the operating room. So stroke volume indexes. So the author says that the magnitude of stroke volume decreased during the lung recruitment. When we perform lung recruitment maneuvers in the ICU. So the study is whether whatever lung recruitment maneuver we are performing in the ICU, whether it can predict the fluid responsiveness in mechanically ventilated patient in operating room or not. So lung recruitment कैसे करते? We increase the PEEP or we take on a hand and ventilate it. So we can increase the PEEP and we can check it do the recruitment. So in this study suggests that the area under curve of it was 30% decrease in stroke volume during lung recruitment maneuver, predicted fluid responsiveness with a sensitivity of 88% and specificity of 92%. So this was also very this test was also very predictive of fluid responsiveness. So there was another study, fluid challenge in intensive care. Phoenix study was done. This was around 2,000 patients, and these fluid challenge, what 500 ml of fluid challenge was given. The main indication of this in the patient was hypotension. Was in 59% of all patients was hypotension. So the 43% case में no hemodynamic marker was used. Okay, so what we do, fluid challenge 500 ml दिया गया, then and the main indication of these patient was hypotension. In 43% what we see, the no hemodynamic marker was used. Okay, and 43% में no hemodynamic marker was used. Static marker use किया हमने 36%. Means static marker means क्या, CVP or pulmonary artery catheter or other rest. And dynamic marker PPV, SPV and SVV using 22%. So what we observed is no safety variable for fluid channel was used for 72% on 72%. No statistically significant difference in patient who received further fluids. This was irrespective of the results of any testing fluid responsiveness. So this study suggests that there was no statistical difference in patient who received further fluids. So fluid response spontaneously breathing with systemic review. So there was another study which was systemic review was done, and this study also suggested that fluid response in this study also said that our systemic review indicates that regardless of the limitation of each maneuver, fluid response can be assessed in a spontaneously breathing patient. In this the test was a stroke volume or cardiac index was used, considered for the fluid responsiveness. So these can be also used in a spontaneous stroke volume index can be also used in the fluid to assess the fluid responsiveness in spontaneously breathing patient. But the area under this was the pulse pressure variation during the pulse warm was 52%, and passive leg raising induced change in stroke volume index was greater than 30%, showing the highest accuracy to predict the fluid responsiveness in a spontaneously breathing patient. So this also says that the PPV and the passive leg raising were more sensitive in the PPV, and passive leg raising test was more sensitive in the patient if the patient was spontaneously breathing. So this much is the topic for the fluid responsiveness. So to summarize, it is that you have to use the wave to summarize. So for checking the fluid responsiveness of the ICU,
I think your voice does नहीं चला है.
not to use the CVP. छोटा सा you better use the dynamic marker, and to bedside you can use the IVC for assessment of fluid, and if it is possible you can go for the passive leg raising and so, and you have to use all the clinical markers and other findings you can use. Whatever the instructions you have level, you can use different parameters to assess the fluid responsiveness.
So next speaker is Dr. Kishore Jhunjhunwala, Director Critical Care in Medanta Hospital, Patna. He is going to talk about methods of monitoring cardiac output and overview, minimally invasive and non-invasive.
Okay, thank you. So before going for my lecture, I just want to recapitulate since morning what we learned. A lot of discussion done by Dr. Yudhaveer, Dr. Simant Jha, and we know this is a very complex topic today what we are discussing, and maybe most of the tools you and still at so many at good centers is not available, but it's very important to know, to have awareness about what the tool, what the gadgets, how we are going to monitor, because we are living in an era of precision medicine. And let me just 1 second, where it is. So we are living in an era of precision medicine, and ये आपका पहले ये नहीं आ रहा है, जरा सा हेल्प करें। ये आया नहीं, ऐसे करेंगे तब आएगा कि आपका क्लोज नहीं हुआ? नहीं, ये हाँ आ गया, यस। So, so we are living in an era of precision medicine, and we just want to get more and more information. Why this? What the purpose of this workshop, and why you people all are here? Because you want to manage your patient in a better way. Whenever you are managing your patient, we want more and more information. So you want more information. So many times you are stuck when you are resuscitating your patient in emergency or in ICU setting, or when you are going to moving towards the maintenance, or when you are switching from maintenance to you want to de-escalate the treatment. Yeah. So during entire course of patient management, you want information and real-time information. You can't wait. Ki this information you will get after a 2-hour, 3-hour report, or you are going to manage. The ultimate aim is what? Ultimate aim of hemodynamic is what? Number one, please, since morning what you learned, please participate. Why you are doing the hemodynamic monitoring? Yeah, great. Real time, continuous. You want to see the organ perfusion, whether your organ is perfused or not. Next. One is organ perfusion, what is happening at the microcirculation level. You want to know at the tissue level, so many parameters. So what is your oxygen delivery, what is your, how the this oxygen is utilizing, what is circulation at the microcirculation level, at the cellular level, and where you are going to keep the hemodynamics appropriate for that person, appropriate for the individual. What MAP is appropriate for your individual that you want, what blood pressure you want to target, what hemodynamics you want to target. These are the purpose, and you know, because of all the clinical parameters, like we have the stethoscope. Can we wait till patient become wet? If you are resuscitating and you want to wet your lung so that the patient started desaturating, no, you want to stop it before. So you need a continuous monitoring. That's the entire purpose you people are here. So before going, why this is a complex topic? Because so many new terms you learn, like pulse pressure variation, stroke volume variations, what is the cardiac output, what are the different, what is the PSE, what is invasive, what is minimal invasive, what is the Frank-Starling curve. Whenever you are going to home, keep one picture in your mind, which we learned in the first year of your medical education, first year of MBBS, is about Frank-Starling curve. Don't forget that Frank-Starling curve. You forget each and every tool, whatever we learned today. But if you remember that Frank-Starling curve, which Dr. Yaduvir has taken a long lecture on that. If you remember that Frank-Starling curve, this will fulfill all your queries and all, because you want where you are. You are at the initial phase of the Frank-Starling curve, where you are giving the fluid and getting a bigger response, or you are at the top where you don't want to give the fluid and your lung become wet. So where you are, always give a question whenever you are resuscitating patient. Okay, the fluid, keep that. Fluid is also a medicine. Whenever you are resuscitating the fluid, this medicine, whether I am using it the overdose or underdose. Because this monitoring is very important. If you keep the patient underfilled, what will happen? You will get the AKI, end organ damage. If you overfilled, has a consequences that already we discussed. So we want that optimum. You don't want to underfill and don't want to overfill. And meanwhile, the entire exercise is to preserve the organ. So whatever, this always remember this Frank-Starling curve in your mind. So my question to you, what is the very basic question about the Frank-Starling? Now come to the, what is the cardiac output? So stroke volume multiplied by the heart rate. What is stroke volume? during each beat. Heart is pumping on each beat. That's all, very simple. Don't go with the formula. Anna, what the ventricle pump with the each beat is a stroke volume, and during the entire 1 minute, what the blood volume is coming out from the heart is cardiac output. Very simple. The first year of your medical school, nothing more. So this is very simple, cardiac output, Anna. And you know cardiac output depend upon what? Preload, afterload. Preload means you want to give the fluid. For that, the fluid responsiveness, the entire exercise was there. How much you want to give the preload? If there is hypovolemic, you want to increase the preload. And afterload depends upon, yeah, peripheral vascular resistance and also systemic vascular resistance. So how you know what is the peripheral vascular resistance of your patient? फर्स्ट ईयर में पढ़ तो लिया हमने, लेकिन कैसे पीवीआर जानेंगे, कैसे एसवीआर जानेंगे, है ना? कोई तो टूल होगा, नहीं तो हम तो पढ़ते आए कि एसवीआर पीवीआर होना चाहिए, लेकिन हाउ वी नो दैट व्हाट इज द पीवीआर ऑफ माय पेशेंट, व्हाट इज द एसवीआर ऑफ माय पेशेंट, व्हाट इज द प्रीलोड ऑफ माय पेशेंट? ये कर्व तो पता है, लेकिन कर्व में फ्रैंक हम कहां हैं? तो वी नीड अ टूल, वी नीड अ मोर एंड मोर इंफॉर्मेशन. सो हमारे पास था, टूल थे, स्टेथोस्कोप था, हमारे पास कैपिलरी रिफिल टाइम था, हमारे पास स्किन की मॉडलिंग थी. दिस ऑल टंग का ड्राइनेस देख रहे थे, यूरिन आउटपुट मेजर कर रहे थे. अर्लियर सीबीपी था, जो डॉक्टर साहब ने बताया कि सीबीपी इज अ स्टैटिक मेजर, नॉट द डायनेमिक, नॉट चेंजेस विद द टाइम एंड डिपेंड्स अपॉन सो मेनी थिंग्स. सो वी नीड अ टूल, वी नीड अ टूल बिकॉज नाउ वी आर इन द 21st सेंचुरी में हम लोग जी रहे हैं. वी कैनॉट रिलाई ऑन द टूल ऑफ लास्ट 200 years back. It was the precision medicine. That's why the entire theories, entire complex things you are learning. So I am talking about the minimally invasive and non-invasive cardiac output monitoring. So the gold standard for cardiac output monitoring is what? What is the gold standard? Thermodilution. Very good. So इतना सारा सब जान ही रहे हैं. And the name of that tool, thermodilution, is the technique. What is the name of that tool? Yes? Yes, please participate. नहीं तो पोस्ट लंच खाने के बाद नींद आएगी. हाँ? मैं तो अपना नींद भगा रहा हूँ आपके साथ. Yes, excellent, good. इधर से कोई जवाब नहीं दे रहा भाई. ऐसा टीम डिवाइडेड है क्या? That is the PAC, है ना? Pulmonary artery catheter. And that we discussed during the entire course. The PA is no more we are using because of Dr. Simant told us कि due to the chances of more invasive, infection rate, and technically difficulty in inserting that PA catheter. So PA catheter is little obsolete. So what we are using are the different minimal invasive, and we are switching toward the non-invasive techniques of the cardiac output monitoring. So they are the tool like esophageal Doppler. I will touch all these names. I am not going to detail of all these things because this is again going to mug up because you are using this esophageal Doppler or not. But you must be aware about the esophageal Doppler, your echocardiography, thoracic bioimpedance. That these terms are coming often with you, like partial CO2 rebreathing and the pulse contour analysis. I will come to the pulse contour analysis. Most often we are using the pulse contour analysis, and for you is very important to know about the echocardiography. And simple what you are doing is in a day-to-day practice is intra-arterial BP monitoring. My friend Dr. Shyam is here. He told he is using and demonstrated to you people about the how you are inserting the intra-arterial line in your institution. So wherein you have the echocardiography tool, the best tool is available bedside, and you have the intra-arterial line at least, and you can monitor with this tool, and you can tailor your treatment according to the need of a patient. So before coming, this is a theory regarding the transpulmonary thermodilution cardiac output technique. This is transpulmonary thermodilution, and PA catheter is also thermodilution. There is a little gap because this is a minimally invasive, where we are using minimally invasive because we need one central venous line and one arterial line, probably in a femoral artery or anywhere, but the one is the CVP line, one is the arterial line, and we are using either your hot or cold saline temperature or guided by the lithium. So we can use that. Why this is the thermodilution, and we are saying that the transpulmonary. because blood is crossing from the to the heart, crossing to the lung, and we are measuring. And these the machine and gadgets are there that are analyzing this theory and making you a graph and giving the result like cardiac output, stroke volume, and all measurements. So this is the transpulmonary thermodilution cardiac output. This is the minimally invasive technique. We are so what we are in this you are using, we are using this ice cold saline injected through the CVP line, while changes of temperature is measured in the large peripheral artery like femoral, axillary or brachial via special arterial catheter equipped with a thermistor. जो वहाँ पे एक thermistor है, and we inserted the cold will travel, the thermistor is changed, we are recording the change in the temperature, and accordingly this extrapolated in a graph by the machine, and we are calculating the cardiac output and all different parameters. So respiratory efforts on the stroke volumes are average and albino, where they are trying, because they are crossing to the lung, thoracic cavity, we are the machine trying to eliminate this thing. That's why some machines are coming with the calibrated and non-calibrated machines are there. But this is all about the gadgets, and different companies have a different gadgets, but basic theories of is like this. So transpulmonary thermodilation cardiac output, the availability and reliability of any machine whenever you are using, so comparable to the, because of the gold standard, that PA catheter. So this can also measure this EVL. This is very important, EVLW. This is extravascular lung water. This machine will give you what is the EVLW. If EVLW is high, it suggests that the lung is getting wet, the pulmonary edema is there. So you can stop prior to that. Will stop your resuscitation. You can tailor your treatment according to the EVLW. So you don't need to stethoscope. Stethoscope will only say once the lung becomes wet. जब आपको क्रेप्स मिलेगा तभी आप स्थित बताएगा. Prior to that, you will get with this tool. So we also measure the global end diastolic volume, intrathoracic blood volume, and cardiac function index. We can so many things we can get. This machine will tell you. So what the basic funda? See, the bolus you are injected, the bolus is circulating through the lung, going back again to the heart, and during the there is a, I already explained you, there is a thermistor is available on the radial artery, and during that entire journey of this bolus injection, this extrapolated over temperature and time will get the curve, and accordingly will calculate, and the machine will calculate all the parameters. Now coming to the esophageal Doppler, I will come again to this TPDD, transpulmonary जो thermodilution है, again I will come in the last few slides. So just to comparing with the PSC, this TPTD is there. Now coming to the esophageal Doppler, already sir explained. Esophageal Doppler means esophagus, Doppler means what the ultrasound. We can use the trans-esophageal echocardiography, or this is a tool. This is again a very important tool, because we know the cardiac output is crossing through the descending aorta. There is a descending aorta, 70% of the cardiac out कितना जाता है? Cardiac output from descending aorta is, descending aorta में कितना जाता है? 70% है ना? Around 70% of cardiac output is traveling through the descending aorta. Rest is going to the up. So 70% of cardiac output जब cross कर रहा है through the descending aorta, if put a probe from esophagus on above the, we see the descending aorta, and we can calculate, the machine will calculate the velocity, what are the velocity, how the time is passing, accordingly this extrapolate what is the flow there, and accordingly the with the this esophageal Doppler we able to calculate the cardiac output and other parameter. So this is the esophageal, about the esophageal Doppler. Then the then velocity of blood in descending thoracic aorta is plotted against time, and this machine will calculate, or will know what is the flow time and all. So this is already explained. The esophageal Doppler, same, we'll get it, the parameter is FTC, systolic flow time, corrected for heart rate, and if it is low, we are sending the low cardiac output status, if it is high cardiac, accordingly we can calculate. So this is the machine, have seen, this esophageal Doppler machine. Again, this is a minimal invasive because we are inserting using the going to the esophagus. So next, coming to the echocardiography, I am taking only 2 slides on echocardiography because Dr. My next team member will take care of the echocardiography in a shock. We'll understand how this this tool is helpful in understanding the your patients. And we also organized one bedside training where everyone expecting to show it like IVC, SVC it was not possible, but IVC collapsibility, cardiac chamber, or VTI, and sir will also explain each and everything on a bedside. Utilize those time during there. Machine is ready. Machine is ready. Volunteer Dr. Sam will arrange. So echocardiography is a powerful tool to diagnose and assess cardiac function perioperatively or during your as a point of care ultrasound also. So there are 2 things what we are using. One is TTE, that is transthoracic echocardiography. Another is transesophageal echocardiography. This TE basically people are using it during the in a operative inside the OT. But TT is anywhere, either in emergency, either in ICU, either in a OT, anywhere. Regarding the TTOT is very important when you are, because we are talking about the cardiac output, very easy to tool. There are various way, Simpson method, there are various way we can calculate the cardiac output, but this is only one thing which I want to explain here is about the LVOT. That is full form of LVOT. Oh, you are all aware of it. Oh, great. So this is the LVOT, and here we are calculating this diameter, and accordingly sir will explain how you are going to learn with this cardiac output measurement through this or fluid responsiveness with this LVOT. Next is your TE. T is transesophageal. Again, the picture is the same. Which picture is this? Which view is this? Come to this. Which view is this? Yes, parasternal long axis. Excellent. Yeah, they know each and everything. So new learnings are, ये बेसिक तो सब पता है आपको, तो न्यू लर्निंग्स तो आसानी से आप कर जाएंगे, तब तो ज्यादा आपके लिए नहीं हुआ है. PPV, SVV, all are easy then. So this is again is very important. This is again important as Dr. Yudhavir is saying. Yudhavir, sorry, is about the VTI. This is velocity time integral. What we are seeing, the just put a probe, make it a diagram, machine will calculate about the VTI. VTI is very important. VTI you can do it here, and VTI also you can easily way में you can see it at your carotid artery level also. So transthoracic echocardiography again is a non-invasive, small learning curve, you can easily learn. This is a point of care available everywhere, but little difficulty with the TE. T is also very accurate when you are managing a shock patient, particularly inside the OT. So, so there is a limitation. Limitation क्या है? Not continuous, man-made. There is a variation, है ना? Each time you have to put the probe. You cannot see it around the clock. In the night, if you are not here, your residents, है ना? Everyone has some. कोई कहेगा 25% EF है, कोई कहेगा 30% EF है, कोई कहेगा 40% EF है. But reproducible नहीं है. But other parameters which are saying that more reproducible, more accurate. But it's still the best available tool on the bedside. So coming to the next slide, thoracic bioimpedance. This is another way. What happens in thoracic bioimpedance? We are generating the electric impulse, and according to the electric impulse and the thoracic blood flow, they are calculating, machine is calculating with this impedance about the cardiac output. Another parameter is based on change on electrical impedance of the thoracic cavity occurring with the ejection of blood during cardiac systole. Technique impedance cardiography relies on measured change in signal amplitude of a transmitted electrical current via 4 electrodes placed on the neck and the thorax. This is like that. The electrodes are placed they are generating the electrical current, and according to that impedance with the sensor, they are analyzing. They are the different formula by that they are utilizing, the machine utilizing, and according to that they are calculating the parameters. So this is a toric bioimpedance. The validity studies are there, है so different there are validity studies are there. So overall bioimpedance seems to be unreliable method of absolute cardiac output measurement in the ICU. Still a lot of challenges are there with this, but still are evolving this bioimpedance, the different gadgets utilized for the different subset of patients. So you must aware about these kind of tools are available. Another tool is a partial carbon dioxide rebreathing. In a partial carbon dioxide rebreathing, what they are using the indirect formula or indirect fixed equation on which we are calculating the cardiac output. Fixed equation, everyone is knowing about that. The cardiac output, here the consumption of CO2 divided by your venous content of carbon dioxide minus arterial content of the carbon dioxide, and accordingly this machine particularly we are using the intubated on a patient on a mechanical ventilator. This is the connector, this is the flow rebreathing valve, this is the loop, and this is the flow sensor, and this flow sensor analyze the what kind of cardiac output patient is having. So advantage, entirely non-invasive, but we are limitation, we are using the intubated patients. Now again come to the pulse contour analysis. I already explained the theory of the pulse contour analysis in my initial slide about according to the that we talk about transpulmonary thermodilution. They are using the same kind of concept of the transpulmonary thermodilution, that the three technique. These are the machine and gadgets are available, and you must be aware about the name. So many time in your DM entrance they will keep this picture and they will ask one or two questions, particularly those are preparing for their DM entrance for critical care or DRNV entrance. This is the pulse contour analysis. According to that, they are the pressure time and they are area under curve from where they are calculating the cardiac output. So there are the three major system about the pulse contour analysis is about the very important LIDCO, PICO and FlowTrack. There are three different companies using different thing. In the LIDCO, people are using lithium as an indicator dilution for continuous monitoring of stroke volume. Bolus of lithium chloride is injected into the venous line and arterial concentration is measured by withdrawing blood across disposable lithium sensitive sensor containing an ionophore selectively permeable to lithium. Cardiac output is calculated based on the lithium dose area according to the concentrated time circulation. It requires calibration and every 8 hourly, and it will give you the parameters. Like another is the PICO system. PICO is again based on the transpulmonary thermodilation. Invasiveness, yes, because minimal invasive, we need the central venous line, we need the intra-arterial line, and most of the ICU patients are on those lines. Again, we are using a specialized intra-arterial line. Advantage, you can use in children, and we can get the with this PICO system, that is your global end diastolic volume, and we are also getting the lung water. Another parameters we are getting through this is SVV, PPV, and one more important is this SCVO2. With this SCVO2, what is the target of SCVO2? Oh, excellent. That was the EGDT. Dr. Saab telling about the EGDT. Hai na? In the EGDT, we are keeping this SCVO2 of 65 to 75. There are means and tools when you want to increase the SCV. If you are getting low SCVT during the case scenario, sir will discuss about how utilizing this SCVO2 is important, particularly in a sepsis patient, how we are targeting, when to use the vasopressor, when to use the, when you know entire data, then only will know when to use the vasopressor, when to use the inotrope, when to use the give the fluid, when to give the blood, and what are the time, how you are going to intervene. So these information if utilize. So this is your PICO system, Persian company ka. Just have a look of a picture. So again, I explained most of the thing in it. And another thing, LIDCO, PICO and FlowTrack. FlowTrack by the AdWord. EV1000 has this FlowTrack. The machine developed by the AdWord is this pulsion by the pico and another is the lead curve. So technique is used the same, and the arterial line and the Vizilio monitor is there, and accordingly this is the uncalibrated, and it is utilizing here is the now the Vizilio plus 4 generation is device available. They are calculating every 20 seconds. You are getting this cardiac output, and entire every 20 seconds you are getting the information. So fast this machine is. This is the flow track sensor, and what we are getting here, like your SVRI, SCVO2, stroke volume variation, and cardiac index. If the cardiac index is low, you are thinking that, oh, this is the low cardiac output state, we need to add the inotrope. If the cardiac index is high, okay, heart is fine, still we are not getting the BP, maybe this is time to give the fluid. If we are getting, how you are utilizing, please focus. Please focus. When you are getting the SVRI is low, so if the SVRI is low, you want to increase the SVRI, what you will do? Use the vasopressors, use the NORAD, vasopressin. If you are getting your cardiac index is low, so you have to use your milrinone, dobutamine, dopamine, whatever you want to use, adrenaline. So this information you will utilize. That you cannot get it with your clinical sense, what exactly happening to the patient. So that's why this workshop is very important to understand your patient, to precise your treatment. The same way is the FlowTrax Vizilio system is there. There are the certain recent advances. I am just enumerating because otherwise it's going to take a long 20 minutes. So I am just trying to finish it off. These are the arterial valve pulse waveform analysis that we are saying APW. So this is one arterial pulse waveform analysis. The corrective, factors they are using impedance, arterial compliance, and also using the systemic vascular resistance. So two type of APW, calibrated like Pico Plus, PICCO2, EV1000, and LIDCO Plus, and uncalibrated like FlowTrack, LIDCO Rapid, ProAccurate, Most Care, PRAM, and Clear Sight system. Clear Sight system is based on the volume clamp. I'll come to later on. So EV1000 is about the machine. This is the machine where you'll get this kind of information on a. This is on a machines. You'll get it. There's a LIDCO Plus. I'm just enumerating the name. Don't go with the detail of this. But you must be aware about the name, about the curve, what we are getting. So this is our different type of waveform. Already sir has explained all these things, what we are going. The another name is the ProAccurate. This again recent advances where we are getting this pulse contour analysis with proprietary algorithm without calibration. Can be calibrated with echocardiography and TPTD. Definitely. Is it? One is name is the PRAM and Most Care. Doctor saying about that the AIMS they have this PRAM. Another is volume clamping. In a volume clamping, we are using clear sight system. In a clear sight system, you see there is the cuff here, and there is the finger. They are generating the pulse according to the generation of that pulse. Is analyzing about the, because it's a minimal invasive, non-invasive. Here you don't need any kind of arterial line or CBP line or any kind of catheter, and this machine like analyze your cardiac output. So measurement of continuous finger BP by the photoelectric, photoplethysmography, and volume clamp method. Transformation of the finger BP curve into the brachial artery waveform, and calculation of the stroke volume and cardiac output from the brachial artery pressure pulse contour using a physiological 3-element nonlinear Winskell's model of the arterial input impedance. Forget about what these are all the model, but you understand there is a clear sight system is there. So again, esophagus, esophageal Doppler, thoracic Doppler. If you put on a carotid, we'll get the carotid Doppler. You can also calculate the VTI index from here, easy way. So many times you are unable to do the echocardiography, put on your carotid, and you can easily assess the cardiac output or volume responsiveness of a patient, whether you want to give the volume or not. Like this is the we are putting in a cross-sectional, and there is a longitudinal. Get the this carotid artery, and accordingly you can calculate the VTI index here. We know the in the carotid artery, only 10% of the cardiac output is going. If you multiply by 10, you will get the cardiac output. From the descending thoracic aorta, 70%. Here we are cardiac output is going 10 to 15%. So accordingly, we'll get the cardiac output. Machine will calibrate and give you the cardiac output. They can measure the cardiac output. Now another is the ultrasonic cardiac output monitor. I already say physical Doppler explain. Another bioimpedance, already we discussed about the bioimpedance, and this is ECOM, another machine. The ECOM is the impedance plethysmography will get, and it will also provide the cardiac output, cardiac index, stroke volume variation, and SVR. The ECOM is there. They are using the, this is the endotracheal tube, and we can analyze the things. Bioreactance in another way, in the bioimpedance electrical impulse. Similarly, in a bioreactance, they are using the AC impulse, AC wave of electrical impulse, and this is called bioreactance. These are the names, certain NICOM, like cheetah starting, success of cheetah is NICOM. This is a bioreactance. Just don't know the name. If you go to some higher center and people are saying, oh, we have the flow track, we have the LIDCO, we have the PICO, हमारे पास NICOM है, this is nothing new for you. At least you are aware about this is NICOM, this is cheetah, you are aware of all these things, name. So we'll get again there. And last slide is a smartphone based. This is the Castasia, the smart hemodynamic monitors. This is just a gadget, though those intra-arterial pulse are going, you captured it, your smartphone have the AI based that will analyze and give you the cardiac output and about the other cardiac output, CI or SVB, SBR. This is again interesting tool. Thank you. Thank you for your patience. Hopefully you will enjoy your hands-on. Any question? Thank you. So just you have to learn about and what happening in the world. This kind of workshop is not that key. Whatever you are learning today is going to apply tomorrow. Whatever these gadgets maybe you will face after 2-3 years next whenever you are going to your during your DM or during your senior residency at various places, you will see these things. But at least awareness is very important. Today, you know about all these gadgets are very important. At least you know about the Frank-Starling curve. This is PPV is there, SPV is there. How we are going to precise my treatment and all. So that's why this house is full. Thank you. Thanks.
So next we will talk about the management of shock. How you manage the shock unless you know which type of shock it is. Classification is very important. I will take 10-15 minutes because we are running short of time. So I will try to finish it fast. कहाँ लगा रही है ना मैं बोल देता हूँ फटाफट सेकंड से स्टार्ट होता है नाम बताओ सेकंड से हाँ बोलेगा कि बोल रहा है करंट स्लाइड कर दो वो कहाँ है वो So unless until you know which type of shock it is, because there are various type of shocks and they are being managed differently. This is a case study. 72-year-old man with difficulty breathing with productive cough. Patient is febrile, 38.8 degrees centigrade. Heart rate is 130% tachycardic. Patient is tachypneic with 26 breaths per minute. Blood pressure 112/40. Oxygen saturation of 84%. Receiving oxygen 2 liters per minute via nasal cannula. Total urine output is 10 ml last 6 hours. So what is the problem you are seeing here? Anyone? Huh? Yeah, ठीक है oliguria. What is this? Needing oxygen requirement. Blood pressure is on lower side. Patient is tachycardic. Patient is tachypneic. Patient is febrile. Patient is in shock or not? Yes or no? Yes. Yes. What compensatory mechanism evident? Anyone? Yes, yes. Okay, fine. So we'll finish it fast. Syndrome of impaired oxygen delivery to the tissues at the tissue level, okay? Absolute relative decrease in oxygen delivery. Delivery is impaired. Ineffective tissue perfusion. Ineffective utilization of delivered oxygen. Okay? What other clinical laboratory findings would suggest the presence of shock? What you will do? What you will measure? Huh? Lactates, yeah, serial lactates, what else? So what you are seeing here, altered mental status, increased lactate, sometimes you'll finding transaminitis, then your decreased mixed venous oxygen, what he was talking about, in sepsis, you'll finding around 40, 50, and you try to increase the SBO2, means your patient is getting better, okay? And what he was talking about, the hemodynamic monitoring, everything is there, how much SBB will see, how much fluid to give, whether we give fluid or not, SBR it is showing, cardiac index it is showing, accordingly you will treat the patient, when to use the vasopressors, those things matters. If you have got working in tertiary setup and you have got if you have got those monitors, okay? Now, patient can have AKI, patient can have transaminitis with mottled skin, hypotension, everything. Same case study, a coffee Raji. What type of shock this patient likely have? Distributive, that is distributive shock. So classification of shock, cardiogenic, hypovolemic, distributive, obstructive. So ACS, mechanical, arrhythmic, this is cardiogenic, you all know. Then your hypovolemic, hemorrhagic, non-hemorrhagic, okay? Can, because of the vomiting, diarrhea, other things, patient can have so hemorrhagic shock, you all know, patient is bleeding. Septic, distributive, adrenal crisis also distributive, neurogenic and anaphylactic, you must remember. These are also distributive shock, obstructive, your embolism, your tension pneumothorax, tension pneumothorax, your tamponade, these all are obstructive shocks, and constrictive pericarditis too. These four things you should remember. So how you differentiate? Cardiac output decrease. In distributive, it may be normal or it is increased cardiac output because of the hyperdynamic solution, hyperdynamic state. Filling pressures are increased in cardiogenic, vascular resistance increase, SBO2, SCBO2 is decrease. In also SCBO2, SBO2 can be normal or increase, but it may decrease in case of your septic shock. Resistance SBR is decreased, filling pressures are decreased, but in cardiogenic filling pressures are increased, okay? Obstructive shock, filling pressures are increased, vascular resistance is increased, but SCBO2, SCB, this is decreased. So you should see this obstructive shock, obviously, then pulmonary embolism, patient shock, this cardiac output is decreased. Case study, same patient BP is now 88/40, heart rate of 150, respiratory of 32, SpO2 90% non-rebreather mass, lactate has gone up 4.2. The initial interventions are needed to treat shock in the patient. Obviously, start with the fluid, you will give fluid, but up to a limit, start your vasopressors early. Preload, fluid, inotropes I have already talked about. When you think that your systolic pressures are okay, you can start your dobutamine, that is the good one. Inotropic agents are going to increase the contractility, afterload, vasopressors or vasodilators, that will take care. Hemoglobin, if the HB is low, hemorrhagic shock, other things, then you will transfuse. In case of hemorrhagic shock, 1, 2, 3, 4, 3 and 4, if the patient is grade 3 or grade 4, that is being replaced with blood. Always 1 or 2, I don't have that much time. 1 or 2, no blood. 2, 3 and 4, replace blood with blood. Okay? Means one is your more than 30%, one is your around 35 to 40%, grade 4. So this hemoglobin saturations, you will supplement with oxygen. If needed, you have to ventilate the patient. Oxygen demand, if increase oxygen demand, patient is tachypneic, even if you are giving through your either HFNC or your NIV, whatever, patient is not meeting oxygen demand, ventilate, sedate, and give paralyze the patient. Treatment of shock, what the thing you are looking for, you have to restore the tissue perfusion and oxygenation, identify and treat a specific cause, because you should know why this patient is shocked. There could be so many. Anaphylactic shock, treatment is different. Your neurogenic shock, treatment is different. So you have to look for the monitor responses, whether your patient is, suppose the heart rate is high, you are giving fluid, you are giving blood, and it is coming down, means your patient is responding. Okay? So oxygen delivery, determinants are cardiac output, hemoglobin saturation, and SpO2. And interventions, what you will do, give fluid. If the patient is bleeding, give blood, or give oxygen, patient desaturating, and vasoactive agents you have to use, like your whatever the vasopressors you can use. The same patient, what intervention to decrease oxygen consumption, what intervention to increase oxygen. What we will do here? Huh? Yes, patient suppose antipyrete is heart rate is high, and you give fluid. That's why the oxygen consumption, if the map is cardiac output is good, you have to try to increase the cardiac output. What intervention will increase the oxygen delivery? If the hemoglobin is low, give blood. And what other things you can do? Give oxygen, but in any form, whatever form you can give. Fluid you will administer, yes, initially, either crystalloid or colloid. Initially crystalloid, if it is hemorrhagic shock, blood, 3 and grade 3 and grade 4. Don't give colloid initially in case of any type of shock. This is the dictum. How much fluid is needed? Recommend fluid boluses, assess response to each intervention, monitor endpoint services. We have talked about all these things, and need of the vasopressors at the earliest, blood transfusion, following the next into shock. What you will do? Which of the following the next intervention for shock? What you will do? Norepinephrine. Good. So we have talked about this. Vasoactive agents, we have talked in detail. Which agents are given a septic shock? You all know. Noradrenaline. Then this is your patient hypotensive. Initiate fluid boluses. Assess volume status. Hypovolemic. Give fluid. And if the patient you have not hypovolemic, start your vasopressors. Then adequate BP. Assess oxygen delivery. Titrate fluids and vasoactive agents. We have talked this lactates, serial lactates you have to do, SaVO2, SVO2 monitoring you have to do. What other interventions might be considered, and which can achieve control of infection, early use of antibiotics, and before giving antibiotics, you all know, you try to take out all the cultures you have to send, okay? And how would fluid and vasoactive agent you differ in other types of hypovolemic? Yes, you have to give cardiogenic, only right ventricular failure, right ventricular infarction, you have to give fluid. Not, you have to be very, very careful. Obstructive shock you can give, but try what are the causes. Suppose it is tension pneumothorax, put chest tube. If it is your pericardial tamponade, do pericardiocentesis. Even you give fluid, patient not going to improve. So try to treat the cause. Yes, what are the causes? Okay, so case study same. Creatinine has gone up, AKI is there, and blood burn is high. Urine output is 25 ml per hour. BP has come up 110/60. Normal saline solution 150 ml per hour you are giving. Norepinephrine is stopped after 24 hours. Should fluid infusion be increased to improve urine output renal function? Yes or no? What you will do? Again, what you will do? Already norepinephrine stopped, normal saline 150. More than that, see again you will assess the patient in toto, do the echo, check the IVC. First important, check the IVC, other things. If the patient is fluid responsive, and if you have got the hemodynamic monitoring, flow track, whatever. So I think so you cannot give more fluid here right now, or patient is AKI, still needing fluid, you have to do the first thing you do, check the IVC. Okay? And what intervention needed? Oliguria, serum creatinine, when you all know the definition, less than 0.5 ml per kg for 12 hours. Increase in creatinine more than 0, you know the criteria, more than 0.3 milligram or 1 to 1 times baseline. So you have to see those criteria. Prompt resuscitation, resolution of shock necessary to minimize severity. I told you, if the kidney goes into shock, the patient, you can lose your patient. So that's why you have to treat at the earliest, and you have to treat the cause. Why the sepsis is there, that can also cause the AKI, or there are so many tropical diseases like dengue and all other things, they directly attack the kidneys also. So you have to treat the cause, and you have to see how your patient is responding. Laboratory tests, your blood weight more than 20. This is acute tubular necrosis. Acute tubular necrosis is always reversible. Acute cortical necrosis is irreversible. Patient often go into CKD, remember. So urine specific creatinine more than prerenal. Prerenal causes can be treated, okay? And fractional excellence of sodium is less than 1, urine sodium less than 20. So it is treatable. Prerenal you can treat. and urinary catheter for monitoring, volume assessment management, furosemide challenge in fluid overload. Because see, furosemide can be double-edged sword. Only two conditions furosemide can be given. One is volume overload, and what other things you can give furosemide? Volume overload, pulmonary edema. Yeah, those things. Otherwise, you give the furosemide, it can also increase the creatinine. So double-edged sword. The volume overload is there. You can treat the patient. Challenge in fluid overload. Medication to nutritional formulas you can see, and you have to avoid the whatever antibiotics you are given. Check your antibiotics and the other drug. Avoid NSAIDs, other things. Don't give. And renal replacement therapy at the earliest. Any questions? So shock is syndrome of impaired oxygen delivery to tissues. Clinical manifestation shock results from inadequate tissue oxygenation and perfusion and compensatory response. And interventions to restore perfusion center on achieving adequate blood pressure. You have to always increase the cardiac output, optimizing the oxygen content of the blood. If the patient is bleeding, you have to give blood, and decreasing oxygen demand. Initial therapy, most form shock is replacement of intravascular volume with crystalloid. Always use crystalloid as first line, and if the blood is there, but don't use colloid as the first agent. This is the dictum, okay? So, thank you. हाँ ले खत्म कर दे उसको दूसरा कर दे रहा एक हमको कर लेने दो इको उसका लास्ट तुम कर हाँ अच्छा so वो सिनेरियो तो बुक में है उसमें two scenarios I am just showing up. One is obstructive, one is cardiogenic, and you people have to be you have to answer. उसमें नहीं है कहाँ लिए मैं कर दे रहा हूँ तो कोई बात नहीं बोल देते हैं आराम से. A 54-year-old man presented to the peripheral hospital with a 2-week history of dyspnea, leg swelling, abdominal bloating and fatigue. Okay? Over the next 1 to 2 hours, patient had progressive hypotension and drowsiness, requiring intubation and initiation of vasopressor support. He was subsequently transferred to our quaternary care cardiac intensive care unit. Okay? First patient was admitted to the peripheral hospital with a 2-week history of dyspnea, leg swelling and abdominal bloating and fatigue. Okay? Over the next 1 to 2 hours, the patient had progressive hypotension and drowsiness, requiring intubation and initiation of vasopressor support. Fine? On arrival, he was profoundly hemodynamically unstable. He required 3 vasopressors to maintain blood pressure of with a blood pressure of 75/58. He was bradycardic with a heart rate of 47 in sinus rhythm. On physical examination, he was sedated and ventilated. He was mottled with 3D peripheral pulses and cool extremities. His neck and face were markedly discolored, swollen with distended veins. His heart sounds were barely audible in precordial auscultation with no murmurs or extra heart sound heard. Lungs were clear to auscultation bilaterally. His abdomen was slightly distended but non-peritonitic. He had with no evidence of peritonitis. He had a Foley's catheter inserted but had not produced urine for several hours. He was hypoxemic with arterial PO2 of 75 despite ventilation with 100% inhaled fraction of oxygen. FiO2 100% and arterial PO2 75. Serum lactate of 21.2 with an arterial pH of 6.85 and a serum bicarbonate so with past medical history of he received a diagnosis of pericarditis during a visit to a peripheral emergency department and was started on colchicine and ibuprofen before. His past medical history otherwise significantly only for cigarette smoking with no previous home medications. Okay, he had no known allergies or illicit drug use. So what you are thinking about this case? Huh? What? See, blood pressure of 75/58 with requiring 3 vasopressors, mottled peripheral pulses, and patient had history of and no urine output. And patient had a history of colchicine and ibuprofen, both are nephrotoxic. Past medical history was otherwise significant only for cigarette smoking. Huh? And his diagnosis of pericarditis during a visit to a peripheral meningitis. So pericarditis was also there. Okay? So what could be the cause of pericarditis? Huh? Viral, see, myocarditis is mostly, in case of sepsis, myocardium is mostly involved. Okay? And when you see stress-induced cardiopathy or toxoplasmosis, sepsis is mainly all. Pericarditis could be other causes also. And he had a history of, that's why. So what you will do here in this case? This is basically obstructive shock. Huh? Hearts are muffled. Okay. Barely audible on pericardial auscultation. Okay, heart sound. His neck and face were markedly discolored, swollen and distended veins. Obstructive could be tamponade. Whatever you do, whatever antibiotic you give, your patient is not going to come out unless and until you immediately do the TTE, followed by either bedside your pericardiocentesis or take the patient to the cath lab. हाँ? फ्लोरोस्कोपी गाइडेड भी करते हैं ना? Either फ्लोरोस्कोपी करते हैं या कहीं कहीं bedside करते हैं. Don't take pericardiocentesis lightly. We have seen cases, all sort of complications. है ना? So ideally has to be done either bedside, ultrasound guided, or take the patient to the cath lab. Fine. So this is a case of obstructive shock, and patient is also developed AKI. AKI may be prerenal or maybe because of the use of the nephrotoxic agents. It's clear? Anything you want to ask here? Anybody has got hypotension, draws requiring intubation, ventilation? ठीक है? हाँ बताइए. Bradycardia could be because of the your cardiac tamponade, because contractility is gone. It hampers your contractility mostly. Bradycardia is a terminal, so that's why immediately you have to perform the pericardiocentesis. Fine? Because initially in sepsis we have tachycardic state, compensatory tachycardia होता है. देखा उस केस में ना, bradycardia नहीं मिलता है. Bradycardia may be because of use of some drugs, but he was using colchicine, you was having ibuprofen. So colchicine doesn't have any effect on his heart rate. Either beta blockers, other things you get. So clear? So this is also, then another case I am discussing. 51-year-old woman with a history of chronic kidney disease and hypertension was brought to community hospital with several days of intermittent chest pain and acute onset dyspnea. CKD patients, hypertriglyceridemia and MI is very common. Okay. Initial electrocardiogram demonstrated anterior Q waves and ST segment elevation due to evolving respiratory distress and repeated episodes of non-sustained ventricular tachycardia. Patient required endotracheal intubation. Okay, all of you are hearing now. You have to be interactive. मैं पूछूंगा आपसे, सबसे पूछूंगा मैं. ठीक है? So, due to evolving respiratory distress and repeated episodes of non-sustained ventricular tachycardia, the patient required endotracheal intubation. Emergent angiography revealed moderate left main and severe 3-vessel coronary artery disease, TVD, with an occluded left anterior descending artery. Left anterior descending artery was occluded. Due to hemodynamic instability, IABP was placed, and after an unsuccessful attempt at percutaneous revascularization LAD, because LAD was blocked, they attempted revascularization. Okay? And the patient was referred to tertiary center for further management. Is clear? Patient is having CKD. Patient was brought to the community hospital with several days of intermittent chest pain and acute onset dyspnea. Initial electrocardiogram say demonstrated anterior Q waves and ST figure 1. I can show you if it is there. Yes, you all can see ST segment elevation. I don't have, I forgot. Yes, that one. See? Huh? The patient had ST segment elevation. देखो है ना ST segment elevation? All of you. है? Huh? Yes? I could have done it there then. ठीक है. So, and you can see Q wave. Peak. So Q wave is also there. So what you can do, what you will do, then they have attempted angiography, LED LED was blocked and critical. Then patient was taken to the tertiary center for further including surgery, CABG, surgical ventricular assisted device, implantation or cardiac transplantation. Two-dimensional echocardiography prior to transfer showed ejection fraction of LVF of 15%. C arrived to the coronary care unit on multiple inotropes and vasopressors with ongoing hemodynamic instability. Because already LVF was low, so triple vasopressor support was started. C was assessed by both surgery and advanced heart failure transplant services. From a surgical point of view, C was deemed very high risk for surgical revascularization. Okay? Given her overall clinical status and questionable vitality within the anterior wall. She was also deemed not an ideal transplant candidate given her current clinical status, her history of chronic kidney disease and unclear compliance history. Now you tell me, which of the following statement is correct regarding the best management option? Continue medical therapy and pursue a viability before proceeding with the revascularization? Yes or no? Then continue medical therapy, exchange IABP for an Impella CP, left ventricular assisted device and pursue complete revascularization. What could be the answer? Then pursue revascularization of the right coronary artery and the left circumflex artery only with hemodynamic support because of the LED occlusion is likely chronic. Then proceed with durable surgical LV assisted device implantation because the left ventricle is unlikely to recover. No. Pursue complete percutaneous revascularization including the LED with the IVP support. What are you thinking? Who said B? Great. क्या नाम आपका? Great. Give a clap for him. Great. So basically, the patient presented with cardiogenic shock is clear. CKD patient and severe LV dysfunction, 15% of ejection fraction due to triple vessel disease. Despite aggressive medical therapy and IBP support, the patient is still demonstrating hemodynamic instability and in-organ hyperperfusion. Mortality is still shock in the setting of ischemia is 50 to 60%. This is despite significant advances in percutaneous therapies, development of sophisticated care delivery pathways to minimize ischemic time, and advanced pharmacotherapy. Based on the results of shock, should be immediately revascularized occluded coronary for cardiogenic shock trial. Early revascularization offers the most promising result in terms of improving short and long-term mortality. Based on, so what you will do? Continue medical therapy, exchange IBP for an Impella and left ventricular assisted device and pursue complete revascularization. Okay? And based on these findings, clinical practice has been to attempt to achieve CR in hemodynamically unstable patient presenting with acute myocardial infarction. Assessment of myocardial viability is not unreasonable in a hemodynamic stable patient. However, given this patient's tenous clinical status, delaying revascularization is not likely to be significant benefit. You have to go for the revascularization. Second important point to take away from this case is the importance of hemodynamic support. The 2011 ACCF AHA SCI guideline for percutaneous coronary intervention and the 2013 ACCF AHA guideline for the management ST elevation myocardial infarction recommend the use of percutaneous hemodynamic support in patients with ST elevation. Okay. Second most important point to take away from this case is importance of hemodynamic support. Okay. So this is the things what you will do. Okay. Now, moreover, the recent 2015 SCAI, ACC, HFSA, STS clinical expert consensus a statement on the use of percutaneous mechanical circulatory support devices in cardiovascular care endorses the use of percutaneous hemodynamic support during the high risk percutaneous coronary intervention. When you are doing the PCI, IBP kar denge, especially in those with severe LV dysfunction as the patient in this case. Okay? Although both IBP Impella are accessible systems of hemodynamic support, Impella बहुत महंगा होता है, लाखों में आता है. IBP cheaper. Okay? The use of more aggressive support with an Impella or tandem heart or even extracorporeal ECMO on the center's experience and the patient's clinical is now recommended over IBP for high risk PCI, especially patients with LV dysfunction. The clinical efficacy Impella 2.5 was demonstrated in the PROTECT 2 trial of hemodynamic support with Impella 2.5 versus IBP in patients undergoing high risk PCI study, and this device has been recently approved for the use in patients with cardiogenic shock. The PROTECT 2 study randomized patients deemed inoperable severe CAD and severe LV dysfunction prior to PCI and followed them up for up to 90 days post PCI. The study demonstrated that the Impella was associated with improved clinical outcomes. ठीक है, Impella महंगा है बट क्लिनिकल आउट बहुत महंगा है. Impella का जो डिवाइस बोलते हैं इतना महंगा है कि कितना बताया उन्होंने 15-20 lakhs. Impella बहुत महंगा है. ज़्यादा ही बता रहे थे, क्या तो बता रहे थे कि वहाँ से यहाँ आ जाएंगे. तो Impella इज ठीक है. ये समझ में आया ना कि 2 cases we have discussed. One is your obstructive shock, treat the cause. One you have cardiogenic shock. ठीक है. Now इकमो ही बोल देते हैं एक बार. कर फिर तुम कर लेना लास्ट. All of you know how to set up the put the arterial line कैसे connect करते हैं वो पता है आपको? CP line कैसे connect करते हैं? हाँ? एक बार दिखा देंगे. एक बार ना थोड़ा सा एक बार दो भी जल्दी डिस्कस कर लेते हैं. ये इंटरनेट नहीं आ रहा है? हाँ कर लेते, बनाए हुए ना स्लाइड, थोड़ा बता देना जरूरी है. एक और डिस्कस कर लेते हैं. ये क्या हो गया? इंटरनेट नहीं आ रहा है क्या? देखिए तो थोड़ा जानिए, उतना डिटेल में थोड़ी करेंगे. क्या हुआ? तो लो तुम करो 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 लो ये एक बार वो बता दो. सुनो ना कैसे आर्टिकल लेना वो सेटअप जो कैसे करते हैं. तो लास्ट ज़्यादा जरूरी है ना. तुम करो कितना टाइम लगेगा तुम्हें?
आ गया. So we are moving to the very important topic. So most of the time we are monitoring these things in the ICU. When we are receiving the patient with a septic shock or in the patient going in the shock, okay, or in the critically ill patient. So you will see the ABG and you will assess the patient with other parameters also. So while you are seeing the ABG, you will see the PaCO2, you will see the various other parameters, PaO2, lactate, HB, bicarbonate. So these all parameters need to be evaluation. So how to use these parameters while evaluating the patient? So we are going to see. We also assess the microcirculation. How will you assess the microcirculation in a patient? How will you assess the microcirculation? CRT. Okay. So we also will see the CRT and its importance in the critical care. So first we will go into the CRT. Okay, capillary refill time. Okay. So what is capillary refill time? Anybody? What does this show? क्या होता है capillary refill time? So ये assess in the. Tell me. You are compressing the periphery vessels, and with what you are assessing is the perfusion. So you compress it, you blanch it for the few seconds, then you release the pressure, and whether you are seeing whether it is the perfusion is the refilling is in a proper time or not. If it is not proper time, then the perfusion is delayed. Okay. So this is very important in critical care. Almost now it has come back to the critical care. We can assess the patient, we can resuscitate the patient with the capillary refill time. It is very important. So it measures the peripheral perfusion that help can assess a patient blood volume and shock etiology. So these can be used in the remote setting or rural setting where you can resuscitate the patient. Even studies have suggested that this performance is equivalent to the even lactate. Okay, na? We are assessing with the lactate. So newborn CRT can be of little 2 seconds. Infant children usually less than 2 seconds. Adult CRT is usually less than 3.5 seconds. And older adults it is 4.5 seconds. So you must know how much is the CRT. Okay? 3.5 seconds. So these are the values you must remember. So the problem with the capillary refill time is that most of the patients in Indian scenario, there may be dancing will not be seen. So you have that assessment is problematic. So the use of CRT in such population becomes difficult oftentimes. So where you look for, you assess with the hand, apply pressure to the hand for the 10 seconds, and then you see the capillary fill time. So these are the values we already discussed. In older adult, it is in 4.5 seconds because we will be dealing with the adolescent and the adult. So if it is less than the 3.5 seconds, so the CRT is delayed. If the more than the 3.5 seconds, the CRT is delayed. So this suggests that the patient may be in the shock. So this is the capillary fill time assessment on the mortality, and one study was done. So the capillary fill time was assessed on 7 days of the mortality, and it was found that the capillary fill time was a good predictor for the 7-day mortality. So factors affecting the capillary fill time: environment. Environment, if the temperature is very cold or if the temperature is very hot, so it can affect the CRT. So if you are examining the patient, you have to take consideration of the patient, whether the patient is very cold or not. So you have to warm the patient, then you assess the capillary fill time. Skin temperature, quality of technique, how you are blanching it, and place of the pressure, where you are applying the adequate pressure or not. And light of the room also. If the appropriate light is not there, so it will affect the CRT assessment. So regarding the CRT, whether it has proven a benefit in the critical care setting also. So recently, over 2019, a study was done, and this was very remarkable trial in the critical care, and this was the Andromeda shock randomized control trial. And this trial suggested, what is this trial suggested? This was this study trial suggested that targeting peripheral perfusion stressors versus serum lactate. So just I was telling ki it was compared with the CRT was compared with the assessment with lactate. And what was the study suggested? The question was that does the use of resuscitation strategy targeting the normalization of capillary refill time compared with the strategy targeting serum lactate level reduces the mortality among the patient with the septicemia. So there was RCT was done in the lactate assessment and CRT assessment. So CRT was assessed every half an hour for 6 hours, and the lactate was assessed every 2 hourly for 6 hours. And the group were compared. So results were there. So the result that there was significantly less organ dysfunction at 72 hours after randomization in the peripheral perfusion group. Okay, and there was no significant difference between the group in both the group. Okay. So the overall outcome suggested that the CRT group performed almost equal to the lactate. Now coming to the other study, effect of capillary refill time versus lactate targeted fluid resuscitation or regional microcirculation and hypoxia related perfusion parameter in septic patient randomized control trial. So these were another study done by the Gastro Ricardo, and the what was that? Key capillary refill time and lactate, there was 2 groups, and there was a targeted fluid resuscitation was done. So CRT targeted fluid resuscitation was not superior to lactate targeted fluid resuscitation or administration in both the, but it was almost comparable, not superior. CRT was not superior to the lactate. So in the peripheral remote setting, you can use CRT to resuscitate the patient if you have no monitors to assess the patient. So these are very useful parameters. So it is again come back to the critical care. So this was the same study. See the CRT targeted group and the lactate targeted group. So the P was 0.18 at 2 hours, 6 hours, and 24 hours. So it was 2 hours. It was significant between the two groups, CRT targeted group and lactate targeted group. But otherwise, in both the group, it was comparable. CRT assessment and pulse oximetry. This is the device. And this is a new device which can assess. क्या हुआ? So the quantitative CRT assessment. This is a device developed which can assess this continuous assessment of CRT assessment can be done by the, if you are connecting like it is a pulse oximeter like device which you connect to the patient and it will continuously assess the CRT while you resuscitating the patient. So this device has been developed now. Now coming to the lactate. So one of the very important parameters which is used to monitor the resuscitation in the ICU. Whenever you are doing ABG, you often see even surviving sepsis guidelines suggest you should get, while you resuscitate the patient, you obtain ABG and then you see the lactate. So what is the normal value of lactate? Less than 2. So normal lactate value is 0.5 to 1 millimole liter. And if it is more than, it is less than 2, it is considered normal. If it is more than 2, it is considered abnormal. So something is, what happens why lactate is produced? So it is related to the oxygen delivery and the oxygen demand. Okay. So basically we will not go in the details of these things. So when oxygen delivery is not happening, okay, that can be there, or oxygen demand is high. Okay. So that can be the oxygen demand. Oxygen क्या होगा? Arterial oxygen content and cardiac output. Okay. And arterial oxygen content depend upon the hemoglobin, oxygen saturation, partial pressure of the oxygen, heart rate, and the cardiac output depend upon the heart rate and stroke volume. So these are the oxygen deliveries. So whenever there is the oxygen delivery is hampered, okay, and the oxygen demand is also high during high metabolic state or septic state when there is tachycardia. So these lead to the anaerobic metabolism. So whenever it goes through anaerobic metabolism, so there will be the production of the lactate, and these lactate will adapt to the, will produce in the body, and he also go into the metabolism where the, and if it is not, because where lactate is metabolized, lactate will produce through the anaerobic metabolism, where lactate is metabolized, liver. Okay, so that is the part. So in what happens if the anaerobic metabolism is increased, so more amount of lactate will be produced, and at a certain point of time, lactate will enable to metabolize by the liver, and that lactate will get accumulated, and that will be reflected in the ABG or ABG. So these are the all assessing oxygen delivery. We are not going to the details of this oxygen. So what is lactate? It is a byproduct of anaerobic metabolism. Okay. So where is lactate produced? Mostly in the muscle, RBC, etc. Okay. And this is the pathway. You can read in the books and you go through the pathway. This is the pyruvate plus NDH and lactate plus NADH plus NH. So these are the primary site produced in the muscle and RBC, and these go under the production in the muscle and RBC, and finally it absorbs. How it absorbs? What is the cycle name? Cori cycle. So Cori cycle, through Cori cycle, the lactate will reabsorb, be utilized by the body, and it will again convert into the pathway. But at certain point of line, the level of the pyruvate lactate is more, then it will unable to utilize the body. So daily production is 1400 millimole per day, and serum level is less than 2 millimole. And if it mobilizes mostly in the liver and less in the kidney. Okay. So it will be mobilized in the both of the part. And what happens the sepsis? Sepsis also, liver is also impaired. If the hemorrhagic shock is there, so liver is impaired, and the production, if patient has got more production of the anaerobic, so liver is unable to metabolize the excess lactate. So that's why the lactate is deposited. So these all are about the anaerobic glycolysis. Causes of lactate elevation, it is divided into two groups, type A and type B. Hypoxic, failure of circulatory system. So in this there is increased oxygen demand. Increased oxygen demand कब होगा? There is, if you are heavy exercise you are doing, ठीक ना, seizures, who have high grade fever हो गया. So these are the high failure of the circulatory response, increase oxygen demand, decrease oxygen availability. Okay, decrease oxygen availability means there may be cardiac output is decreased. Okay, there is decrease in tissue perfusion. So the condition will be like shock also there, then cardiac heart failure, hypovolemia, there is diarrhea, left ventricular failure, low cardiac output state. These are the causes. And type B, non-hypoxic. So type B non-hypoxic means diabetes, decay also the lactate is elevated, liver failure. These are the all type 2 drugs and toxins. So which drugs causes the lactate increase in the lactate? Metformin. Any other drug you are using in the ICU which is causing increase in the lactate? Beta agonist. Okay, so norepinephrine also causes. You are using norepinephrine, and the norepinephrine also causes increase in the lactate level. So whether you will use norepinephrine or not. Shock patient में आया and norepinephrine also causes increase in the lactate. So will use norepinephrine or not? Definitely we will use it. Okay, you have to maintain the, you have to decrease the anaerobic metabolism. So ultimately you have to increase the blood pressure. Okay. And other the mitochondrial disorders also. Okay, these are the sepsis and septic shock. How these are the pathway how lactate is produced. Okay, lactic acid in sepsis. So coming to the Cori cycle already explained. Lactate is a beneficiary compensating mechanism. So how do we use lactate clinically? कैसे use करें clinically? ठीक है. So first, what lactate will tell you? Lactate अगर बढ़ा हुआ है patient का, you are seeing it is, let's say you have done the ABG and lactate was 5. What does this suggest? So this suggests that there may be anaerobic metabolism that may be due to any of the cause. Let's say patient has come with the hemorrhagic shock. The shock has persisted. Okay, the patient has gone into shock. They remain for the shock. So that the reason is the hemorrhagic shock in that case, and the lactate is increased. So now coming to the occult shock, maybe sometimes you're seeing the patient, you have come with the come in the ED area and you're not visible. Pulse pressure is fine, BP is fine, tachycardia is not much there, 100 and around, and you are not office physical features are not there. But when you are doing the ABG, you find that there is lactate is raised. So what happens in the sepsis? There may be weak catecholamine response, okay, and hypotensive. Okay, so in that case also lactate will be raised, and strong catecholamine response, elevated lactate, but no shock. So there are two types of response you can see. There may be weak catecholamine response, hypotension is manifested, but there may be strong catecholamine response. Body releases catecholamine to fight against any shock event. Any shock, any event which is occurring, body releases lot of catecholamine. So according to that, there may be elevated lactate level. So these are the studies: severe hyperlactemia in unselected surgical patient, respiratory as a prognostic outcome factor. So lactate are often, hyperlactemia suggests that it is a poor prognosis for the patient outcomes. So prognostic marker, it is used as a prognostic marker. Okay. Trending lactates. Now coming to the what that lactate level shows. Let's say you are receive the patient 10, there was a 10 level of lactate, okay, 10 millimole per. And then you again resuscitate the patient, still lactate was 14, it is not improved. So what does this suggest? So this was the study which systemic review which suggested that the observation of better outcome associated with the decreasing blood lactate concentration was consistent throughout the clinical studies and was not limited to the septic patient. So this suggested that if a lactate is improving, decreasing, so it suggests a better outcome. If lactate is increasing, it suggests a poor outcome. मतलब अगर lactate 10 आया, 14 आया and 18 आएगा, तो it suggests the outcome is going to be the poor. So this is the how. So there is a lot of study lactate guided research saves lives. No. So these are the source of the lactate production. Lactate is produced in all the the 10 pitfalls of lactate cleanse and sepsis. So seeking to lower lactate levels by whatever means given in the multiple events that regulates the blood has no credibility and low logic in terms of hemodynamic barrier to tissue response. So idea of seeking to lower lactate by increasing clearance in sepsis is both an illusion and folly. This doesn't. So that is not good. So that's why we check for the fluid responsiveness. So many of the people do कि नहीं lactate है, we resuscitate, we give lot of fluid. अभी 1 liter दे दिया, 2 liter फिर दे दिया. So it's not a point of lactate will take time to clear. It's not like that कि आपने अभी fluid दिया 1 liter and lactate will get clear. But because lactate will go ultimately the metabolism through the liver. So should we use ringer lactate? Anybody? मान लो सेप्टिक में सेप्सिस में आया पेशेंट 10 लैक्टेट है तो we are not going to use linger lactate. No, we will use ringer lactate. Okay. Sodium lactate in the क्या कहते हैं ringer lactate is very less. Okay. So that is going to contribute a very in a small quantity. So the fluid for resuscitation is crystalloid and that is plasma-lite solution. So you always use a crystalloid, not use the normal saline because it will cause unnecessary other complications. That is hypochloremic metabolic acidosis. Okay. So it is always to recommended is lactate. Use RL. So what about TK? So what about epinephrine? This is the same study. To summarize, lactate monitoring in critical illness, simply and widely available test, inexpensive, high levels associated with the poor prognosis, a minimal effect with deranged renal function, should be used to assess resuscitation endpoint in combination with other measures of perfusion. So now coming to the central venous oxygen saturation. So this is also very important. So while you are monitoring the patient in the ICU, you also take the central venous oxygen saturation. So central venous oxygen saturation reflecting which reflecting saturation of which part? SCVO2. So you see from the superior vena cava, so where you get from the sample? So you take the sample from the CVP that reflects the central venous oxygen saturation. So what about the SVO2? Where we will get the SVO2? Pulmonary artery. So we will get the SVO2 from the pulmonary artery. So normally SCVO2 will be higher than the SVO2 or lower than the SVO2? SCVO2. SCVO2 will be lower than the SVO2. Why? This is the mix. It is the latter part of the body. SVO2 SCVO2 you are collecting at the right atrium, okay, and SVO2 you are collecting at the pulmonary artery level. And here the oxygen extraction is more. The blood flow is coming from the upper part of the body where the oxygen is more utilized. So the oxygen dissolved oxygen in the blood is less in the SCVO2. Okay, the SCVO2 value is less. So this is very important to note down. So these are all values. So this is the mixed venous oxygen saturation and this central venous oxygen saturation. So blood drawn from the pulmonary artery and superior vena cava, venous clinical picture, average venous oxygenation, and these are the disadvantages. So what is the relation between SCVO2 and SVO2? Nowadays this parameter is not used. Okay. Moreover, the difference is very minimal. So indirectly because nowadays pulmonary artery catheter is not put, so it is better to monitor SCVO2 in place of the SVO2 to monitor the saturation. SCVO2 is less than 2 to 3% in physiological condition. But what will happen in the condition of sepsis or shock? क्या होगा? Sepsis में क्या होगा? SCVO2 is less than the SVO2. But in what will happen in the case of shock? SVO2 will be less. That's why shock, because the SVO2 blood is also coming from the lower part of the body where the oxygen extraction is more. Okay. So in shock, perfusion to brain is just splanchnic and renal perfusion is compromised. Okay. So SVO2 is greater than the SVO2 during the state of the shock. So and poor correlation between the two state in the two in a state of shock. So these are the no agreement of mixed venous and central venous saturation in sepsis independent. So they in sepsis there is matlab ki no there it is very independent. Okay, it varies. Clinical interpretation. So how do you interpret SvO2 and SvO2? SvO2 is reduced in SvO2 SvO2. It is reduced when the oxygen demand is increased. Pain, shivering, agitation, hypothermia. Okay, and SvO2 is increased in the if it is we are giving the decrease in the oxygen demand. How the oxygen demand will decrease? Either giving the sedation. ऑक्सीजन डिमांड कब होगा? मान लो कि यू आर गिविंग सेडेशन देखो पेशेंट को, एनेस्थेसिया में है पेशेंट, एनाल्जेसिया एंड रेस्पिरेटरी सपोर्ट. ओके, दिस इज द हाउ यू विल डिक्रीज इन द ऑक्सीजन डिमांड. ओके, so these are all the lactate based evidence of lactate based resuscitation trial. There was a reverse trial. So this reverse trial was done regarding the early goal directed therapy and targeted map of 65 targeting SCVO2 of greater than 61, HV of 80, and fluid aggressively was given. So mortality 50% low in patient with the early goal directed therapy than the usual care. It was found that if we monitor these parameters, so this suggests that a map of 65 and SCVO2 of greater than 70%, and we give blood transfusion early and also give fluid aggressively. So this suggested that the mortality will be decreased in the 15% than the patient with the early goal directed therapy than the usual care. If you are providing a usual care to the patient and you are following this path by maintaining the SCVO of 70%, MAP of greater than 65%, and early goal directed therapy, early goal directed fluid therapy, though it will improve the mortality, decrease the mortality. So this supports the lactate resuscitation. Newer trials de-emphasize early goal-directed therapy. There was this process trial. This suggested that either going for the early goal-directed therapy also doesn't have any impact on the resuscitation. Means if you are giving a early goal-directed therapy and also the patient giving with a lactate transfusion, so it doesn't have any impact on that. Okay. So no difference in the mortality in any arm. So ARISE and the PROMISE trial. Compare early goal directed therapy with usual care and early goal directed therapy usual care. Patient is coming and you are giving the early goal directed fluid therapy. You have a targets कि हमको stroke volume इतना चाहिए, and you are giving the therapy, and you have a targets and giving the usual care जैसा आप normal fluid देते हो and or early fluid देते हो. So there was no difference by all the trials. Okay. So relationship between cardiac index and SvO2 was the same in this study. We are skipping this. So there are factors which affect the SvO2. SvO2 you can go through the chart and
PSO to get PSO to get all of you can do. See, this all you know. You don't have.
ये वाला भी कर दे क्या?
This will go into the back here, where we maintain the pressure here. Okay.
Fluid है.
This is transducer. You all know? हाँ? फिर वहाँ लगाएंगे उसमें.
This will connect to the monitor.
हाँ. This will connect to the monitor. Okay. This is patient in either arterial line or the CVP line. Is okay? Okay. Now what you have to do this. That flushing you have to maintain. हाँ? And ये हो गया हाँ patient. तो देखो जब भी zeroing करना होता है ना, ये zeroing करना होता है, this position should be there. Zeroing करना होता है this position. अगर आपको ये इंड कर लोगे, ये कौन सा इंड हो जाएगा? ये
ओपन टू जाएगा.
हाँ? ये अगर ऐसे करते हो, देखो zeroing करने के लिए almost this one. अगर आपको फ्लश करना है, इसको खींचना है, ठीक है? लेकिन अगर ये कर दिए तो ये किधर जा रहा है? This one, patient वाला, है ना? ठीक है, ये patient हो गया. इसको अपोजिट करो तो क्या होगा? हाँ? जीरोइंग करके यहाँ पे ये जीरोइंग इन है, यहाँ पे करके तभी आपको उसमें ये ऐसे करके तभी जीरो करना है.
You will connect to that monitor, na? Then you will rotate the knob, the three-way knob. You rotate the knob, and they will see the monitor. When you connected the monitor with this
Both RTL
connector,
and CP line.
it's
जैसे
the
कि
same.
आपको ओवर डैम्पिंग या अंडर डैम्पिंग मिल रहा हो, अब कितना डिस्कस किया हमने. तो ओवर डैम्पिंग में हमने क्या डिस्कस किया, यंग पॉपुलेशन में हमें अगर ज़्यादा मिल रहा है या फिर आपको लग रहा है कि उसमें क्या सिस्टोलिक ज़्यादा दिखा रहा है, उसमें क्या करना है, जीरोइंग करो, फिर से देखो कैसा आ रहा है. अंडर डैम्पिंग में एल्डरली पेशेंट्स में ये सब में अगर हो सकता है तो उसमें भी उसको फिर जीरोइंग करके फिर देखो, कई बार वेव फॉर्म सही नहीं आता है. जब तक आपका वेव फॉर्म सही नहीं आता है गलत हो सकते हो आप मॉनिटरिंग, समझ लो ना. अब देखो सिस्टोलिक पीक है, डायक्रोटिक नॉच है, फिर नीचे आया, सीपी लाइन का भी देखा, ए सी बी एक्स वाई जो भी देखना है आपको, तो वो सब देखने के लिए ये जीरोइंग करने का ये सबसे इंपॉर्टेंट है कि ये यहाँ होना चाहिए.
and it should be placed at the fourth intercostal space,
फ्लेवोस्टैटिक
flavostatic axis.
एक्सिस बोलते हैं उसको, है ना. तो वो
At the level of the right atrium, यहाँ पर place कर दो, और scale ले, you can use the scale to just level it around and see that.
ठीक है.
Approximately करना हो.
आर्टरियल लाइन में सीपी लाइन में सेम है, इस क्लियर. इसको रखना है ऊपर करके, इसमें से आपका फ्लूइड बैग में 300 प्रेशर रहेगा और उससे बैग से ट्रिकल करते रहेगा फ्लूइड.
If there is no fluid bag, you have to just क्या होता है कि आर्टरी लाइन ब्लॉकेज होने के चांसेस है, यू कैन इंटरमीडिएट 1 to 2 ml हाफ एन आवर 2 आवर में फ्लश करते रहो. मेनी ऑफ द जगह नहीं होते हैं बैग, तो यू कैन यूज दैट. और मेनी द टाइम वी आर आल्सो नॉट यूजिंग इंट्राऑपरेटिवली ड्यूरिंग दैट.
ठीक है. तो 300 का प्रेशर रखना है, ये करना है. जहां आपको वेव फॉर्म सही नहीं लगे, जीरोइंग करके इसको इसमें रख के जीरोइंग करके फिर से देखना है. अंडर डैम्पिंग, ओवर डैम्पिंग, एसीबी एक्स वाई जो देखा है. पीएसी नॉर्मली वी आर नॉट यूजिंग, इसलिए मैंने पीएसी वेव आपको नहीं बताया उतना, है ना. अच्छा पीएसी कैथेटर भी लाए तो खोल ही देते हैं, लो ना, क्या फायदा है ला. दिस इज पीएसी कैथेटर. ईटीयू किया हुआ है. नॉर्मली आजकल डालते हैं जो कार्डियक वाले सब है ना, रिजेक्शन फ्रैक्शन लो रहता है, वही डालते हैं. या स्टिल इज गोल्ड स्टैंडर्ड. आपने ये क्या समझा, गोल्ड स्टैंडर्ड है, लेकिन इसके अपने कॉम्प्लिकेशंस है. कई बार सही जगह नहीं पड़ा तो फिर मुश्किल हो जाएगा, दुनिया भर कॉम्प्लिकेशंस आएंगे. तो व्हेन वी हैव गॉट अदर सेफर मिनिमली इन्वेसिव ऑप्शंस, हम इसको क्यों ट्राई करेंगे.
अच्छे से तो रहने दे.
कितना ल्यूमेन है इसमें, 4 ल्यूमेन का भी आता है,
3 लुमेन से.
3 ल्यूमेन से है ना.
So इसमें basically one is the one there is distal opening, when the distal opening that goes into the pulmonary artery region, okay, and the other is the proximal opening, and जो proximal opening that is 30 centimeter from the distal opening, last opening, and that is in the remains in the right atrium, okay, and at the tip just 1-2 centimeter there is a balloon, so that you can transduce into the pulmonary artery. Whenever you are just going towards the pulmonary vein just near about, then you can do that.
3 ल्यूमेन 4 ल्यूमेन का भी आता है ना. एडवर्ड लाइफ साइंसेस का है. हाँ, तो इसलिए मैंने खोल लूँगी ईटीयू, उनको लौटाना तो पड़ेगा ही, तो फॉर योर सेक पर आपको दिखाने के लिए मैंने उठा लाया. तो पुराने आते कहते दिस इज द गोल्ड स्टैंडर्ड बिफोर इट वाज डन, एंड स्टिल आपको लगता है लोग डालते हैं.
It is placed in the pulmonary sheath आता है, then we place it like that.
Also looking after some time after post liver transplant cases, उसमें भी नहीं यूज करते हैं.
नहीं यूज करते, not using.
एक बार इको का देख लेते हैं वहाँ पे चल के. इको का ये कहाँ गया?
इको का कौन सा?
कोरोना टिकट इसको डाल देते हैं.
इको ही
चलते
बता.
देख लेते हैं. इको बताता हूँ. सबसे पहला ये हाउ टू मेजर द आईबीसी, है ना. और फिर एक बेसिक इको देख लीजिए, उतना कार्डियक आउटपुट पहले बेसिक जानिएगा तब ना कार्डियक आउटपुट है उसमें है. तो बेसिक मैं बता देता हूँ, ठीक है ना. जीरोइंग का समझ गया ना क्या करना है. दोनों सीपी आर्टरी लाइन सेम है. जीरोइंग करना है, अंडर डैम्पिंग पढ़ना है, ओवर डैम्पिंग पढ़ना है, और आपको जब भी लगे तो फ्लूइड रिस्पॉन्सिवनेस के लिए बहुत इंपॉर्टेंट है. ठीक है सर. एक बार इको दिखाओ, एकदम आराम से दिखाओ. बाकी हमने सब वो कर हाँ सर हाँ सर सर कब तक सर वहाँ पे चलेगा सर सुबह का कितने था सुबह चले जाएंगे तो
बच्चों को चल देना आराम से चल के
और आके बोले का एयरपोर्ट आ गया
हाँ हम इसको भिजवा देंगे हाँ तुम्हें करके तब आराम से इधर को थोड़ा सा
आप निकल दीजिएगा ना
हाँ हम
तो 1 घंटे लगा सुबह और कम टाइम लगेगा हाँ
आराम से सिखा के फिर होटल जाओ हाँ फिर हम लोग चलते हैं बात करके हाँ संजय तुमसे कोऑर्डिनेट करेगा
यस सर यहाँ का करके 15 स्लाइड है वो पहले दिखा लेते हैं
हाँ दिखाई दीजिए
इको का नहीं पहले दिखा लेते हैं
हाँ पहले
पहले वो डेमो को नहीं जा रहा
उसकी जरूरत है उसको हमको और कुछ सपोर्ट चाहिए
सब डन हो गया सामान भिजवा दिया मैंने
कोई दिक्कत नहीं ना
कोई दिक्कत नहीं सब आराम से हो गया हाँ सपोर्ट तो चाहिए सर
क्या बोले हाँ हाँ हम नहीं नोडल ऑफिसर है हाँ हमारा बिल्डिंग बन गया है उसका इंस्ट्रक्शन के लिए हमने नहीं भेज दिया है उसके बाद हाँ नोटल किया है हाँ कल सवेरे से वो किसी में डाल
नहीं नहीं ये तो
यहाँ की सब शादीशुदा है
सब जब जहाँ जहाँ जा रहा है तो हम लोग लेके जाते थे तो वही वही होता ही जो लोकल एरिया का जो चीज़ फेमस है वही देना ही
सब शादीशुदा है सब बचपन में ये खुद पढ़ने की हम लोग पढ़ने की
नहीं तो बहुत ही बहुत लोग लगता है चले नहीं, बहुत लोग फ्लूट रिस्पॉन्सिव है, सब नॉन रिस्पॉन्सिव होते जा रहा है, सुबह से क्लास चल रहा है तो अनरिस्पॉन्सिव होते जा रहा है. सो लास्ट not the least one assessment is or more. So have you heard about the PSU2 gap? So this is also used to assess the perfusion. Okay, in the sock you will assess the PSU2 gap. So what do you mean by the PSU2 gap? What do you mean by the PSU2 gap? That is the venous, the gap between the venous CO2 and the arterial CO2. The CO2 will be higher in the venous and the arterial CO2 will be less. So this gap will be assessing. So you are doing the AVG, okay, and you are obtaining PSO2 from central line. You can assess the PSO2. That's the venous. कई बार होता है कि arterial line peak नहीं हो तो हमने venous sampling करके PSO2 वो assess कर लेते हैं. We just see the lactate and other parameters, and then we can have a arterial line and we see the PCO2. So this gap if we calculate and if we this assess, this is called the PCO2 gap. So what will happen? अगर shock बढ़ जाता है तो क्या होगा? CO2 uptake होगा. Since the perfusion is decreased at the level of the tissue hypoxia is there, तो CO2 level क्या होगा? बढ़ जाएगा. So the CO2 level is increased at the tissue level and the hypoxia is there. This is one of the reason the anaerobic metabolism was CO2 level बढ़ गया. There can be exchange problem, obstructive problem, or there is the tissue damage. So there can be this. So there is two level. So that's the CO2 gap we are calculating. So this is the same definition. It is the difference between venous and formula used to calculate is this PSO2 gap, central venous PSO2, then with the arterial PSO2. Mostly we take the central venous PSO2 from the central line. If it is not available, then we can go for the peripheral veins, but mostly it is central venous. Purpose क्या है? Most of the purpose we are assessing the perfusion, whether the patient the perfusion or oxygenation is maintained or not. What happens in the shock? The perfusion and the oxygenation is hampered in the patient. So whatever what we are studying is to assess the perfusion and oxygenation and to maintain with this calculation we can maintain the perfusion and oxygen in the patient. So normal range क्या होता है? It is different. Mostly it is a 4 to 6 millimeter of mercury normal value. If it is less than 6 millimeter of mercury, it is normal. And what happens in the septic shock patient? It will be increased. So higher gap indicates impaired perfusion at the tissue level because venous blood is retaining more PSCO2. Maybe poor clearance of the CO2 at the tissue level or increased anaerobic metabolism. So CO2 production and clearance, CO2 is a byproduct of cellular metabolism produced in the tissue, transported to the lungs for the elimination. CO2 is eliminated to the lungs. If you remember the metabolism in the RBC, that H2, CO2 plus H2, it becomes bicarbonate. Okay, so that is the reflected in the AVG also. Under normal condition, tissue produces CO2 at a steady state, and this carbon dioxide is efficiently transported from the venous blood to the arterial blood. Okay. Venous blood to arterial blood within a minimal buildup in the venous system. But if this is hampered, if there is a shock, if there is a damage at the tissue level, if there is a mitochondrial injury, then there will be the CO2 absorption will be delayed and production will be also higher. So both of the reason will be there. So if you examine this scene, this is the veno-arterial CO2 gap and this is the cardiac output. What we are seeing is the high cardiac output state, the veno-arterial, the CO2, the veno-arterial gap is very less. Okay, so it is not indicative in if the patient has a high cardiac output state. So this delta CO2 gap will be of not importance. You are not able to assess. Let's say the patient is in a hypermetabolic state, let's say thyrotoxicosis like that, or a high grade fever is there. So then if you are assessing the PCO2 gap, it may be inappropriate. Similarly, if it is low cardiac output state, let the patient is in the impaired heart function. There is oxygen metabolism hampered, often featuring the shock stage. Combining with other parameters, always use these PSO2 gap along with other parameters like lactate. Okay, lactate will also assess the overall tissue oxygenation and perfusion stress. Elevated lactate with high PSO2 gap suggests that suggest more severe hyperperfusion than the lactate alone. If you are seeing that there is an elevated PCO2 level also, delta PCO2 is elevated, and there is also lactate is elevated, means this suggests that the patient is in the more shock state. So both of the parameters you are using, so both is suggesting the same thing. So it shows that the more of the in the shock state or hyperperfusion. Now coming association with the mixed venous saturation or SVO2 or SCVO2. Low SVO2 means low SVO2 का क्या होता है? The low SVO2 means the oxygen excretion is more in the splanchnic circulation. SVO2 so we are talking about the pulmonary artery where we get. And with elevated PSO2 means low SVO2 means the oxygen excretion is happening more in the splanchnic circulation or the other parts of the body, and also the elevated CO2 is there. It enforces the diagnosis of there is inadequate oxygen delivery, and that is leading to the anaerobic metabolism. Now coming to the SCVO2, low SCVO2 with high PSO2 gap indicates hypoperfusion. Okay, this is the hypoperfusion. So this is the chart which suggests, so this is the algorithm you can follow. This is mentioned in the books also. So you follow this chart, sign of circulatory shock and lactic acidosis. Lactic acidosis is there, shock was there, and lactic acidosis is there. Maybe lactate is more than 2. And then you measuring the saturation of the SCVO2 less than 70%. And if it is less than 70% and veno-arterial gap less than 6, greater than 6, ठीक है? SCVO2 is less than 70% and veno-arterial gap is greater than 6, means there is a low cardiac output rate and stagnant dysacia. But if it is less than 6 millimeter, means PCO2 gap is maintained. तो ये किस में होगा? एनीमिया, ठीक है ना? एनीमिया में तो कोई टिश्यू हाइपोक्सिया तो हो नहीं रहा है. Only thing is that the hemoglobin content is come, the oxygen content is come. See, so it is happening in the anemic dysoxia. Okay, and so SCVO2 greater than 7% and veno-arterial gap is greater than 6 millimeter mercury. So the SCVO2 is more than 70% and veno-arterial gap is more than 6 millimeter. This suggests that the SCVO2 is more. The SCVO2 is reflecting the upper part of the saturation, ठीक है, upper part of the body. क्योंकि वो supply का वो that is measuring the brain. Blood is running from the superior vena cava. You are measuring that. That is greater than 70%. So that is not reflecting the lower part of the body, and that is more. Boss. So greater than 6. So this suggests that it is hampered at the microcirculatory impairment is happening, at a tissue level in the peripheral lower part of the body, splanchnic circulation, or in a or stagnant dysoxia and inadapted cardiac output. Maybe cardiac output is not coming the cardiac output is not able to adapt to the demand. Okay, not compromised. It is not able to the demand is much more than the, and it is not able to cope up with the demand. And similarly, if it is SCVO2 is greater than 70% and gap is less than 6 millimeter mercury, okay, gap is more. This suggests that there may be cytopathic hypoxia, means there may be at a cytosol level, at a tissue, at a cell level, there may be hypoxia. So these are the findings. That is no, you can follow the chart to measure the perfusion. And then again, there is no sign of shock, normal lactate level and greater than 70%. So this is the way. Sometimes happens with the blood, there is blood loss happen in the OT. So you measure the lactate is also coming around, you are giving the blood and maintaining the perfusion, adding the NORAD, and the saturation is SCVO2 saturation greater than 70%. So and you have gone in, the patient is shifted to the PACU, okay, post-operative anesthesia care unit, and then you are seeing. So that time maybe that key less than 6 millimeter mercury, so the homeostasis is achieving. So these are the parameters. You follow the chart and you can manage the patient. So limitation, PCO2 gap is supportive parameter and should not be used in isolation. So it should be used along with the CRT, lactate, other parameter, or SCVO2. It is most useful when integrated with the clinical science, lactate and other hemodynamic data. Conditions like hypermetabolism and severe acidosis were just can influence CO2 and production and clearance, like thyrotoxicosis. Okay, so hypermetabolic state जो भी है, like certain hormone disorders. So in that hormone disorders, it will be impacted because the CO2 production are increased in such patients. And also the clearance is affected. So interpretation should be done accordingly the disease status of the patient. So key takeaway, PCO2 gap useful indicator for tissue perfusion, especially in shock. Guide, help assess response to interventions. Integrate along with the other tests, SCVO2, lactate and other clinical indicators. So that's over. So.
This is the last talk. Within 20 minutes I will finish. वो शेयर कर दो उन सबके साथ. हाँ सर, आप लोग का मोबाइल नंबर है नहीं, कैसे भेजा जाए? हाँ कोई ग्रुप में सर को ऐड करो, इनको सर को ऐड करो. हाँ भेजे तो है तुमको. ठीक है? So this is the last talk, and thank you all for your perseverance, your patience. At least some people are here right now. So echo, as discussed, is very, very important. है ना? It's a very good tool when you don't want to go do anything invasive, and it can give you a lot of information. You all know uses ultrasound, physics of ultrasound, to visualize the heart, blood vessels, and blood flow, providing a detailed picture of cardiac performance and hemodynamics. Transthoracic echo and TE, two things we do normally. ये भी काम कर रहा है. हाँ, okay. So T, when we do T, when we fail to, we have having some doubt what it is. For better magnification, we go for TE. TE has got its own limitations. Unless until the esophagus has some problem, some bleeding is there, or some pathology is there, or some narrowing is there, we cannot do otherwise. And for doing TE, normally the patient should be intubated. Can be done in spontaneously ventilated patients, but ideally, patient is on ventilator, then it is better. Okay? So there are some limitations, but still you are having doubt, you can go for the TE. This is the amount of blood that is being pumped by heart per minute, that is cardiac output, central measure of cardiac function. What components are the cardiac index, cardiac output adjusted by the body surface area, normally up to 2.3 something is normal. Cardiac output index provides a more accurate assessment of heart's ability to perfuse tissue, especially patients with extreme body. In fatty patients, preload and afterload, you know, preload is basically left in diastolic volume or the pressure. Afterload is the amount of resistance heart faces must overcome to eject the blood, that is SBR. So both preload and afterload are very important. SBR, measure of resistance of the heart faces when pumping blood in the arteries. So SBR normally in cases of sepsis goes down. Pulmonary vascular resistance, the same thing, resistance in the pulmonary circulation, and especially important in case of pulmonary hypertension. Stroke volume is VTI, velocity time integral into pi into left ventricular outflow tract diameter into 2/4 stroke volume. That volume ejected by the heart with each beat. This is important formula. Cardiac output, you know, stroke volume, this is calculated this way into the heart rate. Now, left ventricular diastolic volume, that is your preload, gives insight into the ventricular filling pressures, and elevated LVDP suggests increased. Basically, this is preload. Fine. Inferior vena cava and its collapsibility, we have discussed a lot. With patient with low central venous pressure, the IVC diameter will collapse during inspiration, means patient needs fluid. Okay? And collapsibility index always in case of when the patient is not on ventilator, spontaneously ventilated patients. This collapsibility can help assess the patient's fluid resistance, their ability to respond to fluids. Estimating afterload, aortic Doppler you can do, measuring the velocity of blood flow through the aortic valve using the Doppler ultrasound. You can estimate the aortic valve gradient and calculate SVR. Higher velocity of pressure gradient across the aortic wall suggests increase after load. Anything across the aortic wall is suggesting after load. So this is higher velocities increase through Doppler. You can measure your vascular resistance and your SVR. PAP again pulmonary is the same thing. Doppler measure tricuspid. This is around the aortic wall. This is around the tricuspid wall. Velocity, that is called pulmonary artery systolic pressure, and helps in assessing the right heart function, and you assess the PVR, pulmonary vascular pressure. BTI is very important. It's a key Doppler electroechocardiographic measurement that quantifies the distance blood travels through a given cycle. The distance the blood travels. This is crucial in estimating stroke volume, because we have seen the formula stroke volume and the cardiac output. So BTI is very important. TAPSE we do across the tricuspid wall. It tells about the when it's less than 14, it is patient is in right heart failure. Okay, and TAPSE evaluates the longitudinal motion of the right ventricle and can help identify right heart failure. Okay, and can be used to assess left and right ventricular function. When it is done across the mitral valve, it is MAPSE. Okay, and when done that is mitral annular plane systolic excursion. TAPSE is tricuspid annular plane systolic excursion. Less than 14 is, or less than 12 is suggestive of right heart failure. Okay. Pulmonary artery pressure and the right heart function, important one. In patients with suspected pulmonary hypertension, right heart failure, the estimation of pulmonary artery pressure is essential. Doppler ultrasound of the tricuspid regurgitation jet can provide an estimate of PAP. What is the tell? Doppler, you do it around the tricuspid wall, can tell you the pulmonary artery pressure, which is critical for assessing right ventricular load and function. That's why you might be seeing whenever the echographist they do, they also write about the pulmonary artery pressure. This much, okay, this is TAPSE value they write ventricular size, then also they write pulmonary artery pressure separately. So this is important for right heart function. So 7 basically normal, hypovolemic, primary diastolic failure, primary systolic failure, systolic and diastolic right ventricular failure. So for determining hemodynamic state, always estimate the left ventricular in diastolic volume, preload, estimate systolic function, estimates filling pressure, final assessment determining the primary dysfunction. LVDP, invasive monitoring, estimates EVD, EDV using PC, pulmonary capillary wedge pressure. As PCW increases, so does the EDV. अगर ये बढ़ेगा तो in diastolic volume बढ़ेगा. Does not take into account the compliance of the left ventricle. Echo can directly measure left ventricular volume. Several methods. Note that the preload refers to the volume of the left ventricle, not the filling pressure. So preload is basically volume of the left ventricle in diastolic pressure, not the filling pressures. Simpson's method we do. I cannot go in detail. Manual desystole for knowing the ejection fraction. Okay, summed up and the ventricular volume. Basically, for this is one of the methods for knowing the left ventricular ejection fraction. Preload, hypovolemic, normal and dilated. You can see normal is this more than 14 dilated. Ventricular volume M mode. If you put estimating RV volume, this is parasternal short axis view. Crescent separate normally it is and appears to wrap around the this is your wrap around the your circular LV. Here LV is there, is showing the parasternal short axis view. When RV becomes circular, it is dilated. Normally it is crescent separate. If it is dilated, that means and the septum causing LV to become disseparate. With volume overload, flattening occurs in diastole. The volume overload there is flattening but in diastole. With pressure overload, the septum remains flattened in systole. This is important step. Systole, if it is flattened, then pressure overload. If it is flattened during diastole, that is volume overload. Parasternal short axis view, right ventricular outflow tract. This is already showing right. This is outflow tract. Then and LA should all be roughly equal size. Normally, LA, RVOT should all be equal when the patient is normal. Parasternal short axis. Plaques, normal RV has oval shape. In parasternal long axis, as RV dilates, it becomes circular. Normally it has oval shape, but if it dilates, it becomes circular. This is a 4-chamber view. Normal is RV is lesser than your LV, 2/3 of the LV. But apex of the LV shorter than LV. If RV and LV equal means RV is dilated, moderately dilated. If RV is more than LV means severely dilated. Normally RV is 2/3 of the LV. It's all clear. Estimating RB volume, 4-chamber view, RB in diastolic, basal cavity diameter. So leave it all these things, cavity length, then outflow tract diameter. We have to go to subcostal. That I was showing subcostal view. Normal is less than 0.5 centimeter. RB hypertrophy suggestive of chronic pulmonary hypertension. Remember, RB hypertrophy is suggestive of chronic pulmonary hypertension. Estimate systolic function. Use estimates of ejection fraction. What you can do, ejection fraction shortening, you can then fractional area change, visual assessment. Normally we do visual assessment. So fractional shortening, what are the formulas? This is left ventricular end diastolic diameter minus left ventricular end systolic diameter. End diastolic diameter minus systolic diameter divided in left ventricular end diastolic diameter into 100. It gives you fractional shortening. Limitation does not reflect global air function if there are significant wall motion abnormalities, conditions that affect the motion of the interventive septum result in inaccurate value. Therefore, it is not an appropriate measuring system. So, you have limitations when the left ventral branch block is there, pacing is there, prior open heart surgery, RV overload is there. Values are reduced less than 28%, normal is 28 fraction shortening is 20, is more than 44% means your there is more increased. So fractional shortening you can use to estimate the ejection fraction. This is the formula. Okay. So estimate systolic function. This way you can do fractional area changes, parasternal short axis LV area, Simpson's that one that I showed you, biplane method, more accurate. And if fractional this one FSC, it is more than 60. Normally is 50. Normally what you find, ejection fraction between 50 to 65, but decrease is less than 50%. You can see all in this. So normal, this is decrease, this is increase more than 65. RV also. RV systolic function, I told you tricuspid annular plane systolic excursion should descend briskly, and if it is less than 12, that is suggestive of right ventricular failure. Okay. Generally reduce, and RV is normally shorter in size compared to LV. If it is more than LV, means severely dilated, what I talked about. LA pressures, shape and movement of the intra-atrial septum shows the best sensitivity and specificity for differentiating normal from high LAP. Leave all this in high LAP, leave all, is not that. Left atrial filling pressures are there, estimate of LA pressures, LAP, final assessment. Normal, you have to know all these things. Normal LVDP divide normal EF, normal LAP. So assessment, this one is important. Left ventricular volume normal, 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 is all systolic normal, left atrial filling pressure normal. Empty, this is all normal or LV systolic function increase. Because kissing sign is there when the empty, this will left ventricle, this is called kissing sign. Primary diastolic failure, LV volume is decreased, systolic failure it is increased. Diastolic failure, LV volume is decreased. LV systolic function normal, left atrial filling pressure is increased. Again, you systolic and you take this, snap it. This is a good one. Systolic and diastolic failure, LV volume is increased. LV systolic function is decreased. LV atrial pressures are increased. Vasodilatation, then the right ventricular failure. In case of right, LV volume is decreased, and left ventricular systolic function is also decreased, and increased left atrial filling pressures. Done? This is important one, huh? Limitations of echocardiography, operator dependence, it can vary from person to person. Yes or no? Somebody is writing ejection 20%, some 30%. So Simpson method is good, fractional shortening is good. Okay, eyeballing may not be, but it's operator dependent, is experienced one. It can be. Image quality is also important, obese or critically patient. And thank you. So it's all done. Huh? We have not left anything. You have also got that post-test papers. Try to solve it. Pre-test you have done. Thank you. have not left anything. Whatever we have come with, we have shown it to you. And the exact 5 o'clock we have finished. Despite we were late in the morning, also it's fine. और थोड़ा सा एक्सप्रेशन में नेक्स्ट टाइम हम कभी करो तो हो गया कुछ भी नहीं छोड़ दिया
यहीं से ऑफ है फोटो का
हाँ सर
आइए तुम लोग जाएगा कैसे आओगे कब आ जाएगा सूचना नहीं कैसे पे कौन है यहाँ का देख लो इधर करियो मैं तो काम करो ये लो हाँ इसको इसमें डालो इसमें लो हाँ ठीक है दे लो ये तीनों एनेस्थेसिया डिपार्टमेंट तक पहुंचा देना एक मिनट यहाँ पर लो लो ना थोड़ा सा यहाँ पर लो लो ना ये यहाँ तीनों कहाँ पहुँचाओगे एनेस्थेसिया डिपार्टमेंट एनेस्थेसिया डिपार्टमेंट है डिपार्टमेंट ठीक है